You need big numbers.
Richard Westcott, BBC Look East, Cambridge.
But first, take a look at this. Essentially, it's a small sponge on the end of a string, but this has saved the life of retired Cambridge scientist Liz Chipchase. She'd agreed to take part in a medical trial purely out of curiosity, and this cyto sponge, which is only available here, was the thing she was testing. Now, it's a quicker and cheaper way of spotting cancer of the esophagus. She's been sharing her story with our science correspondent Richard Westcott.
It looks so simple. A patient swallows this pill on a string and a sponge emerges. Last year on this programme, we showed you how it works. Once the capsule dissolves, you can pull the sponge back out up the patient's food pipe, where it gathers around 1 million cells. You can then test for signs of cancer. You can see some of those cells here. They're the white bits gently floating around. The cyto sponge won't be in wide use for at least a couple of years, but Liz signed up for a clinical trial funded by Cancer Research UK. A decision that saved her life. So Liz, this is really a case of like scientific curiosity and pure luck, isn't it? I mean, tell us what happened.
Well, I was extraordinarily lucky. It was curiosity that made me want to do the trial, and also because I have a scientific background, I was just interested in how the trial was run. I assumed that I was entirely healthy. I had no problems, so I thought I'd be a good negative control.
She did the test and forgot all about it, but further tests brought bad news.
I was asked to go in and discuss the results, so I already had a fairly good idea that the results weren't good. And I was told then that I had cancer, which is a bit of a blow. Even if you're half expecting it, it's still horrible to hear someone say the words, and you come home and start looking at your will.
But the cyto sponge had helped spot the signs of cancer early. After treatment, Liz is now fine.
I'm incredibly grateful to the people who do this sort of work, and to the sort of people who fund it, to all the people who raise money to make this work possible. You can't thank someone enough for saving your life. The symptoms are not clear, and by the time the symptoms do appear, it's too late. It's spread too far. So I think had I not had the cytosponge test, I would have died.
Richard, the trial is taking place across the country. This was developed here. Obviously, it's worked for Liz. Do we know how successful it's proving, though, elsewhere?
It's too early to say, to be honest, because although there are cases like Liz, and that, it's an amazing, compelling story, isn't it? They haven't got all the results in yet. They haven't tested everybody. I think there's about 12,000 people signed up for it along those lines, and only about 1,500 have had it done so far, which is still a lot of people. So when they've got all those results in, they'll analyse them and they'll start then presenting them properly in official papers, medical papers, and then we perhaps get to the point where this is more widely available, they hope. So that perhaps that could be a couple of years down the line. But we're seeing here already, Liz isn't the only one, where they're picking up the early signs of cancer. It doesn't find cancer, it finds the sort of the stage you get to before the cancer, what makes you more likely to get cancer. But it is working.
I think what's really interesting is when you look at medical advances, we've done a lot about very complex surgeries that can save lives. There seems to be this real switch, particularly in this region, to develop very simple ways of spotting cancer in particular. I mean, you look at this, it's a string with a sponge on the end.
Yeah, it's a big push to basically come up with things that are cheaper, simpler, and so the NHS picks them up, because if it's really expensive, no health service can afford it. So if you think a nurse does that after a few weeks training, well, if you go for an endoscopy, that horrible thing where they put the camera down your throat, that you need someone who's highly trained to do that. It's much more expensive. So there's a really big push for stuff that's cheaper, because there's just no point in finding things that are brilliant but cost so much money we can't pay for them.
And again, we're at the head of the race. Richard, thank you. around 360,000 people.
so RMDT.
Calvin, I think we'll get started.
All right, yeah, that's good.
A warm welcome to everyone who is on the line to this 9th Oesophageal Cambridge Symposium Masterclass in Esophageal Diseases. My name is Massimiliano Di Pietro. I'm one of the consultant gastroenterologists at Cambridge University Hospital and senior, and senior clinician scientist at the MRC Cancer Unit here in Cambridge. I am very pleased to open this symposium. As you know, this is the 9th edition of the symposium. Started back in 2002 with 20 attendees in one of the side rooms in the clinical school in Cambridge. And it's grown a lot during the years. We are not at the 10th edition yet, but we are making very good plans for the 10th editions. As you know, this was supposed to be a face-to-face meeting in March, but since then, life has changed for all of us. I think we all miss face-to-face meetings, traveling to conferences these days, meeting friends and colleagues from other places of the world. And obviously, this new life has come with many differences, but I think also with some good opportunities. Clearly, this is our new way of living, these meetings. And I think virtual meetings do have negative aspects, but also have many positive aspects. And certainly, it gives us the possibility to reach out to many more people than we used to do in the past. In the good days of our Cambridge Symposium, we had at most 120, 130 applicants. Today, we have more than 200 applicants. Obviously, they will decide at what stage to come in and listen to the lectures and sessions that they are most interested in. But we had a really, really good turnout of application. So a warm welcome to all of you that are on the line at the moment, and later on we'll connect. Let me give me just 1 minute to thank the people that have made this event possible. Many thanks to Joanna. Many of you will have heard from Joanna. She has done an amazing job to put this event together. Reach out to many of you, give you all the instructions to be in today. So thanks, Joanna, for your help organizing this meeting. And to Calvin, that has done a truly outstanding job with all the IT aspects of this meeting, helping all the speakers to resolve the technical issues. We're always very nervous about these virtual events because there is always a possibility that things might happen during the meeting. I hope everything will go smoothly, and the presence of Calvin today makes me feel much more relaxed about sort of the way the meeting will go. And finally, I want to thank Nastasia, who has done also an amazing job, both from the scientific perspective, but also from the technical point. So many thanks to Joanna, Calvin, and Nastasia for making this event possible. Today we have 3 sessions with outstanding speakers, internationally renowned, and I hope that this will be a very good educational day for all of you, and also give us the possibility to learn a lot about management of upper GI diseases. I just want to remind you to mute yourself. At the moment, there's no background noise, so thanks for all of you for complying with this. And I want to remind you that we have a system to collect your questions. I think all of you have received instructions to go to www.pigeonhole.at/esophagus. That's our personal room today for posting questions. All the questions will come to us and I will place them to the speaker. So feel free to ask as many questions as you want. I hope we will have good time after the talks to have good discussions. But if you do encounter problems, you can post questions also on the Zoom chat. We'll try to collect those as well. And as you know, this event is also streaming by YouTube, not only live, but also there will be a possibility later on to watch the highlights and or even the whole meeting on YouTube at later stages. So I would like to get started with the first session. Just to mention that one of the speakers, Rami Trace, is also at the moment participating to another virtual meeting. So we hope to have him in time for his talk, but there might be a small chance that the third and the fourth talk of this morning might be swapped. I hope to keep the order as it is. So that gives me the possibility to introduce the first speaker, Professor Sifrim from London. He's an outstanding figure in the management and diagnosis of upper GI diseases. In particular, has contributed significantly to the interpretation and introduction in clinical practice of methodology for diagnosis of upper GI disease, in particular high resolution manometry. He works between London and Leuven. Actually, I learned today that he lives in Leuven, but then travels every week to London to do his clinical and academic part. So it's really a great pleasure for us to have Daniel today to talk to us about the spectrum of GERD, indication and interpretation of the esophageal investigations. Thanks, Daniel, to be with us, and I look forward to your lecture.
Thank you very much, Messi, and thank you for inviting me to participate in this fascinating activity. I will discuss today some new things in the investigation of esophageal disorders, particularly benign disorders. If I can move. Right, these are my conflict of interest. When we have a patient with symptoms potentially of reflux disease, the first thing that we need to do is to see whether there are alarm signs, particularly weight loss and dysphagia and an epigastric mass. If they are, what we need to do is directly an upper GI endoscopy without further delay. However, the majority of patients do not have alarm signs, and they start treatment, empirical treatment with PPIs, in many cases once daily, and sometimes the patient does not respond and the doctor needs to either switch to another PPI once daily or right away to a PPI twice daily. There is now the possibility in Asian countries to test other drugs more potent than PPIs, and this is a novelty for this meeting. These are pickup drugs that have a faster and stronger effect on acid secretion. One of them is vonoprazan, and it is being tested at this moment in patients both with esophagitis and non-erosive reflux disease. Now, if this empirical treatment doesn't work, then the next step is to investigate the patient. And the investigations are mainly endoscopy and manometry and reflux monitoring, which is what I am going to discuss today. So if we have a patient that gets the endoscopy, there are two possibilities. The patient might have reflux esophagitis and the diagnosis is done, or the patient does not have esophagitis and no erosions, and that patient will get reflux testing. The reflux testing will also have two potentially outcomes. The patient has pathological acid exposure, and this is what we call non-erosive reflux disease. And the patient can have physiological acid exposure. And here we have two other possibilities, that there is a positive temporal association between reflux events and symptoms. And this is what we call hypersensitive esophagus or acid hypersensitive esophagus, or that the patient doesn't have a temporal association between reflux events and symptoms. And this is what we call functional heartburn. So we are left with four phenotypes. One is reflux esophagitis, and three are non-erosive. One is the true NERD, the other is reflux hypersensitivity, and the other is functional heartburn. The phenotyping is based on results of endoscopy, acid exposure, and reflux symptom association analysis. Endoscopy is strong. Acid exposure is, I would say, also strong. However, the reflux symptom association analysis is somehow weak in terms of accuracy, sensitivity, and specificity. It depends on the accurate reporting of the patient. Sometimes the prediction of outcome based on symptom association analysis is not as good as we would like. And in patients with mild to little reflux, the variability of the symptom association is pretty high. So this is a weak point in the phenotyping process. Nevertheless, it's very much used clinically, and this is what we have at the moment. There are many, there are many diagnostic possibilities in gastroesophageal reflux disease, starting from symptoms, endoscopy, biopsies, radiological tests, reflux monitoring, a new modality called mucosal impedance, some new endoscopic techniques, not new, but specifically related to diagnosis of non-erosive reflux disease using NBI, and salivary pepsin test. I will not discuss all of them in detail, but I will go through most of them. Let's start with symptoms. Heartburn and regurgitation are the most reliable symptoms for making diagnosis of GERD based only on history, but the sensitivity and specificity of the symptoms is pretty poor. For example, patients with dyspepsia or IBS might have some heartburn, and it doesn't mean that they have reflux disease. There are questionnaires that are generally used in clinical trials, but not in the clinical practice every day. This is a GERD-Q questionnaire, which is interesting because it is defining somehow the probability that reflux is they are present, and therefore, if it's a high probability, there is no need for further tests, according to the authors. Whereas, if the probability is intermediate, you can judge whether you can do a PPI test or not. and if the probability is very low based on the GERQ, you better study the patient more thoroughly. This is something new that I want to put on the table today, which is, I think, is very important. Over the last years, we know that many patients with reflux disease have what we call as hypervigilance. Hypervigilance is a psychological behavior that can be very important in non-erosive reflux disease in patients with hypersensitive esophagus and even more in functional heartburn. Knowing the level of hypervigilance is very useful because that will incline us to one or another therapy. This questionnaire is available in the literature and we are using it in London. It's very useful. What about endoscopy and biopsies? The sensitivity and specificity of endoscopy is known by everybody. Endoscopy has a very good specificity, of course, but it has a very low sensitivity because the majority of patients with reflux symptoms, they do not have endoscopic findings. Now, taking biopsies in a index endoscopy in a patient with reflux symptoms is a matter of controversy. There are people that they think that it is not useful. However, I think that it is useful, particularly to exclude EOE and to exclude microscopic inflammation if you have the pathology department able to do it. Of course, if there are no endoscopic signs of EOE and the patient doesn't have dysphagia, the chance that the biopsy will give a positive diagnosis of EOE is low, but there is still a percentage of patients with endoscopy normal and they can have EOE. Another important issue to consider is whether the patient has non-erosive reflux disease true, so he always had non-erosions, or the patient in fact is having a non-erosive reflux disease because he stopped the PPIs 1 week ago and 3 weeks ago he was having esophagitis. This is very difficult to know when you are doing the endoscopy whether the patient is a true NERD or a fake NERD, meaning a patient with previous esophagitis. The use of manometry for reflux disease is not for diagnosis of reflux disease. It's an adjuvant test that can help in many circumstances. For example, if you have a patient with achalasia, like this, sometimes patients with achalasia may have heartburn or regurgitation for a long time until the achalasia is diagnosed. Another possibility is that patients have postprandial regurgitation, not responding to PPIs, and when we study them, combining manometry and impedance, we make diagnosis of rumination syndrome. With manometry, we can know how good the esophageal body motility is, and we can also determine the presence of a hiatus hernia and how long is the hiatus hernia. So these are not diagnosis of reflux disease, but adjuvants. Moreover, we can identify the pattern of the OJ junction contractility, and you can see that this is normal, and this will probably allow more reflux to occur. And finally, in patients that had both surgical or endoscopic treatments for reflux disease and persist with symptoms after the treatment, manometry is very useful to identify phenomena like this, like intrathoracic fundoplication or a disrupted intrathoracic fundoplication, so we can search for disruptions of the fundoplication using manometry. Therefore, as I said, manometry is not for diagnosis, but is very useful to exclude other diagnoses, to quantify the OJ junction, and to understand anti-reflux therapy failures. Let's come to reflux monitoring. Reflux monitoring has at this moment different modalities. It can be catheter-based, it can be wireless, it can be only pH metry, or it can be pH combined with impedance. At the end of the day, we are interested in knowing how much acid is coming here, if we have a pH sensor in the stomach, how much acid is in the stomach in a patient that is studied on PPIs and see whether the dose is adequate. How many times there is a failure of the anti-reflux barrier, 20 times or 120 times. That will tell us how much this is failing and what is the association between symptoms and reflux episodes. We use normally a symptom index, symptom association probability, and all this information is used to determine whether a patient has true non-erosive reflux disease, hypersensitive esophagus, or functional heartburn. Why is it important to know this? Because the treatment is completely different. Non-erosive reflux disease is treated with PPIs and surgery. Hypersensitive esophagus is treated with PPIs and or surgery and or pain modulators. And functional heartburn should not be treated with surgery, should not be treated with PPIs, and it should be treated with CBT or pain modulators. So it's very important to identify the patient with functional heartburn. I will discuss more in detail impedance because this is the toy that I used for the last 20 years, and I have some new things to share with you today. Impedance can identify both acid and non-acid reflux. It can correlate non-acid reflux with symptoms. It can assess gas-related events. We can measure with impedance the integrity of the mucosa at this level. And we can now study a clearance phenomenon called post-reflux swallow-induced peristaltic wave. Of course, impedance can be used both off and on PPIs. This is an impedance tracing. You can see that together with a little pH drop, there is a drop in impedance and a spike. That spike corresponds to air. When you see it like this, you don't know the direction of the air, if it is going that way or that way. So when you amplify the time scale, you can see that in this case, the air is coming from here to there, and then it's going out from here to there. So this is not a belch coming from the stomach. This is air which is sucked into the esophagus and eliminated afterwards. This is what we call supragastric belching, and supragastric belching together with gastric belching are the two common belch phenomena that occurs in reflux disease, and it is very important to be able to identify supragastric belching because this is a behavioral disorder that needs to be treated accordingly. This is another impedance tracing. These are swallows. And you can see that in between the swallows, the impedance baseline is pretty stable. Now, when we look at the value of impedance when there is no swallow and there is no reflux, it represents the status of the mucosa that is touching the impedance electrodes. When the mucosa is normal, the impedance is around 2, 3, 4,000 ohms. But when the mucosa is damaged, it's more leaky and the resistance or the impedance is lower. So when we find a lower impedance baseline, it means that the mucosa is more or less damaged. And this is another parameter that impedance can teach us something. This is a reflux episode with a pH drop and an impedance detected reflux. And you can see that a few seconds later there is a swallow, and that swallow is associated with an improvement in the pH. So this is a reflux episode, and this is a swallow. But that swallow is not by chance. It's the consequence of a reflex. This is reflux, and this is reflex. There is a vagal reflex triggered by this acidification that makes us swallow saliva containing bicarbonate that in turn will improve the pH. In normal subjects, this reflex is present in most of the reflux episodes. In patients with reflux disease, sometimes this is not present. So we don't know whether this is a consequence of reflux disease or this is a primary cause of the prolonged acidification. But in any case, the presence of a low impedance and a low PSPW score is helpful to make diagnosis of patients, particularly with a pH negative, symptom association negative. In these cases, the combination of these two can help us to decide whether the patient has reflux disease or not. Now, the diagnosis of reflux in impedance pH tracing is normally used by applying an automatic software. All the systems have an automatic software. In general, the software is very bad. It's over-diagnosing reflux episodes. So we need to go through the tracing and select those that are real reflux and delete those that are artifacts. Now, in order to do that, we need to get an agreement. So we have recently published a consensus criteria to say which are real reflux episodes and which are artifacts. This has been recently published, and in that table you can see the criteria that should be used to say, okay, this is reflux, this is not, delete, go to the next. On top of that, another thing that I want to share with you today is that everybody thought that the impedance normal values were the same in South Africa, in Turkey, and in Tokyo, and in Buenos Aires. But unfortunately, it's not the same. We just finished a very large multi-center international study with hundreds of tracings for individual healthy asymptomatic, normal asymptomatic subjects to know what is normal in impedance pH metry. And we discovered that there are both system differences, these are two different machines, Sandhill and MMS, and region differences in different parameters detected by impedance, acid exposure, number of reflux, PSPW, MNBI. So now we have the real normal values for impedance pH metry, and you like it or not, you will have to use the values that correspond to your country and to the system that you are using. This is very important because there are significant differences in baseline impedance, for example, between Asian and European countries, in acid exposure differences between different systems. So now we have a very large database of normal values, and you can look at the tables and say, okay, these are the values that I need to use in my lab. This was published 2 weeks ago in Gut. Another interesting novelty of the use of impedance is in patients that are refractory to PPIs and persist with regurgitation. Now we know that there is a pattern in the impedance tracing that corresponds to rumination syndrome in patients with potential rumination. It's a postprandial regurgitation, and it is a frequent occurrence of non-acidic symptomatic episodes, and we have a score, and you can say, okay, the likelihood that this is a rumination is very high. The use of wireless pH metry is very much disseminated both in Europe, in Asia, and in the United States. There are specific indications for the use of wireless pH metry, and there are specific indications for the use of pH impedance monitoring. We have recently tried to put together what are the indications for one and the other technique, regardless of some non-medical bias. I mean, insurance biases, economic biases, non-medical biases that determine why one system is used and the other not. And we came up with some guidelines for indications to respond to the question, does the patient have pathological reflux? Why is this patient with previously confirmed reflux disease not responding adequately to PPI therapy? So the indications for wireless pH metry are the following. The test should always be done off PPIs. It is indicated particularly in patients who do not tolerate the transnasal catheter, in patients that have infrequent symptoms, that where reflux symptom association is needed and you cannot get it in a 24-hour test. in patients with clinical suspicions of GERD, but the 24 hours initial test was negative, and in patients that you think that he doesn't have reflux, that the referral doctor and the patient, they do think that they have reflux. And so you want to have a very consistent negative study to stop the PPI treatment. The indications for the 24-hour impedance pH monitoring are the following. The study should be done on PPIs when the patient is refractory to typical symptoms and it has documented reflux disease. In patients with respiratory symptoms or disease potentially triggered by reflux, for example, cough, or prone to deterioration from reflux-related microaspiration, for example, pulmonary fibrosis, cystic fibrosis, lung transplant, in patients with repetitive belching with or without GERD symptoms, in patients with suspicious of rumination, and in patients that have persistent symptoms after anti-reflux surgery or endoscopic procedures. There is one more toy to work with. This is the mucosal impedance. The mucosal impedance has been proposed to identify patients with EOE, achalasia, and reflux disease. It is a very interesting technique. It's a catheter through the scope that touches the mucosa and identifies the mucosal baseline impedance. The problem with this technique is that not allowed to perform reflux symptom association analysis, and therefore you cannot diagnose hypersensitive esophagus or functional heart. The determination of pepsin in saliva has been a topic of research in my lab and in other places in the world, and we were very excited in the beginning of the 2000s because we found very good results. Unfortunately, we repeated the test more recently, and the company that performed these PEP test studies changed the antibodies, changed the technique, and we couldn't reproduce our previous results, and we couldn't distinguish different phenotypes of reflux disease. So we propose that this technique is interesting, but is not ready for clinical application. This is my last slide. The Lyon consensus proposed three different situations. Conclusive evidence for reflux disease, when you have a pathological endoscopy, very pathological, and acid exposure more than 6%. It proposed a very clear situation against reflux where the endoscopy is negative and the acid exposure is less than 4% and few reflux episodes. And there is a borderline situation where the esophagitis is grade B or A and the acid exposure is between 4 and 6, and there are between 40 and 80 reflux episodes. In this situation is where all the other techniques become relevant as an adjunctive or supporting evidence of reflux. So you can look at the histopathology score, you can look at the baseline impedance, at the PSPW, you can look at the presence of a large hiatus hernia, esophageal hypomotility. If all this is heavy in the direction of reflux, then you need to treat that patient consequently. In the other hand, if all this is negative, then you are in this situation. All right, this is my group last Christmas. Unfortunately, this Christmas we will not be able to celebrate this way, but I hope that next Christmas we will do it. Thank you very much.
Thank you, Daniel, for this truly outstanding lecture. It clearly shows that reflux disease is much more complex than what we think in clinical practice, and a lot of aspects of it should not be underestimated, particularly when we want to make a more refined diagnosis. I have a lot of questions for you, but I don't think that there is enough time to ask all of them. But while we wait for questions coming on the chat, I would like to ask you, so if we decide to do a test, a pH impedance test on PPI, should we use a different cutoff for esophageal acid exposure time?
This is a very, very good and modern question. I must say that in the Lyon consensus paper, the authors proposed to use the same cutoffs as what we have for off PPIs. and I think it's a mistake. And we are at this particular moment, the same group, we are collecting all the studies of healthy subjects studied on PPIs from all over the world to do a similar work that as we did with the off PPI to come up with a real good cutoff for these patients. Definitely is not 4%. It's not. It will be much less than that. So when you have a patient studied on double dose PPI and the pH is 4%, probably is pathological.
Yeah, I agree. And between the symptom index and the symptom association probability, are they equivalent? Should we focus on one, or should they be taken together?
They should be taken together. Both of them should be positive to consider a patient with reflux hypersensitivity. And this is very important when you look at the number of symptoms and the number of reflux. A patient with very few symptoms, 3 in 24 hours, does not allow you to do any meaningful reflux symptom association. So when we have a patient with less than 4 or 5 symptoms, we simply ignore the reflux symptom association, and we use both.
And a modern question, is there any risk of, during the COVID period, on doing transnasal intubation in terms of aerosol generating? What is your perception on that?
I think there is risk, and we both at the Royal London and in the Princess Grace Hospital, we are taking all the precautions to use the PPE, and the patients all that are performed this day come with a swab negative. There is an aerosol generating risk. Just at the moment of intubation, the patients normally gag or cough in front of you, and I think that this is risky.
And a very quick question and a quick answer. Do you think we should stop PPI before a diagnostic upper GI endoscopy for GERD?
Oh, yes. For endoscopy, yes. I think that you should stop PPIs, at least for a week. And I think that this is very important. If I have to make a choice, I will stop it for more than a week, for 2 or 3 weeks, because many patients will develop esophagitis when you stop the PPI. This was shown by Stuart Spechler. 2 or 3 weeks when you stop the PPI, the real disease appears. So 1 week to me is too short.
Yeah, which is generally not done in this country. So no. I hope all of our attendees today will take a lot of insight from your truly outstanding presentation. Thank you very much, Daniel.
My pleasure.
So we will carry on with the second speaker. This is part of a debate. It is my pleasure to welcome Giovanni Zaninotto. He's one of the pioneers in the treatment, endoscopic and non-endoscopic, in particular surgical treatment of benign diseases of the esophagus. He trained between Italy and the US, and he was fellow of Tom de Mister in the old time. So he also has a dual appointment. He's professor at the University of Padua and Imperial College in London, and he's published an enormous amount of research on the management of esophageal benign disease. So it is my great pleasure to welcome Giovanni today. He will talk about the surgical perspective in the management of difficult GERD. And this will be part of a debate together with the next talk given by Ramesh Weiss, and we aim to take questions at the end of the two talks. Thank you very much, Giovanni, for being with us today.
Thank you, Massimo, for the invitation. Just a second that I arrange my computer. Okay. That's it. Okay. So when I was invited to give a speech on the difficult GERD patient, according to a surgical perspective, we decided that the most difficult patients that the surgeons will face is the non-responsive patients to the PPI. And if I go back to my practice, I was about 60% of my practice are patients sent by gastroenterologists or they GPs because they do not respond to PPI. And this seems logical because if the patient is PPI responsive, why he or she should be referred to a surgeon? So my patient, this typical patient is most likely a female, a woman, and he has some typical symptoms like heartburn and some strange symptoms sometimes, like I remember patients who have an horrible burns on the tip of the tongue. These symptoms responded quite well for a while with PPI, but then the symptoms recurred. Then the patient Googled his or her symptoms or met some friends and he is advised to have a surgical consultation, and they arrive in your office very distressed, and they ask you to do anything is possible to resolve their symptoms. There are several questions on PPI non-responders patients. The first is, do we have a clear definition of them? Who are they? The second one is how many patients are non-responders? And which are the mechanisms of refractoriness to PPI? How many refractory symptoms are caused by reflux? What can surgery do for them? And last, if surgery has a role, what type of intervention? Complete Nissen fundoplication, partial fundoplication, other endoscopic treatment, LINX, or endostim. So the best definition in the literature for non-responder patients came from the previous speaker, Daniel, and it states that non-responders are those patients whose symptoms, heartburn or regurgitation, do not respond to a stable double dose of PPI during a treatment period of at least 12 weeks and continue to report troublesome symptoms while on PPI at least 3 times a week for the last 3 months. So, sorry about that. So the key words of this definition are the presence of typical symptoms, double dose of PPI per 12 weeks, and symptoms that are at least 3 times a week. The problem is this word, troublesome. Troublesome means causing difficult or annoyance, and this is somehow a subjective definition of the symptoms. So in other words, we do not have a clear cutoff using a score, a symptom score, or something else that tell us this is a non-responder or a responders, because some patients may consider their symptoms troublesome and other they can't. How many patients are non-responders? Well, there are a couple of papers. One is published recently, but I prefer this one that was published about 10 years ago by Elserag. And this is a systematic review on persistent reflux symptoms in primary care and community studies. So this systematic review involves 21,000 patients, and there were 8 observational studies and 11 interventional studies with 6 randomized control trial and 5 non-randomized control trial. The prevalence of combined or partial non-responders is quite high, from 17% to 45%. The risk factors for the study to have more non-responders is that observational studies has more non-responders than interventional or randomized control trials. Studies from Europe reports less non-responders than studies from United States and Australia. If the study has a higher proportion of females, the risk ratio increased to 3.66, and if the reported outcome is less than 2 symptoms per, greater than 2 symptoms per week, the risk ratio obviously is lower. Which are the mechanisms of refractoriness to PPI? This is a little bit modified by the article of Sifrin, and we have symptoms that are related to an abnormal reflux, and this maybe the patient is not compliant with drug treatment. That is a very common situation, or he has a rapid PPI metabolism, that's very rare, or he has a hypersecretory status, again, it's not frequent. He might have anatomic abnormalities influencing the regurgitation, especially at night, as a large hiatal hernia, or he might have reflux of non-acidic material, like weak acidic of bile reflux. And then we have symptoms that are not clearly related to an abnormal reflux. So like we have functional heartburn, so with an hypersensitivity to physiological amount of reflux, both acidic or weak or gas reflux, or impairment of mucosal integrity for other reasons than reflux disease, or psychological morbidities. The next question is, how many refractory symptoms are caused by reflux? There is another small but relevant study by Roman, by Sabine, and she investigated on 78 non-responders patients with a high-resolution manometry pH impedance on PPI, and only 7 patients, 9%, had persistent acid reflux. 28 patients, 36%, have a reflux-sensitive esophagus, and in more than half of the cases, they have functional symptoms. What can do surgery for non-responders? Well, in general, anti-reflux surgery recreates a paraphysiological barrier between the esophagus and the stomach by increasing the lower esophageal sphincter resting pressure, reducing the transient lower esophageal sphincter relaxation. And as a consequence, anti-reflux surgeries abolishes all the acidic, weak acidic, and bile reflux, and reduces belching, and may potentially cure also patients with hypersensitive esophagus. But anti-reflux surgery has a price to pay. It is an effective treatment. We have a Cochrane review that demonstrates that, but has side effects that can be quite important, like dysphagia, gas bloat, inability to vomit. And we know also from another interesting review, although it's a little bit older, that anti-reflux surgery is less effective in non-responders patients than in responders patients. What can do surgery for hypersensitive esophagus? There are a few studies on that. One is this one by Brothers, and he compared 28 patients with esophageal hypersensitivity and 128 patients with true gastroesophageal reflux disease who underwent laparoscopic Nissen, and they found that in both groups, the quality of life improved. The second studies I want to share with you is anti-reflux surgery in refractory patients with positive symptom index and non-acid reflux. Again, this is a nice study, extracted 19 patients out of a group of 200 patients. Only 14 patients, they have a non-acid reflux with positive association, positive symptom association. And you see that in these 14 patients, most of them, 13 out of 14, they responded well to surgery. If we look overall, we have only 2 studies that's evaluating correctly alkaline or weakly acidic reflux and surgery. And both are positive. I mean, they report 94% and 98% of success rate. But The two studies have one 14 and the other one's 29 patients, a small number of patients. No physiological assessment of the results was done after surgery, and we cannot exclude that the placebo effect of surgery can justify these very optimistic results. In a few years ago, there was an interesting systematic review on the effects of laparoscopic fundoplication for GERD in partial responders to proton pump inhibitors. And the interesting thing is that on 17 studies on over 2,800 patients, there were 14 different definitions of partial or complete non-responders. There were only 3 randomized controlled trials. 3 that were reporting on same patients at different time points. There were 10 prospective core studies and 1 retrospective, and the outcomes reported in each of these studies was different. The prevalence of heartburn was reported in only 7 studies. The prevalence of regurgitation was reported in 6. Acid exposure was measured only in 8, and the quality of life was reported in 4. Patient satisfaction in 6. Post-operative use of PPI in 8 studies, showing that, there is the literature is very confused on this. Anyway, at the end of the day, the review shows that surgery may be helpful in these patients, but their positive results that you can see here in these 3 graphs, heartburn, use of PPI, and requiring early intervention, fades, the good results of surgery fades along the time. And you see that the recurrence rate at 5 years and at 10 years is almost 35%, 36% at 5 years. And the use of PPI and the number of patients that require their intervention follow the same line. A much better study was published last year and by Speckler, and he reports a study on the better administration patients, and this is a rare type of patients. They are not comparable to the old population because they are ex-military person. The veteran people are quite different from the normal populations. But anyway, the study was really well performed. They enrolled patients that had abnormal acid reflux on PPI for more than 4% of the total time of pH monitoring, or a positive symptom association probability greater than 95%, or both tests positive. Patients were randomized and stratified according to positive symptom association probability, positive 24-hour pH monitoring, or both tests positive. The medical arm comprised a group of patients receiving only PPI, that was defined as standard group, or PPI or baclofen or desipramine added sequentially, that was defined as the active medical group. The surgical arm was a laparoscopic Nissen, and the outcome was an improvement of 50% of GERD at high quality of life at 1 year. And these are the results. In my opinion, the most important results to remind is that of the 366 patients that were recruited in 3 years, and you think that there are really thousands of patients at the VA hospital, only 366 were recruited, and of these, 80% of these patients were excluded. 70 because they refused, but 99 had functional heartburn, 23 had other disorders, 70 refused, and 54 for other reasons. At the end of the day, only 78 of the patients were randomized, 27 to surgery, 25 to active medical, and 26 to control medical. And you see that in this very selected population, surgery may help. What kind of surgery should be used? Well, there is another interesting review of anti-reflux procedures in non-responsive patients to PPI. And from all group of patients, I selected only the comparative studies. So we have 19 studies on the effect of laparoscopic fundoplication, but we have only 3 comparative studies. 2 were too small randomized control trial, and 1 was a large retrospective study made in France. And at the end, it shows that if we use, they were comparing a 360 degrees laparoscopic fundoplication, the so-called Nissen fundoplication, to an anterior or posterior fundoplication. And at the end of the day, they found that both complete or partial fundoplication obtained the same control of reflux, but in all the 3 trials, there was less dysphagia in partial fundoplication than in the Nissen fundoplication. What about the other possibilities? Well, for transoral incisionless fundoplication, there is only 1 in non-responsive patients, only 1 comparative study, and you see that it's much in favor of laparoscopic fundoplication because, I mean, was normal, acid exposure was normal after laparoscopic fundoplication, but only 50% of patients achieved the same result after transoral fundoplication. There are no comparative studies for radiofrequency ablation, stretta, and other reflux procedures. And remember that the endostim was a pacemaker stimulating the lower esophageal sphincter, was withdrawn from the market due to economic problems last year. For the other possibility, that is a magnetic sphincter augmentation or LINX, that's the small ring that is put around the esophagus. We have only 1 observational prospective studies. He enrolled the study enrolled 24/9 LINX patients and 47 with laparoscopic fundoplication. It seems that PPI discontinuation was better after LINX, and but dysphagia was the same. In whereas the gas bloat symptom was much more frequent after fundoplication than after gas bloat. But of course, all these things should be taken with some grain of salt. And I don't have experience with LINX, but I have removed 3 or 4 of them, and it's not easy, by the way. So I'm not a believer on LINX, that's it. But this is a personal opinion. So the take-home message for PPI responders and surgery are that only a very minority of non-responder patients will benefit from anti-reflux surgery, approximately 1 out of 5. And that proper patient selection is the main requisite for success. Only patients with proven abnormal acid exposure and or clear association of reflux symptoms will benefit from surgery. And if I may make another small comment, you have heard by Daniel how difficult it is to use the pH impedance and how careful could be read. And I do not rely always from pH impedance if I don't know who is the physicians that is performing it. So, I mean, pH monitoring is very simple to read. pH impedance is much more difficult and delicate. Alternative treatment to fundoplication do exist, but their efficacy is unproven. And the only thing that we can say is that, especially in these difficult patients, in which always there will be some, even in those that do have a real reflux, so there are some psychological problems. it's much better to use a partial fundoplication because of the lower side effects than Nissen fundoplication. And this is, I think, the last slide. Thank you for your attention.
Thank you, Giovanni, for your very comprehensive and very clear lecture touching on the evidence that is there and very balanced opinion. So we are going to go straight to the second talk of this little debate, and then we'll take question afterwards. It's my pleasure to welcome Rami, who is a very busy speaker today. He's attending at the same time 2 different meetings. So thank you so much, Rami, for being with us and accepting this invitation despite your conflicting schedule. Rami trained between the US and the UK, Edinburgh, London. He's now consultant in UCLH. He's part of the Chicago Consensus Group, and he's done an amazing amount of work together with experts in the field for the interpretation of the high-resolution manometry, and he's got his hands on a daily basis on the management of patients with reflux and motility disorder. So he's giving to us 2 lectures today, but for the time being, we look forward to the medical perspective of the difficult GERD. Thank you, Rami, so much for being with us.
Thank you so much. Firstly, before I say anything, can you see me and can you see my slides? And can you hear me?
Yes, we can hear you and see your slides.
Great. Thank you very much, firstly, for inviting me to speak today. Thank you very much for organizing this event. I know you had to cancel it before because of COVID, and for persevering. I wish I was there. It would have been nice to have our nice dinners that we usually have the night before. I'm very pleased to be here to provide these 2 lectures. You pointed that this is a debate. I think I think the problem with the debate is that we need disagreement, and I don't think there's any disagreement. Giovanni and I tend to agree more than we disagree. I think Giovanni set the ground for this talk as well, because he explained, him and Daniel as well explained everything that needed to be explained about how to define the difficult GORD patient. What I'm going to do is just go through treatment options whereby when the reflux disease might not be responding as one would wish. Maybe there are other options and things to look at. So here's my disclosures. We know that 20% of the Western population have reflux symptoms. Most receive acid-reducing medications. Acid-reducing medications heal up to 95% of esophagitis, but a large number of patients continue to have symptoms. So is it more than just acid? We cannot predict how patients will respond to the same insult. The insult of acid reflux can lead to Barrett's esophagus in a small cohort. In a third, it can lead to esophagitis. The majority, however, have either functional heartburn or endoscopy negative reflux disease. So treatment is going to be different across the board. We also know that in patients with endoscopy negative reflux disease, symptoms are much more enhanced compared to the more theoretically severe reflux disease of erosive esophagitis and Barrett's esophagus. And we know that patients with these more severe symptoms or enhanced symptoms of endoscopy negative reflux disease, acid-reducing therapy, I've just lost, acid-reducing therapy tends to respond least well. It responds, but not as good as erosive reflux disease and Barrett's esophagus. So is it all just acid? I put to you, no, it isn't. And that might be the reason to why these patients are considered to be difficult GORD patients, because there are many mechanisms one needs to take into consideration, and many of these are overlapping, and treatment is sometimes needs to be overlapping. So let's start with proton pump inhibitors. Most patients receive proton pump inhibitors. When they don't work, well, the low-hanging fruit here is to assess compliance and adherence. Many patients think that they don't quite grasp the concept that acid-reducing medications such as omeprazole are not antacids. So they take it on demand, and of course it's not going to work on demand because it needs to be absorbed, acid needs to be reduced, and then the reflux occurs thereafter. is going to be less acidic. So this is taken as a prophylaxis rather than on demand. The other thing is not all proton pump inhibitors are the same. So the same dose of different proton pump inhibitors can lead to different results. So it's not uncommon and not unwise to change and see what happens. It's also not unwise to increase the dose as a trial, because although the response to increasing dose is small, it is still significant, and it can result in an improved response rate. Increasing the dose also to more than once a day has also been shown to be efficacious. In this cohort on the left, up to a third of patients had reduced acid exposure in both typical symptoms and atypical symptoms by increasing the dose to twice daily. Similarly, even in healthy subjects, the exposure to acid in the stomach reduces as you increase the dose. And as you increase the frequency of the medication. So it's worth having a go at trying before we say that patients are refractory. But obviously, of course, there's many patients don't respond or don't like or have side effects to proton pump inhibitors, and the next best thing to use is an H2 receptor antagonist. Now, this works, and it has been around for a long time, but in the recent past, it has primarily been used as an adjunct to PPIs to be taken before bedtime, because it can reduce the nocturnal acid breakthrough symptoms. But the problem is tachyphylaxis. So patients get used to it, there's tolerability, and it's advised that patients should perhaps have holidays where they stop the medicines for a period of time. We all know about the problem with the current shortage of ranitidine and all its all the other H2 receptor antagonists. So moving away from esophageal acid exposure, from anti-secretory medicines to antacids, Gaviscon needs a mention, because Gaviscon has not only antacid properties, but it is an alginate. And as an alginate, when it reaches the stomach, it forms a foamy raft, so like a roof that it forms over the food, and it can last for a few hours, and it's a reflux suppressant. So it reduces acid or food reflux because it refluxes itself, and so symptoms are reduced. And its utility is primarily not only as an ad hoc therapy, but can be used as an adjunct to proton pump inhibitors. So what I do is I give patients who are not responding so well the combination of acid-reducing medications in advance of eating, 30 to 60 minutes, because the proton pump inhibitors work best on an empty stomach, and Gaviscon after food and before bedtime. And not uncommonly, patients say that there is a good response to that. The problem is it's short-acting, and not everyone likes the taste. GABA B agonists, baclofen, have been around for a while. We know that they reduce transient lower esophageal sphincter relaxations, increase lower esophageal sphincter pressure, reduce both acid and weakly acid reflux, increase gastric emptying. They can also be used in patients who have Hiatus hernia. The best used as an add-on therapy to PPIs, and they can also be used in functional disorders like rumination and supragastric belching. But we all know the side effects. The problem is that it has a short half-life, and patients don't like the drowsiness and the feeling that they experience. So if you're going to use it, you start low and you build up, and it can be a benefit as an add-on, not as an exclusive therapy. Neuromodulating agents have been around for a long time. They're probably arguably the most studied drug in functional upper GI disorders. These include SSRIs, tricyclic antidepressants, and numerous others. These help to reduce visceral sensitivity. Patients who have no evidence of reflux disease but have ongoing symptoms, or patients who have evidence for reflux disease but are not responding enough, this can help. It's also important to note that these patients can also have psychosocial comorbidities, and that needs to be addressed. So the patient isn't a reflux disease positive or reflux disease negative. They're a patient as a whole, and we need to look at these patients as a whole and treat them as such. So we need to combine the medications with other forms of therapy As you know, with neuromodulating agents such as amitriptyline, daytime drowsiness and constipation can occur, and we need to warn the patients and have treatments ready for this. So on the note on the psychosocial issue, we know that patients who have psychosocial comorbidity will have enhanced symptomatology. Patients with symptoms that are not responding will also lead to enhanced psychosocial stressors, comorbidities. The study from 1994 very interestingly showed that muscle relaxation techniques can reduce heart rate, anxiety, and also reflux symptoms, and in fact can also reduce esophageal acid exposure. Now, major diet and avoid this and avoid that, but to be honest, there is very little evidence that any of this works. Stopping caffeine, stopping chocolate, spicy foods, alcohol, even smoking. There's very little evidence that any of this makes a difference to actual objective measurements. What there is evidence for, however, is chewing gum. So chewing gum increases salivation, increases peristalsis, increases clearance. And there's evidence that changing the diet content can help if you're reducing calorie content and fat. So interestingly, low-calorie diet can reduce both reflux events as well as symptoms. Low-fat diet can reduce reflux symptoms up to 40%. So a low-fat and calorie diet can be helpful, especially in those patients who are refractory and who are considered troublesome. Of course, the problem is compliance and quality of life. So patients might not enjoy not having their burgers every once in a while. Obesity is clearly a factor. We do know that there is clear evidence that obesity will increase the likelihood of reflux. And in this very interesting large study in 2006 from New England Journal of Medicine, looking at 10,500 women, a reduction of over 3.5 units of BMI led to 40% reduction in the frequency of reflux disease symptoms. So it is always useful to try and to look at the patient as a whole and try and treat them not only with medicines but with their lifestyle in terms of weight loss programs, etc. Nighttime reflux is important, and it's often overlooked, but in fact 3/4 of patients who have symptoms who are considered to be refractory have nighttime reflux. And the thing about nighttime reflux is that patients don't have as much clearing peristalsis, less saliva is produced, medications such as PPIs don't work so well at night, so there's nocturnal acid breakthrough. Giving ranitidine can lead to tachyphylaxis. Gaviscon only works for a short period. So, it's these patients are if you have acid reflux and there's pooling of acid, it can sensitize the patients the following day. So there's been interest in looking at how to manage this. And back in the 90s, there are some studies that took place looking at positioning, sleep position. And we know that babies, for example, who reflux, it's advised that they're encouraged to sleep on their left or on their back to reduce reflux events. And this applies to adults. And in fact, there's a resurgence in this area, and there's this new device called Left, which helps train patients to sleep on their left or supine and to avoid the right-sided sleep. We're currently looking forward to studying this. I'm going to just present a couple of slides here, which is not because I propose that these should be used for the troublesome reflux disease patients, but that these exist and they are alternatives to surgery, but the data is not as robust as in surgery. There's Giovanni already discussed this briefly, the TIF, transitionless fundoplication, which basically aims to recreate the angle of His and the anti-reflux barrier. There were two versions, the TIF1 and TIF2. There are lots of cohort studies, a few randomized control studies, and it appears that the esophageal acid exposure measurements seem to be better in the TIF2 cohort following therapy compared to TIF1, so the technology has improved. But what is certainly patients respond to is their symptoms. Their symptoms do improve after, but the problem is that all these studies are short-term studies. There's 3 months, 6 month studies, maybe 1 year. There's no direct comparison between TIF and fundoplication. So I wouldn't use this as a primary therapy for troublesome patients who are not responding to PPIs. Similarly, Stretta, Giovanni alluded to this as well, radiofrequency ablation device that sends energy into the lower esophageal sphincter. It's not clear how it works. It might be through fibrosis. It might be through neuromodulating the area and reducing symptomatology. There are 4 randomized controlled trials, but these are sham or PPI controlled. There's some systematic reviews, including the cohort studies. Again, symptoms improve, but the acid exposure time reduces, although it does sometimes, but it doesn't normalize. So unlike anti-reflux surgery. We can't forget about motility because ultimately patients who complain of ongoing symptoms might have a problem with motility rather than just ongoing reflux. This is what you and I will look like when we have lunch later on. When we swallow, pharyngeal swallows and then clearing contractions. This is a healthy subject. This is what it looks like when you've got chronic reflux disease not uncommonly, patients will have fragmented peristalsis, big gaps in the peristalsis. And so patients will not clear their esophagus so easily. And so the treatment here should include treating reflux, but also consider treating motility. Now, the prokinetics have been around, but every time a prokinetic comes into play, it's withdrawn because of whatever problem. Looking at a recent meta-analysis this year, 14 randomized controlled trials looking at cisapride, domperidone, mosopride, etc. What they found is interesting. They found that when used as an adjunct to PPIs, the esophagitis or change in the esophagus does not improve, but symptom response does. And when they subanalyzed these data, they found that in NERD, in the endoscopy negative reflux disease group, there's no statistical difference. So it's primarily in the esophagitis group that the symptoms tend to improve. So prokinetics seem to work best in patients who have esophageal or mucosal disease and ongoing symptoms. So going back to the previous slide, these patients with ongoing symptoms of fragmented or weak peristalsis or frequently flared peristalsis, who probably have esophagitis to some degree on endoscopy, these are the ones who would benefit most with prokinetics. And it's also important to remember that not all reflux is reflux. So your patients can also have other conditions, such as rumination, such as supragastric belching. And if you put a pH sensor down there, it'll come back positive. But and if you give them PPIs, they will not respond. Well, that's because they don't have reflux disease in the strictest sense. And the treatment here is not with medication. It is with behavioral modification. And we know that rumination does respond very well to behavioral modification therapy, diaphragmatic breathing exercises, for example. The study from Nottingham showed that just under half patients had complete remission with this technique and partial improvement in another third. And supragastric belching also, the diaphragmatic breathing can help, but a dedicated speech and language therapist can reduce symptoms markedly. And these patients, the number of patients I receive with supragastric belching who have been defined as having reflux disease, and even some of them have even proceeded to having anti-reflux surgery. The treatment here is behavioral. So in conclusion, ladies and gentlemen, not all reflux is the same. Not all reflux is reflux. We need to look at all the mechanisms. We need to look at the stomach, look at the esophagus, look at the way the esophagus works, and also look at the way they take their medicines. We need to confirm that they're taking the medicines appropriately, correctly. They're compliant. Consider double dosing, increasing the dose as a trial. That doesn't mean you keep them on high dose twice daily for life. Consider adding adjunctive treatments. So we don't need to remove one treatment to start another. Adding alginate to PPI is not uncommon. Baclofen to PPI, prokinetics, for example. If we're going to advise patients, I tend to avoid dictating to patients to avoid this, that, and the other, because quality of life is more important than reflux. But if we are going to advise anything, then we should use evidence. And the evidence is low fat, low calorie diet is best, lose weight, chew gum, as long as you're not super gastric belcher, and position sleep. Now, behavioral modification and neuromodulating agents are important, and we need to think about their psychosocial stresses, and we should avoid invasive therapy until and unless we've excluded all other options. And the problem is that troublesome GORD patients might do least well if you alter their anatomy. Thank you very much. So I'm just going to also, I'm sorry, Masi, I'm going to plug these two meetings while you're asking questions. Thank you very much.
Thank you, Rami, for this excellent talk, really practical. I think a lot of us will have taken a lot to advise to our patients. So Calvin, if we can have also Giovanni Zaninotto. We are a little bit late, but I want to allow 5 minutes for questions in the interest of the education. So I would like to start with Giovanni. Giovanni, when we say double dose, do we mean like 20 milligrams omeprazole, or we mean 40 milligrams omeprazole in terms of defining the resistance?
40 milligrams of omeprazole.
Twice a day?
Twice a day.
Okay. Rami, is there any definite evidence that esomeprazole is better than other PPIs in terms of controlling reflux?
I flashed one of the slides up showing that esomeprazole 40 is better than esomeprazole 20 is better than esomeprazole, better than omeprazole. Now, the issue here is that the improvement is over time, and the improvement is small. But in some patients in clinical practice, it is marked. And whether or not this is because of the drug itself or because of the presumption that you're getting a better drug that's more expensive, that you're going to do better, we don't know. But it's worth considering increasing the dose.
So it's worth trying, and particularly involving the GP in this decision, so that the GP is aware of this importance. Giovanni, one of the questions from the audience: what is the lifespan of a fundoplication, and what is the evidence that redo fundoplication works in patients that lose effect of the fundoplication?
Well, this is a great question. Who knows? Well, as everything in the life, there is a lifespan for fundoplication that probably should be more than 10 years. But I mean, we see that there is, I mean, the curve of relapsing after fundoplication, there is a first clear step in the first years, and then there is a slow decrease, as more or less as happens for the laparoscopic Keller myotomy. But I'm pretty sure I do not like to operate on non-responders patients, and I don't trust much pH impedance, special impedance, if it's not performed by a very good physiologist, and there are not many of them.
So training is very important. Yeah, absolutely, Rami.
I was just presenting the BSG guidelines for esophageal testing at the other meeting I just came from. I absolutely, that's why this is not a debate, because everything that Giovanni says I agree with, and I hope, in brackets, that he agrees with me. What the issue about impedance is that the Lyon consensus and the updated Porto consensus and the American Society of Gastroenterology, etc., suggest that if we are going to be using making decisions on anti-reflux surgery, it should be primarily with measurements of acid. The addition of impedance is useful adjunct, but we should not be making a decision of anti-reflux surgery based on a number of reflux events alone or impedance alone. The only caveat here is there's a study from the St. Louis group from Prakash Gawali who showed in 2015, who showed that the best predictors of outcome following anti-reflux surgery is acid exposure time, obviously, as well as symptom association for all reflux events. So in that context, symptom association with impedance is important because it includes acid and non-acid, but which is better than symptom association of just acid alone. So in that context, it is important for decision making, but alone impedance is not, there's not enough data to use impedance alone for decision making for anti-reflux surgery. Sorry.
Thank you. I think that's very good. Giovanni, yes.
Yes, Rami, I agree completely with you. I just a short comment. What I do in with the patients, this is not response. I repeat PPI. I repeat pH monitoring of PPI. And if it is still negative, and I believe that the patient has symptoms, I use Bravo. That is another thing that is important because we can monitor more than 1 day of reflux, but of PPI.
1 in 3 impedance pH studies, 1 in 3 will be different when you repeat them. So one test does not equal the final measurement. So don't be afraid to repeat the test, especially if there's any lack of any gray area. The Lyon consensus as well defined what is pathology, what is normal, and then the gray area in between is an acid exposure time is between 4 and 6%, and acid and an endoscopy with esophagitis of grade A or grade B is not reflux disease that is worthy of anti-reflux surgery, nor is a Hill grade measurement. If you have an acid exposure time between 4 and 6%, if you have esophagitis of grade A or grade B, I would propose repeating the test in either again with a catheter or with, as Giovanni says, with a wireless pH study.
Giovanni, any role of prokinetic in patients who have had anti-reflux surgery and are still symptomatic?
Massimo, which prokinetic?
You tell me. That was a question from the floor.
Well, there are, I mean, probably Daniel and Rami knows better, but I'm not aware of any prokinetic that's
okay. So no role for it. And last question, Rami, in the interest of time, baclofen, is it available in the UK, and which patients are more likely to respond to it?
Baclofen is available in the UK. Patients who have, patients with rumination, for example, can have it used. It can be used as a reflux suppressant, where patients have, for example, transient lower esophageal sphincter relaxations as a primary problem seen on manometry. The problem is compliance. The patients don't like it. Yes, don't be afraid to prescribe it, but start slow. Start low and warn the patient.
Excellent. Well, let me thank both of you.
It should not be used alone.
Not alone. Let me thank both of you for your excellent presentations. I think this has been extremely useful for our attendees. We have more than 100 people at the moment. So thanks both of you. And it's time to move to the next talk given by Ines Modolay, one of our consultants here at Cambridge University Hospital, trained in Spain, and then really brought fresh air to Cambridge with her outstanding knowledge on upper GI diseases. She's lead for teaching here of our trainees at Cambridge, and I'm really looking forward to have practical advices on the management of EOE. Thank you, Ines, for being with us today.
Thank you, Massi. I would like to start by thanking you for asking me to take part in the symposium and include me in this distinguished panel of speakers. It's really an honor. Thank you. Sorry, I have no conflicts to declare. During the next few minutes, I would like to share with you a brief introduction to this entity and then proceed to review a few of the salient studies and evidence supporting the alternatives for medical management of this condition, PPIs, diet, or topical steroids, and end with some consideration regarding maintenance and long-term therapy, and also obviously some conclusions. So this is a bit for training purposes. I know most of you know all of this, but EOE is a chronic immune-mediated clinical pathological condition characterized clinically by symptoms of esophageal dysfunction and histologically by finding more than 15 eosinophils per high power field in the esophageal biopsies. The first cases were described in the late 1970s, and it was defined as a distinct entity in the early 90s. its incidence has increased over the last 2 decades. And actually today, eosinophilic esophagitis is considered the most prevalent cause of chronic esophagitis after GORD and the leading cause of dysphagia and food impaction. It can affect all ages with a predominance of males and typically presents in the 4th decade of life. The symptoms are different in very young people than in adults. In children and very young adults, it typically presents with feeding problems, with heartburn or abdominal pain, but in adults, it typically presents more with dysphagia and or food impaction. The diagnosis of EOE, as it is a clinical pathological condition, in addition to the symptoms, we will need to identify eosinophilia in the esophageal biopsies. The endoscopic appearance, as you all know, is quite varied and can range from a normal esophageal mucosa to the findings of edema and whitish exudates, which are inflammatory features, or even find furrows or a multi-ringed appearance and even structures, which is more a fibrosis phenotype. In fact, different characteristic phenotypes have been described as in other GI inflammatory conditions. Complication in this entity is the development of further dysphagia, and in fact, we should consider the objective of therapy not only to control the symptoms, but to prevent the development of further dysphagia and strictures. And now to get on to the topic of today, the medical management of EOE relies basically on 3 possible alternative treatments: PPIs, diet, or topical steroids. So I plan to review the evidence behind these, and I would like you to keep in mind that maybe one or sometimes more than one will be useful for your patient at different times. And if the patient responds, and we'll talk about responsiveness, they can be interchangeable. This complicated figure is taken from a comprehensive meta-analysis including 33 studies, 11 of which were prospective, and included data from 619 patients. The overall clinical response was over 60%, and the histological remission was over 50% for PPI therapy, but with a tendency to find better results amongst prospective studies and better results when the use of PPI was at higher doses and twice daily. Similar results were published in a recent paper, including 630 patients from the European EUROS EOA Connect research group, including data not only from induction of response, but also for maintenance therapy. Clinical remission here was defined, as it should, as a decrease of over 50% in the dysphagia symptom score and was of over 70%. And histological remission, which is achieving a peak eosinophil count of below 15 eosinophils per high power field, was achieved in almost 50% of patients. Actually, the results were even better in patients with inflammatory phenotype and with prolonged treatments. So I hope I've convinced you that PPIs really work. But there is a clinical overlap between GORD and eosinophilic esophagitis. And in fact, most authors admit that in up to 25% of patients, both conditions might coexist. Nevertheless, the relationship between EOE and GORD is quite complex. EOE can lead to secondary reflux due to increased esophageal compliance and dysmotility, causing the secondary reflux. And actually, GORD can also facilitate mucosal injury, decreasing the esophageal barrier, decreasing the epithelial barrier integrity, allowing for antigen exposure and subsequent eosinophilia. And how do actually PPIs work? In this entity, actually, it's not clear. And there is in vitro data that the anti-inflammatory effect of PPIs is unrelated to the acid suppression. But in any case, most experts will start treatment for their EoE patients with PPIs as a good proportion of patients respond. But we will need to verify the histological response. And this we would do after 8 weeks. And we would need to verify that the eosinophil counts decreases below 15. Let's move on to for the evidence for diet. And as EoE is an immune-mediated disease triggered by allergens in our diet, the first attempt for treatment, the first attempt with diet was actually elemental diet, and this was done in children, and they could actually achieve a clinical response of up to 91%. But obviously this is not a practical approach. So the second table shows the attempts that were done to focus on targeted exclusions, which actually were based, as you all know, on allergy testing and prick tests. Now we know that all these tests are not useful or helpful in this condition, and they only achieved a response of around 45% in the best of circumstances. So this is how we came up with the empiric diets. And the 6-food elimination diet was thus empirically proposed, excluding most of the allergenic foods in children. And hence, it is excluding milk, wheat, eggs, soy, but not only soy, other legumes too. And this is important to consider the background diet of the patient in this case. Peanuts, which are the nuts mostly used in America, but in other diets, other nuts would be more important, and seafood. But obviously, a diet that excludes all this is quite restrictive, and it cannot be sustained long term. And this is how a 2-food and a 4-food elimination diet came up. But in any case, we would need to reintroduce the normal diets after this 6-food elimination. And the present diagram is taken from the Chicago group reintroduction protocol, and it is always done, whatever way you decide to do it, we usually always try to start with the foods that are less likely to be triggers. In this case, the foods that are least likely to be triggers are fish and peanuts. Then it would be soy and other legumes and eggs, ending with wheat and milk. However, the key is that after each reintroduction, we should check histologically whether this is actually, we are still keeping the eosinophils before 15. Now, this particular protocol is a bit simplified and saves a couple of endoscopies to the patient, assessing seafood and nuts together and soy and eggs together. But it still takes a long time and quite a few endoscopies to assess what is the ideal diet for a patient in particular. And this is why this is what we call a top-down approach. So this is how we came up with a step-up approach. 2-food elimination diets basically exclude the most prevalent triggers, which are wheat and milk, and 4-food would include soy and eggs. This diagram is taken from a large multi-center study done in Spain, in which I was lucky to take part, well, my patients were, and in which we chose to try this step-up approach. We first excluded wheat and milk, and if we didn't achieve full remission was obviously clinical and histological remission, we proceeded our patients to do the 4-food elimination diet, and if not, then they would progress into the 6-food elimination diet. And we actually achieved full response and remission in over 80% of patients with this approach. It also saved quite a few of endoscopies along the way, as in 44% of patients actually stopped here, and a further 60% were allowed to stop here. And if you want to look at the numbers, we actually saw that most of our patients, as in other groups, were actually triggered, their symptoms were triggered by between 1 and 3 allergens. They didn't really need the 6-food elimination diet. Sorry. Okay, so if we proceed to the evidence of topical steroids, the present forest plot represents the results of the published randomized controlled trials of fluticasone or budesonide with placebo, which both have been used, showing, as you see, slightly better results for budesonide. And in fact, we have a randomized controlled trial between that actually tested swallowed fluticasone from a multi-dose inhaler versus viscous budesonide slurry for 8 weeks. And it actually found a response rate of 64% for fluticasone and 71% for budesonide at 8 weeks, even though, again, there was a tendency for budesonide to be a bit better. The differences were non-significant. Different formulations have been tried: suspension, sprays, and tablets, with a tendency, and when we compare by mode of delivery, with tendency for suspensions to be better than sprays, but better results are achieved by oral dispersible tablets. And so this present figure includes the results of a recent randomized control trial of a specific sublingual oral dispersible 1 milligram tablet of budesonide versus placebo, the famous Gervisa, which showed full remission in 57.6% of patients at 6 weeks. And if the treatment was prolonged to 12 weeks, it got to over 80%. Side effects were found in 10% of patients, in around 10% of patients, and as is expected for all oral steroid formulations, it was mostly oral candidiasis, which can be relatively easily treated and doesn't need to suspend the treatment in most of the patients. The evidence we have for maintenance therapy, as for PPIs and for diet, is limited. But all experts recommend that some form of maintenance therapy is needed in some form or another. And in fact, the key is to adjust the treatment to the individual. And so I'm going to use this algorithm to run an example as what we would do as we would run the treatment in a patient with EoE from induction to remission on. So, for example, this hypothetical patient with symptoms, and once his diagnosis is established, we would recommend treatment with PPIs for 8 weeks to the highest dose that you want to give, because you know that this way you're going to have higher chances of him inducing response. Histological response would then be verified, and if the patient showed full remission, we would recommend to continue on PPIs, obviously titrating the PPIs to the lower dose that you could, but advising to stay on them. Parallel to this, if the patient had symptomatic alterations of his esophageal caliber, and we would identify strictures, we would alongside proceed to endoscopic dilatation. But should the histological comprovation, when we verified whether he had gone into histological remission, we would not assess it, or symptoms persist, I would propose either topical steroids or dietary therapy. And this will depend on the patient. And I would advise to always discuss it with them. In fact, I usually explain the 3 alternatives of treatment, and I always explain them as possible alternatives from the first appointment, and clarify that we may use different approaches at different times in the condition. Trying to identify the food triggers and the ideal diet is something that a young man might not want to initially, but he can consider it down the line. And likewise, a patient that we've already identified the perfect diet for them, and they are following a strict diet, will be more likely to comply with this diet if they can take breaks and it can be relaxed at times. So for example, when they're traveling or when they're going through whatever personal circumstances, the diet can be interrupted and then controlled on steroids, for example. So in conclusion, PPI, diet, and steroids are all possible alternative treatment options for patients. There is a need for maintenance therapy with any, and maybe interchangeable, provided that they are responsive to these. The treatment should be individualized to the patient and to the patient's circumstances. And I must insist that histological response must be verified at each step. And up to now, it's done with gastroscopy and biopsies, but there are many groups using other less invasive solutions, such as string test, or we're going to start thinking about doing cytosponge for this too. And that is all I wanted to say. Back to you, Masi.
Thank you very much, Ines. I think that was an excellent, very practical lecture. And I think has given us a lot of very practical advices for our clinical day-to-day practice. There were quite a few questions, but I think you actually have answered them already in your talk. So one of the questions was, for example, do we need 40 milligrams of omeprazole as a first-line treatment? I think you have said 20 to 40 BD, but you would recommend 40 BD. Any particular time of the day when you recommend the topical steroids to be used by the patient?
Okay, so definitely before going to bed.
Before going to bed, excellent.
And
yeah.
Sometimes, I mean, some groups recommend BD, morning too, but I limit it to the night because I think that's the way. I'd rather make sure that they are compliant.
Yeah, and also because during the night they keep swallowing and then there is no washout from food and drinks.
In fact, I tell them to do it when they are already in bed.
Yeah.
Take it to bed and take it when they are lying down already and they've finished getting up.
The other thing is often in clinical practice, we have patients that say, doctor, you tell me what I have to do. And you try to engage with the patients in the different treatment modalities, but they just want your best advice. So if you have this patient, what is your first line option?
I always start with PPIs. And then I tell them that we have the other two things. I do not discharge them. I keep seeing these patients in a,
And if that patient doesn't respond, then they'll keep saying, doctor, you tell me what to do next.
Then I would tell him, right, we can do diet, but I will need to verify that the diet is working. I always do the step-up approach. I never start with the 6 elimination diet. I have a bad experience with patients complying to it.
So Rami asked, why do you bother about diet if topical steroids have a better percentage of response?
Because they are very young and I want to find a solution that is going to work for them for the next 40 years. And I'm very comfortable at giving budesonide for 40 years.
And do we always need endoscopy to check a remission, or symptoms are just enough?
No, we need to verify the histological remission, unfortunately. I try to limit the number of endoscopies that I do, but we need to do endoscopy at some point.
Correct. I think, you know, this very short discussion has actually given us additional very important points for our day-to-day practice. So with that, in the interest of time, I'm going to stop here. We are 10 minutes behind. So I'm gonna give you time until 11:20. So just 5 minutes comfort break. And then we're gonna be back at 11:20 for our second exciting session on problematic bolus transit. We'll see you shortly. Just give it another minute. Rami, are you ready?
I am ready.
Good. Well, welcome back. I think it's been a truly outstanding first session. We ran a little bit later than time, but I think the discussion after the talk has been so interesting that I think the interest of the education should always come before the interest of time. So we have another very interesting session on the problematic bolus transit. So we're going to focus now mostly on issues related to swallowing. So the key symptom will be the dysphagia, and we're going to tackle some practical aspects in the management of this symptom. So Rami does not need introduction. Is kindly accepted the double commitment for this symposium. So Rami, over to you. You're going to tell us about what to do when the HRM is abnormal, but it's not achalasia. Thank you, Rami, for being with us again.
Thank you very much, and my apologies to the audience having to listen to me and see me twice. I'll start now. I'm going to speak about high-resolution manometry when it's abnormal, but it's not achalasia. But ultimately, there will be a little bit of overlap, which we cannot help. So my disclosures. So before we talk about what is abnormal high-resolution manometry, what is normal high-resolution manometry? What is high-resolution manometry? A catheter with sensors is placed from the nose down to the stomach. It measures pressure in different parts of the esophagus, and it can provide a real-time impression of the segmental character of the esophagus. So pressure is represented as changes in color, and you can see the top of the at the top the pressure. There's the pharynx. Sorry, I lost my cursor. Don't know what happened to my cursor. Then there is the smooth muscle esophagus, and then the lower esophageal sphincter you see relax as the peristalsis progresses. High pressure is red, low pressure or no pressure is blue. So this is what it looks like in health. Now there is a classification of motor disorders, which was initiated in Chicago, and there have been several iterations. We are now on version 3.0. We're finalizing version 4.0. Hopefully, it will be published towards the end of this year. So, what is the basis? I'm having. Okay, so. First, we always start from the bottom. We look at the esophagogastric junction first. Pathology and looking at esophagogastric junction outflow obstruction and achalasia. We then look at major motor disorders, which are looking at the esophageal body. And then we look at minor motor disorders, again within the esophageal body, and we'll define what these are. Everything else is considered normal. So what I'm going to do is start with minor motor disorders. These are hypotensive, fragmented, and frequently failed swallows. Let me take a step back. With regards to symptoms, esophagogastric junction outflow obstruction and major motor disorders, these patients often have symptoms. The minor motor disorders tend to have less symptoms, or they might not be responsible for symptoms. So symptoms are not common. In the major motor disorders and the obstruction patients, we tend to treat the disorder. In the minor motor disorder patients, we tend to treat the symptoms, if at all. So I said we're going to start with minor motor disorders and work our way up. So with regards to finding a minor motor disorder on manometry, this is effectively a good prognostic indicator, because studies have shown that if you just follow these patients up over time, 3/4 of them improve spontaneously, or have very little symptoms. The minor motor disorders basically is patients who have hypotensive motility or big breaks in the motility, or who have some swallows that are effective and some swallows that aren't. Some failed and some don't. And why is this important? Well, if there is a big, if there's a gap in peristalsis, there's more likely to be an incomplete bolus transport. And this, so the wider the gap, the more likely there is the bolus will be held up. And this can be a target for therapy. Now, I've shown this slide earlier. Motility is important. This is what happens in health, while in reflux disease, there is likelihood of breaks in peristalsis and failed peristalsis. So we need to treat reflux as well as the motility disorders in these contexts. We shouldn't just concentrate on one thing. So not uncommonly, reflux is important. And we've shown this several times. We've shown that patients with reflux disease, it's not uncommon for patients to have breaks in peristalsis, breaks in the motility. But what's useful to determine what is ineffective motility versus those that have good underlying motility is to challenge the esophagus, give them not just water swallows, which is the standard for manometry testing, but encourage their esophagus to work harder by giving them solids. And we've shown that in endoscopy negative reflux disease, it's not uncommon for patients to then have a normal motility when they're challenged, while in erosive reflux disease, which is the bottom left, and Barrett's esophagus, which is the right panel, the motility tends to stay fairly poor even when challenged. This study performed in 2006 by Mark Fox showed a concomitant barium swallow whilst doing manometry, and it found that in patients with a big gap in the transition zone, which is the bit between the top third, the bit between the striated muscle and the smooth muscle esophagus, there can be a bolus obstruction when the transition zone is wide. By giving the prokinetic tigacerod for a period of time, repeating the study showed that coordination is improved and the bolus clearance has improved. So prokinetics can work in certain contexts. Unfortunately, tigacerod has been withdrawn, although it was effective. And so we talked briefly about prokinetics earlier, and I'll mention it again later. But what about patients who have a normal motility but have ongoing symptoms? We call these functional dysphagia. It's like functional heartburn, functional dyspepsia. There's functional dysphagia, and these patients have heightened sensitivity to normal eating behavior, and they sense it more and they experience more pathology, and so sometimes visceral analgesics and anxiolytics might be of benefit in this context. And we already mentioned the use of tricyclic antidepressants, etc. Psychological stressors can increase and enhance these symptoms, and their worry about whether or not there's pathology can also enhance their symptoms. So sometimes treating them holistically, targeting their psychosocial comorbidities would be useful. Directed hypnotherapy and cognitive behavioral therapy can help. So in regards to minor motor disorders, so in other words, frequent failed swallows, hypocontraction, fragmented peristalsis, these patients, not all of them require treatment. Sometimes they are just findings that you see on manometry when you're actually doing it prior to pH testing. We don't, if they're not complaining of dysphagia, if the symptoms are not reproduced at the time of the motility, it's unlikely that they require any therapy. We normally need to reassure them. You can consider prokinetics if you want to treat them. You can consider neuromodulating agents. So that aside, let's now concentrate on esophagogastric junction pathology. Now, I promised I'm not going to speak about achalasia, so I'm going to leave that to Oliver and company. But there are other causes of obstruction. We need to always exclude mucosal and structural pathology. These patients should not be coming for manometry. Peptic strictures, eosinophilic esophagitis, rings, and obstruction, Schatzky rings, submucosal lesions, a cancer. These things should not. These should be treated as one would when they find a fibrotic stricture or cancer or eosinophilic esophagitis, as per routine. And if you do find obstruction in this on manometry, we should recommend and advise that a recent endoscopy should have been undertaken. But there is another outflow obstruction pathology, and that is esophagogastric junction outflow obstruction. This is a condition that used to be called variant achalasia. It is when peristalsis is normal, but obstruction occurs. There's a non-relaxing element to the lower esophageal sphincter. Now, we see this very often, and it's not uncommon. In fact, it's more common than achalasia. But what is real and what requires therapy? Now, we've just last week had this paper approved in the American Journal of Gastro, so it's in press. We looked at 121 patients over 4 years with esophagogastric junction outflow obstruction. 97 of them had functional obstruction, 18 had structural pathology, which we addressed separately. Of those, 8 had opiate-induced obstruction. 48 were considered to be spurious, were considered to be artifact, or declined therapy or did not require therapy. 29 moved on to having achalasia-like therapy. So how do you differentiate between these? Well, we find that using provocative testing, providing solid swallows, free drinking during the manometry study is the most important and sensitive test and technique to identify these patients, rather than the standard 5 ml water swallows or even barium. And then we can proceed with treating them. So these are the treatment options. Pharmacotherapy, well, we can always try with nitrates and calcium channel blockers, but usually in the esophagogastric junction outflow obstruction cohort, we tend to move on to the next level. Botulinum toxin is very common, pneumatic dilatation as well. So botulinum toxin, much of this data is from achalasia. I will not dwell on it, but it is easy, it's safe, 2/3 improve for a brief period of time. The downside is that sometimes they can get chest pain and you need repeated procedures. It is very common in patients with esophagogastric junction outflow obstruction of an unknown cause to have a go at injecting Botox. Generally tends to be safe. Pneumatic dilatation can also be offered, just like with achalasia. Day case, normally we use a Rigiflex dilator, non-compliant balloon, to efface the esophagogastric junction. There's a 2 to 4% risk of perforation. We need to just inform the patient of that risk. There is no study specifically looking at esophagogastric junction outflow obstruction, but from our cohort, the patients who had the procedure undertaken did very well. So that's it for the esophagogastric junction outflow obstruction. Now we move on to the esophageal body itself, and we can look at what's called major motor disorders. These are patients with extreme hypercontractions, spasms, and absent peristalsis. So absent peristalsis implies that patients have no motility at all. So throughout, there is no peristalsis. This is not related to the esophagogastric junction. It doesn't mean that they have to have a low pressure OGJ. The hypercontraction, also known as jackhammer esophagus, is hypercontraction extreme. So there is a contraction which is heightened, and there's a cutoff for which we can use to define this. We no longer use the term nutcracker. And there's spasm. Now, spasm is not a simultaneous contraction per se. According to the classification, it is in keeping with what's called a premature contraction. So there needs to be a minimum amount of time between when you swallow and when the peristalsis reaches its end. If it is less than that minimum amount of time, it is considered premature, and that's a definition of spasm. So with aperistalsis, if you take anything from today, it is important to pay attention to this. Aperistalsis does not necessarily mean patients who have aperistalsis need to have further tests undertaken. We should not just stop at 10 swallows of 5 mL of water with manometry and say this patient has aperistalsis. This is because if you wake the patient's esophagus up with solids, it's not uncommon for you to see peristalsis. And in this context, for example, this patient had no movement in the esophagus with 5 mL of water. When we gave him solids, suddenly the esophagus woke up. This is called peristaltic reserve. And when this patient had pH studies and it was positive, and in fact you can see a hiatus hernia there, the patient can move on to having anti-reflux surgery. While if we stopped on the left, the surgeon might be apprehensive. And it is important also, not only in the context of proving normal, it's also important to prove abnormal, because sometimes aperistalsis with a normal lower esophageal sphincter function with small volume water swallows might change if you increase the volumes. And in this context, a patient with a big baggy esophagus, you need to fill the esophagus before you see the obstruction. And in this case, this patient has achalasia, which could have been missed. And we've just published on this as well. So moving on to diffuse esophageal spasm and hypercontraction. So what are the causes of symptoms? It is important because we can use this to target therapy. So impaired bolus transport is most likely to be a major cause. So the bolus doesn't progress and there is symptoms associated with that. Elevated contractions and spasms we presume to be the primary cause, but in fact it's less common to be the cause of your symptoms. Increased wall tension, muscle ischemia, etc. That can occur, but it's primarily the impaired bolus transport that leads to the symptoms. There's a high prevalence of psychological comorbidities, either as a consequence or increasing your sensitivity to the underlying problem. And interestingly, there's also an association with reflux. So it's not uncommon to try to treat reflux first. So, before we move on, there's an important point here. And it's important to differentiate between type 3 achalasia and diffuse esophageal spasm. Both have premature contractions, in other words, spasm, but in type 3 achalasia, there's also obstruction. And while in diffuse esophageal spasm, the lower esophageal sphincter is normal. It's important to differentiate because the treatments are different. In type 3 achalasia, you have to include the esophagogastric junction in whatever treatment you're giving, while in diffuse esophageal spasm, you don't. Also, it's important to comment that opiates can reproduce any form of hypercontraction within the esophageal body or the lower esophageal sphincter. We've already seen in the esophagogastric junction outflow obstruction paper that opiates can induce that effect. It can also lead to spasm and hypercontraction. So we need to be very clear that the patients who we're dealing with haven't had opiates or are not taking them over the counter. They have a long effect even when stopped. How do you treat these patients? Well, in many cases, you don't need to do anything. 1 in 3 patients tend to improve spontaneously over time. So reassurance after doing an endoscopy, proving that there's nothing mucosal, and barium swallow to prove that there's nothing structural. Often just reassurance is enough, and treating reflux. Lifestyle changes, dietary manipulation by encouraging patients to eat soft foods, have a sip of water after every few bites, avoiding procholinergic agents such as coffee, caffeine, and reducing visceral sensitivity by reducing fatty foods, and also reducing stress. As I said earlier, there's an association of these disorders with reflux, interestingly, and patients who present with non-cardiac chest pain after having mucosal and structural pathology excluded need to have a course of PPIs. That is, we don't know whether the reflux can lead to chest pain and be interpreted as chest pain, or if it can lead to chest pain in and of itself. But PPIs can often and sometimes help on their own. And it's only when patients are refractory to this should we then move on to doing high resolution manometry. Nitrates have been used for many years. Nitrates reduce contraction amplitude, promote normal peristalsis, increase duration of peristalsis. They reduce symptoms, and they are best used in patients who have no reflux disease. What's advised is that you try a GTN spray if it helps the esophagus, they need to ignore the side effects of headache, etc. If it helps the esophageal symptoms, that encourages you to use longer acting nitrates like isosorbide or isosorbide dinitrate or mononitrate. But one thing that's interesting is, unfortunately, I don't have my cursor anymore, is look at all the dates of these studies. These are all old studies. So there haven't been any new studies to look at this. Calcium channel blockers, again, another nitrate donor, that can lead to to reduction in lower esophageal sphincter pressures and contractility within the esophageal body. If you are going to use a calcium channel blocker, I'd advise that you start with nifedipine because it tends to work better than diltiazem, slow release nifedipine, for example. But there is a problem with tachyphylaxis, and so you might have to have breaks in the dosing. Again, look at all the dates. These are all old studies. And of course, there are side effects. This is probably the best and of the drugs. It is there are more recent studies, more recent papers. Viagra. It reduces lower esophageal sphincter resting pressure. It prolongs duration of the lower esophageal sphincter relaxation, and it reduces contractions. It also improves symptoms. We shown this in 2007 when looking at patients with focal spasms and pain, which was reproduced at the time of the motility. These patients were then given, these are little old ladies, by the way, so they were given sildenafil, and you can see that the motility improved and the symptoms resolved. And the interesting thing here is that sildenafil is not a nitrate donor. It increases and enhances endogenous nitric oxide so that it is used where it's necessary. But of course, the problem here is that it's expensive and GPs don't like prescribing it. Botox can be used in esophageal body hypercontraction. So in this, this is the most recent randomized controlled trial, or I think it's one of the two most recent ones. And what it's interesting, what it shows is that Botox significantly improves symptoms of dysphagia compared to placebo, but it does not improve chest pain, regurgitation, or heartburn. So the idea here is that if you have hypercontraction or spasm and you have dysphagia, Botox is a good idea. If you have other symptoms, probably Botox is not going to be it might not work. And you need to remind patients that sometimes they can also experience chest pain as a consequence of the Botox, at least for the first 24 hours. This is this ESG guideline has just been published. I'd advise you to seek it out. It's almost the majority of what I said today is on there with regards to therapy. I just put this up because I wanted to comment on POEM, because I'm sure someone's going to ask that. POEM in hypercontraction, in spasm events, etc. There are no comparative trials looking at this. Blinding obviously is not possible. All the studies are cohort studies looking mainly in the short term, and it's subjective responses that are analyzed rather than objective ones. And there's considerable publication bias. So, many of these disorders are relatively benign. Certainly, they should not be. You should not be doing any invasive therapy if the study has not confirmed during manometry that symptoms are being reproduced at the time. Because POEM, as you can imagine, is irreversible. Once you've done it, that's it. And the patients who we have proceeded to doing POEM in our institution who had hypercontraction are the ones who responded least well. So, in conclusion, ladies and gentlemen, history is key. We need to ask the patient, what is the problem? What are the symptoms? Do not just go by manometry findings. We find a lot of interesting stuff on manometry that might not be relevant. So we need to determine what is the problem, what is the history, and try and reproduce that problem during manometry in order to determine what the motility disorder is. Don't treat the manometry, treat the patient. You need to exclude structural and mucosal pathology first. So patients who come to manometry having never had endoscopy or not had a recent endoscopy should be rejected and should go back to having another endoscopy. I encourage what I call multi-layer testing. Don't stick to just one tool. High resolution manometry, water swallows, solids, free drinking, add barium, add endoscopy, take biopsies. And when you're doing the manometry, you need to subtype the motility disorder, subtype the achalasia, subtype the hypercontraction or the spasm prove that there is no opiate use. Treat conservatively first. Don't jump straight to POEM. Reassure the patient and consider PPI therapy, medical therapy, neuromodulating agents. When we are going to consider endoscopic therapy, please discuss the risks with the patients. Thank you very much. And I'm just going to plug these two meetings in one more time. Thank you so much.
Thank you, Rami. I think this was a very comprehensive lecture on a topic which is difficult because often does represent a clinical conundrum, but it's actually a lot of our practice because if we compare the incidence of this minor or non-achalasia motility disorders is higher than the achalasia in itself. So in terms of food challenge during the manometry, what is your preference? What do you use in a clinical practice?
So we never give patients water swallows alone. In our institution, and I think our amazing physiologists are on the line, all of our patients receive 5 ml water swallows because this is standard. And then we move on to giving them a cup of water to drink freely. And then we give them a bowl of rice. And if we are looking at postprandial symptoms, we wait and we observe. If they say my symptoms occur when I have a chicken curry, they bring a chicken curry. So nice. The aim here is to chase the symptom. And we don't just look at the trace, we chase the symptom and we analyze and we just determine what motility disorder is occurring at the time the symptoms occurring.
With regards to botulinum toxin, which is very easy to apply for us endoscopists, but is controversial. Can I just ask you a couple of questions? Does administration of Botox interfere with subsequent treatment, for example, in a patient with obstructive outlet disorder? Does it interfere with the subsequent dilatation, for example?
So the ESGA guidelines suggest it doesn't. The studies that are in the literature are variable. Some suggest it can cause fibrosis, some suggest it doesn't do anything. From our experience, the only 2 patients we failed to even create a tunnel in from POEM are the ones who have had Botox. We know also from the surgeons that there is a difference in the way they operate when Botox has been used first. I personally don't follow the guidelines and give Botox in a circumferential manner. If there's a possibility someone might be considered for POEM, I give the Botox on the opposite side of the esophagus so that the POEM side is free. Whether or not that helps, I don't know.
Okay, so which one would be the opposite side?
So 3 o'clock position is normally when where we do a POEM tunnel. Oliver or I'm sure we'll extrapolate. But so I would put the Botox at 9 o'clock position. This is not evidence-based, it's just Rami practice.
What about esophageal body Botox in patient with diffuse esophageal spasm?
Similar. We need to be sure that this diffuse esophageal spasm is not type 3 achalasia. So we need to give the patient all the benefit to try and prove that the esophageal junction is not obstructed by giving solids, by giving free drinking, by doing a timed barium swallow, doing everything possible. Because in this context, we need to determine whether we should address the lower esophageal sphincter in whatever therapy you're doing, Botox, POEM, myotomy, whatever.
Excellent. Well, Rami, thank you so much for being with us for these 2 lectures today. I guess I will let you free to go to your other meeting, or feel free to stay with us until you have time, weekend. So we're going to move on with the next topic, which is achalasia. We are going to have 2 talks on achalasia. The first one by Oliver Peck, who is probably not needing so much of introduction, but I'm going to spend a couple of lines for him. He's one of the leader endoscopists in the management of esophageal diseases. He trained in Erlangen, then spent some time in Wiesbaden with Christian L. and produced some of the seminal papers in the endoscopic management of Barrett's esophagus, and is now a busy head in a very large unit in Regensburg. We were chatting yesterday. He's boss also of the infectious disease department in Regensburg, so I'm sure he's got very busy time these days. But let me just say thanks, Oliver, for being with us. You're going to give 2 lectures today. The first one is on achalasia and endoscopic management. Thank you so much, Oliver, for being with us.
Thank you, Masi, for the kind introduction and for inviting me to this meeting. Unfortunately, we don't meet in person, but perhaps next year. So my topic is achalasia. I can manage it endoscopically, and you heard a lot about manometry, and those are the typical high resolution manometry images you can see on the right side when you have an achalasia. There are different types of achalasia. You have type 1 achalasia. You can see here on the left side, upper row, type 2 achalasia, when there is some pressurization in the esophagus, but you have this outflow problem here, so the sphincter does not relax. And then you have the type 3 achalasia with high pressure here in the tubular esophagus. And you have to perform high resolution manometry before you go for endoscopic treatment, because you really want to know what type of achalasia you have. So regarding the achalasia treatment, the therapeutic options until 2010 were laparoscopic halasmyotomy with fundoplication, mostly door fundoplication, then pneumatic dilatation, and the Botox injection. You heard about that. And having a look at the data regarding Botox and dilatation, up to that time, recurrence after 12 months, the Botox was significantly worse than the dilatation, and also the improvement of symptoms was better after dilatation. And you heard about that already. When Botox is injected, sometimes subsequent therapy might be impaired. So there are data that, for example, laparoscopic myotomy after Botox injection has a higher complication rate. And also you heard about the problems of Botox and POEM. So when having a look at dilatation, so this is I think the standard treatment, or was the standard treatment for many, many years. And there is one large retrospective series from England comparing PD with halamyotomy. And this was published last year, and it was a retrospective series over 10 years. And so the definition of this series of a treatment failure was when the same treatment had to be repeated over time, but 3 dilatations were allowed in this study, and or when there was a change of treatment to another treatment regime. And the documentation of the complications was up to 30 days after treatment. So a large number of patients were included in this study, almost 7,000 patients. And the treatment was in almost 5,000 patients, dilatation and HELA in 2,200 patients. There was a quite high perforation rate of 1.6%, but I think this is realistic. So also in other studies, you find perforation rates of 0.5 to 1.5%. So I think this is a quite realistic perforation rate. And the mortality of both treatments, like HELA, was 0%, so it's a very safe treatment. But dilatation, it was 2%, and especially when there was a perforation after dilatation, then there was a high mortality. So having a look at the treatment failure, you can see here the upper line, so the cumulative incidence of treatment failure. The upper line is halamyotomy, and it performed worse than dilatation over time. here time to failure in years. So after 6, 8, and 10 years, dilatation did better than the Heller myotomy. So in 2010, POEM, the paraoral endoscopic myotomy, was introduced, and having a look at the technique is, you all know it, I think. You perform an incision in the mid of the esophagus and then tunnel down in the submucous layer to the sphincter, and then perform the myotomy, a long myotomy of the inner muscular ring muscle, and then close the tunnel again with clips. And those are some images. I think those are images from our first patient in 2014, where we started with POEM. You can see the incision of the tunnel. Then you perform the tunnel here. You see this long tunnel in the submucosa. Then you do the muscle incision with a knife, and then at the end you close the tunnel with clips. So the question now is, which technique is the best? Is it POEM? Is it a dilatation? Or is it Heller? And we are happy that we now have some really good studies comparing those techniques. So first of all, we have a quite recently published study comparing POEM with dilatation. This was a prospective, multi-center, randomized trial from Europe, and was published in JAMA last year. And they compared POEM with dilatation. Sorry, I go back. And treatment success was defined here with an Eckert score less 3 or less, and when there was no further treatment and needed, and also when there were no severe complications. And you can have a look here. So the treatment success in the POEM group was significantly better than in the dilatation group. After 2 years of follow-up, the difference was 38%, and it was highly significant. The secondary outcome were also documented and published. And one problem of POEM here, and this is something you can see in all the publications, is reflux. So there were more reflux symptoms in the POEM group compared to the dilatation group, and also more reflux esophagitis was seen, and also there was a higher use of PPI in the POEM group than in the dilatation group. And there was one perforation in the dilatation group in this study. So now we know that POEM has a better outcome for the patient in the long term than dilatation. And now the question is whether POEM or Heller are the better treatment. And this is a prospective randomized trial that also a multi-center trial from Europe that was published last year in the New England Journal. And they compared POEM with Heller's myotomy with a door fundoplication, 112 patients in the POEM group, 109 patients in the fundoplication group, and the primary outcome was quite similar. The treatment success defined as the Eckert score less 2-3 or less, and at 2-year follow-up. And as you can see here, the treatment success was the same in both groups. There was no difference, and this was a non-inferiority trial, and it was significant for non-inferiority. So the both treatment groups performed equal. But having a look at the secondary outcome, you could also see that there was a higher rate of reflux esophagitis at 2 years in the POEM group than in the Heller group, so 44% versus 30%. But there were more complications in the Heller group than in the POEM group, a little bit more than twice as much complications, serious adverse events in the Heller group. So this shows that both treatments have the same effect for the patient regarding the the treatment success regarding the symptoms, but their POEM was associated with more reflux and HELA with more complications. So and also there are some studies out comparing POEM with HELA, so here comparing both in type 3 achalasia, which is a more difficult achalasia type to treat, and you can see here in this cohort study that POEM performed better than the HELA myotomy, especially because you can perform a longer myotomy here, so you can really adjust the myotomy to the spastic segment in the achalasia, which is not possible in the HELA myotomy. And so its POEM was a quicker procedure than HELA myotomy, and also the adverse events were significantly less in the POEM group, and also the results were better in the POEM group compared with HELA myotomy in this special subgroup of achalasia. So the question is, who is the winner at the end? Which treatment should we use? Of course, it's POEM as an endoscopist, I have to say that, and it's a small battle. And I would like to conclude. So we all saw that endoscopic treatment of achalasia is safe and effective. We know that dilatation has a risk of a small risk of perforation, 1 to 1.5%. The treatment success after POEM is significantly higher than after dilatation. And we now know from this prospective randomized study that POEM and HELA myotomy are equally effective, but POEM has less complications. But we have the problem with reflux. We see more reflux in POEM than in HELA myotomy, and also more reflux in POEM than after dilatation. And POEM seems to be also quite effective in type 3 achalasia, where we don't have so many other effective treatments up to now. And as I said, the problem of POEM seems to be the reflux, which is more often than in the other procedures or other treatments I showed you. So thank you very much for listening to this talk.
Thank you, Oliver, also for sticking to time. That was a very clear and effective presentation. Obviously, I tend to agree with your conclusions, but I think actually, because I know that you're gonna stick around with us for a little while, so what I would rather do is to go to Giovanni's presentation and then have questions as a debate at the end of the two talks. I hope it's okay for you.
Yes, of course.
Yeah, so so we are gonna now switch to the surgical approach, and we're gonna see whether Giovanni will convince us that we should rather refer to surgeons, patients with achalasia. Giovanni has been with us also in the morning session, so no need for introduction, and looking forward to your talk now, Giovanni. Thank you very much.
Thank you, Massimo, for the invitation. And this is my second speech, so everybody knows what the spaghetti connection means. So I don't have any conflict of interest. And before starting to explain the reason why I think that surgery is still a reasonable approach to achalasia, let me make some statements. The first are that there is no cure for achalasia, and all treatments are palliative. And most patients with achalasia will experience more than one treatment in their lifespan. And it is very difficult to define what's a failure of a therapy is, because we do not have any patient-reported outcome or any validated questionnaire to assess the outcome of any treatment. Even the ECA score was never validated as a tool for evaluating the outcome. And in daily practice, clinical judgment is used. We can use timed barium swallow, but it is not widely used. So the second one is that this dualistic or black and white definition between which are the therapies of the endoscopist and of the surgeons are, I mean, it's quite strange to me, because there are poem, for instance, in the United States is performed mostly by surgeons, and even in continental Europe, there are surgeons that are performing poem. So why should I recommend laparoscopic myotomy for achalasia patients? There are some pros, and it is a time-honored one-shot procedure. It is effective in all types of achalasia. It is effective in both young and old patients. There is a moderate risk of reflux, but it is widely available and is well standardized.
Sorry, Giovanni, can I just interrupt you? I think your slides are not going at the moment, so you're still with your introductory slide. Yeah. If you go on presentation mode.
Yep. I am that. Do you see that?
We can see slide number 5, but it looks like you're still on the non-presentation mode.
Okay, let me see.
Oh, you might need to.
On my screen is in the presentation mode, but
I'm sorry. Maybe you can try resharing the screen, if that's okay.
So new share. Okay.
Oh, so if it's okay, we'll stop the sharing, and if you can try it again, then I think it might work. Thank you. Oh, that's great.
I think it works now.
Okay, sorry about that. In my computer was working, so I was saying that the reason why I should recommend LHM for achalasia patients is that it's a time-honored one-shot procedure, is effective in all types of achalasia, is effective in both young and old patients. It carries a moderate risk of reflux. It is widely available and well standardized. Against it, there is the patient preference, but we will discuss that later on. So let's compare now laparoscopic myotomy and pneumatic dilatation. Interestingly, there are 5 randomized controlled trials that are published in 8 articles. 2 articles are reported up to date with a follow-up up to 5 years, and there is a double publication. And there are 10 meta-analyses on these 5 randomized trials. In these randomized trials, 5 different scores to assess the outcome were used: the Ecker, the Watson, Van Trapp, and Dellemans, the Demister score, the achalasia severity questionnaire. So it's not easy to interpret the result of this. Anyway, the 2 best randomized trials reporting the outcome in 5 years are the Christoia from Canada and the European trial, the late results by Monand, was published in GUT a couple of years ago. And you see here that both studies, both randomized trials, shows that laparoscopic myotomy and pneumatic dilatation has similar results at 5 years. Sorry. Okay. If you look at to the meta-analysis, there is a little in favor of a laparoscopic myotomy, both in the first one by Agobi and in the second one by Schoenberg, that is a network meta-analysis. And more or less, they favor more laparoscopic myotomy. In a subgroup of patients, or in sub-analysis of the European trial, you see that patients, even patients with type 3 achalasia, do quite good with 85% of success rate with achalasia, and they don't do quite well with pneumatic dilatation. And laparoscopic myotomy is better in patients in young patients with less than 40 years. What about in UK? Some of these studies have been reported by Oliver, and there are two studies with two different periods. The first one from 2001 to 2012, reporting the data from the hospital episode statistics, and the second one is the study that have been already cited. And you see that these two studies, in which more or less the dilatation, the number of dilatation and the number of Heller myotomy were the same, give us completely different results. In the study by Markar, surgical myotomy fares better than pneumatic dilatation. In the second one, Heller myotomy is worse than pneumatic dilatation. And why is that? And these different results are explained because there is a complete different definition of failure after pneumatic dilatation. According to Markar, in the dilatation, the failures occur after a primary series of up to 3 dilatation within 2 months. According to Harvey, there are more than 3 pneumatic dilatation, but the first series of a pneumatic dilatation include any procedure within 30 days, and so it means that patient may have had 4 or 5 dilatation during this trial. So what we have learned when comparing pneumatic dilatation and laparoscopic myotomy. If the pneumatic dilatation are sequential, that means they are allowed more than 3 pneumatic dilatation, they have the same success than laparoscopic Heller myotomy. But laparoscopic Heller myotomy is the best one-shot therapy, and if a patient doesn't want to have multiple pneumatic dilatation, we can offer him laparoscopic Heller myotomy. Laparoscopic Heller myotomy is better than pneumatic dilatation in young people, and is better than pneumatic dilatation in type 3 achalasia. So what about laparoscopic Heller myotomy and POEM? And this is the already cited study by Oliver. The results were the same. And there is another study, interesting study, that is a retrospective, but there is a propensity score analysis in 2 high volume centers for achalasia in Italy. And again, POEM and laparoscopic Heller myotomy have the same results. There are no difference. I mean, I disagree with what POEM said. There are no differences in adverse events considered as a leakage, mucosal tear, aspiration, or intervention between POEM and laparoscopic Heller myotomy in both trials. There are 2 large systematic review reporting that in POEM there are about 6% of mild events and 0.5% of severe adverse events. In laparoscopic Heller myotomy, we have any adverse events in about 7%. 1 patient died after the laparoscopic Heller myotomy because of MI, and the major leak was 0.7%. What about POEM versus laparoscopic Heller myotomy in type 3 achalasia? Again, if you look at the Werner trial, the success rate in type 3 achalasia was the same. I admit that there are few patients, 10 patients with type 3 treated with POEM and 9 patients treated with laparoscopic Heller myotomy. But anyway, 83% were free of symptoms after POEM and 78% after laparoscopic Heller myotomy. That is not different. In a systematic review, however, comparing 500 patients with laparoscopic Heller myotomy and 400 with POEM, the clinical success rate for a POEM in type 3 was much better than in laparoscopic Heller myotomy. So there is a question mark, maybe, but it's not proven. POEM is better in a type 3 achalasia. If we look at network meta-analysis that have been recently published in Lancet Gastroenterology, you see that is a little in favor of POEM compared to laparoscopic Heller myotomy. But as it is being pointed out, the Achilles heel of POEM is reflux. And you see that both in a Bernard trial and in a quite a large review, the incidence of after POEM reflux is much higher than after laparoscopic Heller myotomy. You see here, esophagitis is about 30% in POEM versus 80% in Heller. GERD symptoms, again, are 20% in POEM, 10% in Heller, and abnormal acid exposure, 40% after POEM, and 17% after Heller. And this is a quite large systematic review, accounting with 1,500 POEM patients and 2,500 Heller myotomy participants. This is a network meta-analysis we are performing with a group of people working with me. And you see that, again, reflux esophagitis after POEM seems much higher than after laparoscopic Heller myotomy and pneumatic dilatation. So let's go to the last 2 points, the availability of the treatment and the standardization of the treatment. So in England, there are about 332 centers performing laparoscopic Heller myotomy. And if we divide these centers in high volume centers, more than 5.7 patients per year, and in low volume center, less than 5 patients per year, achalasia patients, in any case, the outcome is the same. You see that we have the same number of reintervention in high volume versus low volume centers. And even if we compare cancer center with non-cancer center, the outcome is the same. And this means, and this is the CUSUM risk analysis that's showing that there is no relationship between the number of the operation performed and the reinterventions. So it means that even in centers that are performing very few laparoscopic Heller myotomy, they do a good job. So it means that the operations, the technique is well standardized. On the other hand, what about POEM? If we Google where can I have a peroral esophageal myotomy in UK, or which hospital performed peroral esophageal myotomy in UK, there are only 7 centers come out, and 3 are in London. And the first article published on POEM in UK comes out from, it's only 2 years old, I mean, in 2017. So against the laparoscopic Heller myotomy, there is the patient's preference. And it's true. I mean, POEM is very attractive for patients, especially for young patients. And they perceive POEM as a less invasive procedures and with better aesthetic outcome than laparoscopic Heller myotomy. However, the big question is, shall we trade off 5 to 10 5mm scars in the skin of the belly with a risk of a lifelong reflux disease and esophageal erosions? And this is a big question mark. So in conclusion, achalasia is a chronic disease, and this should be told to the patients. There are no magic bullet that can treat it, and any treatment, including POEM, will have some failures during the years. And the longer the follow-up, the more failures will be observed. POEM results have been overemphasized because of the initial enthusiasm for a new procedures, as always happens, and the short follow-up. It may have better results for type 3, but this is not clearly proven. But remember that patients with type 3 achalasia represents only 10% of all achalasia patients. And reflux remains a substantial side effect of POEM. Laparoscopic alar myotomy is a one-shot, low morbidity therapy, is widely available. It has consistent results, and it is effective and has a good efficacy in any achalasia patients. The addition of an anterior fundoplication prevents gastroesophageal reflux disease in the vast majority of achalasia patients treated by laparoscopic alar myotomy. And so, for the moment, my recommendation is still send the patient to the surgeon. Thank you for your attention.
Thank you, Giovanni, for your interesting presentation, and certainly has given us a lot of food for thoughts and a matter of debate. We've got quite some time for discussion, so I invite Oliver on the floor. Calvin will sort that out. Thank you very much, Calvin. So I think the first issue that was highlighted by Rami on the JAMA paper that was cited by Oliver is the dilatation protocol, which didn't allow for sequential dilatation and considered a subsequent dilatation as a failure of treatment, which is not what we would do in standard clinical practice. Oliver, do you want to comment on this?
I think this is totally true. Usually what we do in clinical practice, we do 1 or 2 dilatations. And then when the patient comes back 2 or 3 years later, then we can repeat it again easily. And usually patients respond quite well to a redilatation. So this is not a one-shot treatment, but it is still a good treatment, and we still use it also. I think it's, at the end, it's very important to discuss all the treatment options you have for the patient, with the patient, and then choose together with him.
So what is your, if you decide to go for a dilatation, what is your practice? And can you give the audience sort of some good practical advices on how to approach the dilatation?
So first we dilate with a 30 millimeter balloon, and then see if the patient gets a relief of symptoms. If not, then we go to 35. And usually that's it then, or repeat another 35 millimeter treatment. We almost never go to 40, but 35 1 or 2 times, usually patients respond quite well.
So you go by symptoms. So if the patient achieves symptomatic remission with 30 millimeters, you do not do a sequential dilatation at 35.
Yes, but we also do a barium swallow and have a look if it really results in an improvement of clearance of the esophagus. Yeah. Okay.
I would like to touch on the issue of reflux after POEM and discuss a little bit about what is the clinical significance within the context of palliative treatment, because Giovanni has clearly said, you know, every treatment for achalasia is a palliative treatment. So is this a real issue, or is just a matter of number? What is the sort of clinical significance of some reflux that can be easily treated with PPI? Giovanni, I would like to have your opinion first, and then Oliver.
Let me say one thing before answering your question about the cost. I did touch that. I have a couple of slides on that, but anyway, the most economical, cheapest treatment is dilatation. And POEM and laparoscopic alar myotomy has more or less the same cost. So if we look only to the cost of the treatment, that could be important issue. Pneumatic dilatation should be the first choice. That said, you know, the problem with the POEM is that it is quite a young new technique, but already there are reports of patients with that developed Barrett after POEM. So the problem of reflux is, I mean, okay, probably 80% of all patients that may be treated with PPI is not a big deal, but some patients will have more severe reflux, and this is and some reports of Barrett's after POEM have been reported in the literature.
Oliver?
So I don't see this a major problem because we can treat most of the patient with PPI, but you still also have, when you have a patient with severe reflux that is not responding well to PPI, you can still send the patient to a fundoplication afterwards. So, but this is a step up approach perhaps. So I never had to do that because usually all my patients responded very well to PPI treatment. But this is something you really have to discuss with the patient in advance. You have to tell him that you have this risk, and if he's willing to take tablets instead of going to surgery, then I think POEM is a very good treatment.
So perhaps this should be included in the consenting phase. And and would that lead to the next question? Should we routinely put patients post-POEM on PPI, or should we just go by symptoms?
So what I usually do is for the healing phase, I put them on PPI, and then for about 1 month or 6 weeks, and then I ask them to stop PPI and see what they do, and if they have no symptoms, perfect. And if they do develop symptoms, reflux symptoms, then start with PPI and try to really go down to the lowest dose where they have no symptoms.
Just a comment, Oliver. Remember that in the perception of pain and of heartburn may be different in patients with aphasia. Yeah. So we have patients that are asymptomatic and they have erosion on their esophagus. Mm-hmm. So it's a tricky, and I'm a little bit concerned to recommend POEM in a very young patients. Although the young patients are those that are more attracted by POEM because they don't like to have a scar, or they perceive it as a less invasive procedure. What I do after surgery, I put the patient on PPI for 2 months and then go down, and at 6 months I always do a pH monitoring. Mm-hmm. And if the patient is okay, fine, it stays without PPI. Otherwise, I will continue to have it.
Okay, let's talk about training. I was impressed by the data by Giovanni, and I know obviously that in the UK there are still a few centers doing POEM compared to Eller. And it is very reassuring that the outcome of low and high volume centers is very similar. Oliver, can you tell us a little bit about the training? You know, what is the learning curve? How many procedures should an endoscopy do before, being considered proficient for POEM?
I think first of all, you in your center, you need to see enough patients with achalasia to start with the treatment, because you need first of all, you need a few patients for training to get your skills, and then also to hold the skills for POEM. So it should be a center where you practice, where you see enough patients with achalasia. How I trained 6 or 7 years ago, I went to a center, watched to Thomas Resch in Hamburg, and watched him doing 2 or 3 POEMs. Then I had the privilege that he came to my center, and he did 2 POEMs with me together. And then I started myself after this training. But it is a quite invasive procedure, and you should really also discuss this with your local surgeon, because when you have a problem, you need his help, and all should be on board. So this is something you should not do on your own in your dark endoscopy room, but you really need the whole team, including your surgeons, on your side.
So how many procedures do you think are needed before proficiency?
I think 20. There are no studies out there, but 20 should be enough that you're quite proficient. But you sometimes really have difficult cases, and even after 50, you could struggle with a very fibrotic submucosa or a very narrow lower sphincter. So, but I think after 20 procedures, you should be quite safe and proficient.
Giovanni, comparative numbers for Heller myotomy in the surgical training?
Well, I tell you, in the European trial, we admitted patient surgeons that have performed 5 laparoscopic Heller myotomy. That probably is low. And in the Bernal trial, if I don't remember if I remember correctly, there were at least 10 or 15 laparoscopic Heller myotomy to be considered an expert surgeon. I think that the upper GI surgeon is able to do that. I mean, it's easy to teach, quite easy to teach and to learn.
Okay, let's talk about failure after POEM and after Heller myotomy. Oliver, failure after endoscopic treatment in general. So obviously we know that if the patient fails with pneumatic dilatation, can progress to POEM. What happens if a patient fails to respond to POEM?
So when you can do a second POEM, for example, on the other side. So when you did an anterior goat, can do a second posterior POEM, and but there's not much data on that. If this really, in how many patients this helps them, and also you can ask or discuss this patient then with your surgeon and send him to laparoscopic Heller myotomy.
Giovanni.
What we do after laparoscopic Heller myotomy and what is recommended in the achalasia guidelines, both by ISD, the ISD achalasia and the European achalasia, after if a Heller fails, the first treatment is a pneumatic dilatation. It works because most likely it's not a complete failure. There are some muscle fibers left there. So if you disrupt them, the patient with 1 or 2 dilatation, there is an improvement in about 70% of the patients, and it's nice. And I think that this is a reasonable approach also for POEM. If this fails, in my opinion, POEM is better than a redo myotomy, Heller myotomy. So if the patient after 2 or 3 dilatation is still symptomatic, I ask a colleague performing POEM to visit the patient and performing, if possible, a POEM. Because one of the good indication for POEM is redo failure after Heller myotomy, because redo Heller is not a simple operation. There are some risks, and entering and performing a myotomy from another side could be a good idea.
And just very last quick question, Giovanni. When you talk about dilatation after Heller, is this with the 20 millimeter balloon or with the Rigiflex?
No. Forget 20 millimeter balloons. It doesn't work. Not before, not after. No. We start with a 30 or 35 millimeters balloon, and we progress to 35, 40 according to the thing. And the protocol is the same that we have used on the European trial. So up to 6 psi for 1 minute, and then again for the second minute, say 6 psi.
Okay, well, I think that was a very good debate, and I think we had very balanced views from very expert in the fields. I think POEM is emerging, is proving to be an effective treatment, but obviously still an early treatment. It is an option for patients, whereas Heller myotomy is very established, can be effectively done by the majority of the surgeons. But I think the other thing that, pneumatic dilatation does come up with an effective treatment. So for those who might not have access to POEM and the patients might not be wishing to have an operation, pneumatic dilatation remains an effective treatment. I hope that sort of reconcile all the views. And I thank both Oliver and Giovanni for their contribution. And I'm going to now switch gear to another condition that can cause dysphagia. And I would like to introduce Michael Kaminski from Warsaw. Michael is a friend and colleague. I think he's still a rising star, although he's actually an established 360 degrees endoscopist, the lower, upper, everywhere in the luminal tract. He's published seminal papers in polyp detection rate and adenoma detection rate in lower GI, but he's also an excellent endoscopist. Nowadays, he's head of the Cancer Prevention Center in Warsaw and the Oncology Center in Warsaw. And I'm really excited to have him on board for 2 talks today. So the first one will be the last of this session, and he's going to tell us about treatment of that Zenker diverticulum. also known in some place in the world as pharyngeal pouch. Thank you very much, Michael, for being with us, and over to you.
Thank you so much, Massi. Can you hear me well?
Yes, we can.
Okay, then it's perfect. So good afternoon. Thank you for the kind introduction, and thank you for inviting me to join this session on esophageal diseases. I'm mostly involved in the colorectal things, but actually I do quite a lot of both research and also endoscopic activity in the upper GI tract, including esophagus. So I'll try to share my screen and share my presentation. I hope that it will work well. Can you see my presentation right now?
We can see it. Yes, we can see it.
Okay, so my first topic is what do with Zenker's diverticulum. So before we move on to the treatment options for Zenker's diverticulum, I think that we have to understand several things about this disease. First thing that we have to understand is to understand the disease. And we'll start with the anatomy, and this is relatively simple because it's a posterior diverticulum, which is actually a pseudodiverticulum, so it contains mucosa and submucosa only. But the one important thing is it's posterior in here. But the other facts are probably a little bit less known to the let's say general gastroenterologists or endoscopists. So what is the pathophysiology of Zenker? And what is the pathophysiology of origin of symptoms? And I think that it's quite crucial in order to fit it with treatment options. And it was not well understood until, let's say, mid-90s, when it was, thanks to manometry, established that the reason or the pathophysiology of Zenker is reduced compliance of upper esophageal sphincter. So it's not that there is increased tension of upper esophageal sphincter, it's reduced compliance and reduced opening of upper esophageal sphincter, which causes increased intrabolus pressure. And this is quite important because if we want to understand how the symptoms develop in these patients, the common thinking is that the food accumulates in this pouch, Zenker's diverticulum, and then this pouch also compresses esophagus and causes dysphagia and other symptoms. And obviously, compression by the diverticulum is one of the forces to drive symptoms, but probably the more important one is incomplete opening of upper esophageal sphincter and everything which is in here. So the septum and the closure of the esophageal lumen by upper esophageal sphincter. So not diverticulum itself, but the muscle problem. Then the other thing is to understand the symptoms, because we commonly think about Zenker, that Zenker causes dysphagia, and most of the scales which were used, or scores which were used to assess symptoms in Zenker's diverticulum, they were based only on dysphagia. However, there is one recent scale which is called Kotari-Haber score, and this score is dedicated for Zenker's diverticulum, and it may help us to understand the whole variety of symptoms which occurs in patients with Zenker's diverticulum. Obviously, the leading one is dysphagia, but it is followed by regurgitation, hoarseness, cough, halitosis, weight loss, and pneumonia. So this is not such a simple disease with dysphagia only. There is a whole variety of symptoms that we should try to measure in order to understand how effective are our treatment options. And the third thing is to understand the landscape, because in fact we are dealing with very frail patients. And this is on the left side. This is an example of the patient characteristics of patients with Zenker's diverticulum, with a mean age of 73 years, Charlson Comorbidity Index 4, and this is just to remind you what Charlson Comorbidity Index stands for. You can have like 1 point for myocardial infarction and some other comorbidities. So these are really comorbid patients. And the other thing that drives our decisions is a size of Zenker's diverticulum, which on average is around 3 centimeters in size. So what are the treatment options available? I divided them into 3 main groups. And the first group is, let's say, the surgical group. It could be separated in 2 different ones. And the first one is like open cricopharyngeal myotomy with or without diverticulectomy, or endoscopic stapling diverticulostomy. The other option is another standard endoscopic treatment is flexible endoscopic diverticulotomy. And then there is a new kid on the block, which is called Zenker peroral myotomy, which was introduced just 4 years ago. So let's start with the surgical approach. I'm not a surgeon, so I will mention it only briefly, but just to let you understand a little bit better what is being done. Cricopharyngeal myotomy with or without diverticulectomy. Here you can see the Zenker's diverticulum. Here you can see the cricopharyngeal muscle, which you have to cut, and then you have to extend this cut to the muscle layer of esophagus, and then you can cut off the diverticulum, or you can invert it, or you can leave it if it's small. In contrary, endoscopic stapling diverticulostomy, which is mostly done by laryngologists or otorhinolaryngologists, you use the rigid endoscope, and you have to introduce it toward the septum between the Zenker and the esophagus with head or neck overextension, and then you can staple cut and staple the septum. So what is the data behind this approach? There is no good meta-analysis, but there is a relatively nice systematic review which summarizes our knowledge about that. For the open surgery, 41 studies, nearly 3,000 patients, clinical success rates in the range of 90 to 95%, mortality 0.6%, and morbidity around 10%, with a considerable number of significant complications. So it's a high-risk procedure. Whereas endoscopic stapling diverticulostomy, 44 studies, nearly 2,000 patients, clinical success rates slightly lower, around 90%. And on the top of that, there is a problem that let's say at least 5 to 6% of patients, there is a need to convert to open surgery because you cannot access the diverticulum because of the small mouth opening or not enough neck extension and so on. But mortality rate seems to be lower, morbidity rate seems to be lower, though the problem is recurrence after this kind of treatment, which is really infrequent with open surgery. So how can we summarize the surgical approach? What are the pros and cons? Most of the pros arrive from the open surgical option. So high clinical success rate, infrequent recurrence, and it's suitable for any size of Zenker. Whereas the cons for the open surgical approach is high morbidity and mortality, which is also associated with open surgery, need for a neck overextension with rigid endoscopy. Rigid endoscopy is also unsuitable for small Zenker's diverticulum, which may cause significant symptoms. there is a risk of dental or recurrent nerve injury, which will be persistent or chronic complication, and there is a need of general anesthesia for this kind of treatment. So how about endoscopic approach? So I will start with the first, flexible endoscopic diverticulotomy, and I want to show you how it looks like. Now we enter the diverticulum. This is the diverticulum, and here you can see the esophageal opening. So at the top of it, you can see that it's quite close. Then we get in, and then on that we introduce the diverticuloscope. Which is the way to expose better the septum. So when you introduce this diverticuloscope, which with one arm in the esophagus, one arm in diverticulum, then you really nicely expose the septum, which is in the middle, and you have full control, and it's safe to cut the septum through. And you cut it like with a needle knife. The problem with this is that you never know how deep to cut. So it's difficult to say when to stop in order to prevent perforation at the bottom of the cut of the septum. But it's relatively straightforward and quick procedure, and you can finalize it by placing a clip on the bottom of the cut. So you cut through the mucosa, submucosa, and cricopharyngeal muscle. The problem is that you do not extend this myotomy further down to the esophageal part of muscle layer. So you cut only cricopharyngeal muscle. So what is the data behind that? There is a meta-analysis of 20 studies, including over 800 patients, which shows high clinical success rates of above 90%, quite considerable number of adverse events, 13%, but only half of them are significant, perforations or emphysema without frank perforation, but it's certainly something to consider when you do treatment of Zenker's diverticulum, and considerable number of recurrences, around 14%, but in some studies it rises even up to 20 to 30%. So what are the pros and cons of flexible endoscopic diverticulotomy? No need for general anesthesia, short procedure time, short recovery time, and it's feasible in frail or high-risk patients. But what are the cons? You do incomplete myotomy. So usually multiple procedures are needed to reach the clinical success. Then you may have also high recurrence rates, high risk of perforation. It is not suitable for small diverticulum, and the treatment is not well standardized between different centers. And then there is this new kid on the block, which is called a Z-POEM, which developed after the POEM procedure for achalasia. Here you can see the Zenker's diverticulum. Here you can see the opening of the esophagus. Initially, the entrance to the submucosal tunnel was done 2 centimeters above the septum. Right now, most of the people are doing this over the septum. So you inject over the septum with saline or gelafusine or something like that. So it's similar to ESD or POEM procedure. Then you use a knife. In this situation, we are using a dual knife. First to cut the mucosa and submucosa. Here you can have the wide opening of the more or less 1.5 centimeters in length of the mucosa overlying the septum. Then what you do, you expose the septum, the muscle septum. On the right side, you can see the muscle septum. And then you continue tunneling on both sides of the septum. So on the Zenker's or diverticular side, which is right in here, and then on the other side, and I will show you right now. Then you inject on the other side, on the esophageal side. Just let me wait a minute, and then by using a cup, we'll enter into the other tunnel. And then we are in the other tunnel, which we extend, and we can extend it far, really way below the diverticular, the bottom of the diverticulum. So what goes next is that after doing all that, we have the septum exposed, and we can cut it through under direct visual control. And we can cut it not only the cricopharyngeal muscle, but we can cut the entire muscle layer, which extends further down toward the longitudinal muscles of esophagus. Therefore, you can really reach a long myotomy, which is usually considered like a matter of success for open surgical myotomy. And then you close the entrance to this tunnel with a couple of clips, usually 4 clips, and then you may complete it. And then the Z poem is completed, and then you have a short summary of data behind Z poem. The first study, international multi-center study, which is summarized in here, 75 patients with clinical success rate of over 90%, slightly longer procedure time of around 15 minutes, and relatively infrequent adverse event, 4 small perforations, which were all treated endoscopically. And also on the right side, this is the data from our study, in which we tested feasibility of Z-poem before running the first randomized trial in the field of Zenker's diverticulum treatment. And we use this Cottary-Hubbard scale, which assesses not only dysphagia, but also other symptoms. And what you can see is that there is really nice symptoms relief after a Z-poem procedure. So what are the pros and cons? With Z-poem, you can have a complete myotomy in single procedure. Probably it will result in lower recurrence rates. Then you can have reduced rate of complications. It is feasible for small Zenker's diverticulum and feasible in small and frail high-risk patients. What are the cons? It again requires general anesthesia. It is slightly longer than a standard flexible septotomy or diverticulotomy, 45-50 minutes. It is more difficult. It is probably limited to treatment-naive patients, and we have really short-term experience. I mean, we were talking that for POEM, we have short-term experience. So for Z-POEM, it is even shorter. So then we move to my summary slide on the treatment options for Zenker's diverticulum. The first thing that I would like you to remember is that Zenker's diverticulum results from reduced compliance or opening of upper esophageal sphincter, which is a bottom line for the treatment of Zenker. And then on the top of that, there is compression by the diverticulum itself. Couple of things or features that you have to take into account is size of the diverticulum, symptoms, comorbidities, and center's experience, because no one size fits all. So we have 3 different options which have some benefits, each of them. The surgical option, high clinical success rates, especially for the open surgery, but it requires general anesthesia associated with high morbidity, and it requires neck hyperextension if you are using rigid endoscope. For flexible endoscopic diverticulotomy, it is quick, no general anesthesia is needed. So you can use it in high-risk patients, but it is suitable only for medium-sized Zenker's diverticulum, and usually multiple sessions are needed. And Z-poem results in complete myotomy, so we expect that there will be less recurrence, but we don't know. You can do small Zenkers in high-risk patients, but there is very little experience as compared to 2 other options. Thank you so much.
Michael, that was a wonderful recap of the treatment options for Zenker diverticulum. And I absolutely loved the videos. You made it look so easy. I hope not everyone will start doing that tomorrow. So I have a couple of questions for you. Primum non nocere used to say the Latin, so we should not do high-risk interventions unless this is absolutely necessary. And you showed us sort of that nice symptom-based questionnaire on how to select patients. But can we go through it a little bit more in detail and see how actually to best select patients for invasive treatment? What is your sort of day-to-day practice in understanding which patients we should treat and which patient we should leave alone?
So for sure, from time to time, you can diagnose Zenker's diverticulum without symptoms or with very little symptoms. And if it's the case, then you should leave it alone and forget about it. I mean, you can mention to the patient that if symptoms develop over time, then may come back to you. But if the Zenker's is asymptomatic, then you should for sure forget about treating that. What does it mean that the Zenker is asymptomatic? If you take into account Cottary-Hubbard score, the score of 3 is around being asymptomatic or symptomatic. So if the patient is above the score of 3, then it's probably the patient is going to benefit from having a procedure. Therefore, if there is only mild dysphagia only for solids and no other symptoms, I mean, there will be no benefit for the patient.
Is there any, for example, dietary change that we can recommend in order to buy some time?
Oh, it's. I think that it's very difficult. Usually, these patients, because the diagnosis is usually delayed. So already when they come to us, therefore I don't think that we can delay the once the symptoms develop. I don't think that we can help them to do anything. I mean, to suggest them a diet. Obviously, some kinds of foods are less tolerated. So like bread or something like that, it's usually it usually stacks. So. So it's not good for these patients. And they also have to learn how to wash the diverticulum with water and how to try to empty it. So you can suggest them to move their body in a way that the diverticulum empties spontaneously. But it's obviously a difficult thing, and I wouldn't wait for a long time because these patients are already old. They may develop aspirational pneumonia and some other symptoms, and they wouldn't get younger over time. So it would be more difficult to treat them afterwards.
So technical question from Oliver Peck. I usually perform Zenker diverticulotomy without diverticulum, and therefore I'm able to treat also small diverticulum, and also can see during diverticulotomy whether the diverticulum disappears.
Yeah, I mean, you can see whether the diverticulum disappears with when you remove a diverticuloscope, and it may be. I mean, there is no. It is not consistent, or there is no agreement with regard to how to do the septotomy. Some people are using just a simple cup and nasogastric tube. We were doing that in the past. I think that with diverticuloscope it is probably faster. The problem is that always, I mean, when you think about the Zenker's, you never know. It's, even if it's even if you can see well, where to cut, because you would like to extend your cut, your myotomy, really deep. This is the thing that is happening with open surgical myotomy, and it is believed that leaving the muscles at the bottom of the Zenker will result in recurrence. So it is similar thing to achalasia.
Yeah, it makes sense. And just a very last quick question. After either the diverticulotomy or the ZPOM, what's the recovery time for these patients?
So it's very quick in terms of, after standard septotomy or diverticulotomy, usually in terms of, this is not under general anesthesia. So usually patients after half an hour are ready to move. ZPOMs we are doing under general anesthesia, but I know that, for example, Alessandro Repriti, he's doing the ZPOMs with slightly different technique, with a hook knife. So he's not making the big tunnels, and he's doing it without general anesthesia and completes it within 20 minutes. So I think that this is evolving option, and I think that we may that it will develop over time.
And so the last question, Giovanni Zaninotto is asking, what about large diverticula, so 6 centimeters or more? Would you be confident to treat them endoscopically?
So with the large, it is believed that they are unsuitable for endoscopic treatment, but this is probably mostly data coming from rigid endoscopy, where you don't have a control, and when you have really large diverticulum, you may be afraid of causing some complications by going too deep into the diverticulum. I'm not doing that for standard like septotomy. I think that it's difficult, but with ZPOM, I treated even a 9 centimeter Zenker diverticulum, which was the largest one, and I felt really confident in treating that.
So do you see for the future the treatment of Zenker diverticulum moving away from the ENT surgical field and becoming a more endoscopic treatment? Honest answer.
I think that it is actually happening, at least in Europe. I know that in US, I'm not sure what is happening on the island, so in UK, but at least in continental Europe, it is happening right now.
Well, I mean, certainly your videos showed a very neat technique, and so I hope more and more people will become proficient in these types of techniques. So that was the end of the second morning session. So it's time to have a break. I think it's been an exciting morning with top quality presentations and very useful discussion. We had solid number of participants in the range of 120, 130. So I hope a lot of people got very good hints to improve their clinical practice. We're going to break for lunch, and we are going to come back at 1:40, so 20 to 2, for the afternoon session on the cancer journey from screening to palliation. So have a good break, everyone, and we'll see you in 40 minutes.
Calvin? Calvin?
Sorry for missing your message, Tara.
Fine. I was just asking you if we'll have to add in the people again, right?
I think it should be okay. I think later on, yeah, more people will come in. Yeah, there you go.
All right.
Yeah, but
Hello.
take a break. Yeah. Hello.
How is everyone?
Let me please let me turn off the YouTube first before we talk. Yeah.
Hi, Tara.
Hiya.
Welcome.
Fiona, we're still on
Alvin.
YouTube. We're still on YouTube. Sorry. Please. Yeah.
Calvin.
Sorry, just a moment. Sorry. Yeah,
I can't hear you.
we're still broadcasting.
You're muted, Massey.
Mute.
Oh, there. Yeah. Warm welcome to everyone to the third and last session of the day. This session will focus on esophageal cancer from screening to palliation. We are going to have a series of talks, 5 talks, touching on many different aspects from screening in patients at risk for esophageal cancer to diagnostic and treatment of early cancer, and then avenues in terms of oncological management and palliation, including dietetical approach in patients with advanced cancer. So it is my great pleasure to introduce the first speaker of this last session, Professor Rebecca Fitzgerald. I think she needs very little introduction, but she's a consultant gastroenterologist, gastroenterologist, yes, at Cambridge University Hospital, and professor of cancer prevention at the University of Cambridge. She has probably made a step change in the early diagnosis and prevention of esophageal cancer that we are living in this current time. This stems from an enormous undertaking that I have been fortunate to be part of and proud to have collaborated to, which is a large randomized trial recently performed in the UK, investigating the cytosponge as a novel technique for diagnosis of Barrett's and potentially early esophageal cancer. So we are very excited to hear about this trial and learn about the lessons that this trial has taught us and how we can implement them in our daily practice. Thank you very much, Rebecca, for being with us, and we're looking forward to your presentation.
Thank you very much, Massey. A great pleasure to give this talk, and I'd like to thank you and all the team for a fantastic agenda that you've put together and all the organisation that goes with it. And it's lovely looking along the names of the attendees. I can see many familiar names there. So thank you very much for joining today. And it's a pleasure to present the results of the BEST3 randomised controlled trial of cytosponge TFF3 to identify Barrett's esophagus, which was a huge team effort, as Massey has mentioned. And so I'd like to start off just by thanking all of you who have been involved. So many of you will be familiar with the cytosponge, but for any of you who are not, this schematic just does a compare and contrast of the cytosponge technology with endoscopy. So the idea behind cytosponge is to have a very easy, straightforward test from the patient's perspective as an alternative to endoscopy that will collect cells from along its passage. So the idea is you swallow the capsule on a string. The capsule will enter the stomach and dissolve over about 7 minutes. Once it's dissolved, a spherical sponge is released from inside the capsule, and then that can be withdrawn over just a few seconds, and it will collect along its passage cells from the cardia along the whole esophagus and the oropharynx. So it's, if you like, a non-targeted panesophageal cell sampling device, where you don't rely on visualizing the esophagus, but simply passaging and sampling everything along the passage. This is just a brief video clip just to explain what I've just put into words. So here's the capsule entering the stomach. That capsule will now dissolve. It's just the warmth of the stomach that does that. It doesn't require a low pH, so the patient can be on acid suppression. Here's the sponge. And now as it's withdrawn, you'll see it's going to collect cells from the cardia along the length of the Barrett's, including Barrett's if it's there, but then the whole squamous esophageal mucosa as well. A bit of respiratory or pharyngeal cells are often collected. And you can see the cells are sort of in clumps as they come off the sponge into the sample. And often we collect above 1 million cells from this kind of sample. Here's a view of what the collected cells look like. This is a preparation which we sort of homogenize the cells to form a pseudo biopsy. So they've been spun down, and you can see the clumps of cells that have come off the cytosponge, including mainly squamous cells, but then glandular cells. And to make the scoring and diagnosis as objective and straightforward as possible, we stain for a biomarker that we ascertained for the intestinal phenotype, the pathonomic phenotype of Barrett's esophagus, highlighted by this TFF3 immunohistochemical stain, that then can be scored in a binary way as negative or positive. So we've done a series of trials to evaluate cytosponge TFF3. The first one, published 10 years ago now, was really designed to look at acceptability and accuracy, and it was in a primary care setting. The second study, BEST2, this was really powered to look at the accuracy of the device. So this was a case control study, cross-sectional cohort study, in which the cases were those with known Barrett's esophagus and the controls were patients referred by their GP into secondary care with reflux symptoms. So if we look at the data from BEST1 and BEST2, just by way of background, and some other data collected from colleagues in Australia and USA, this analysis, meta-analysis, evaluated over 2,600 of procedures. You can see that it's pretty straightforward to swallow this device with a successful swallow in 96.5% of patients. There was one detachment. That's something that people often sort of are concerned about as a potential complication of this procedure. It's an inconvenience more than anything else if the sponge does detach. This was less than 1 in 2,000 chance of that happening. We simply retrieved at endoscopy. One minor pharyngeal bleed that didn't require any intervention in an elderly man on aspirin. The acceptability across all these studies was a median of 6 out of 10. What about the accuracy data? So this comes from the BEST2 trial, 1,100 patients divided into cases and controls. The per protocol sensitivity was 79.9%. It increases with an increasing length of segment, not surprisingly, to 87%, and the specificity, 92.4%. Now, where do we lose the sensitivity? The sensitivity is often those cases where the capsule hasn't reached the top of the stomach, and therefore we haven't sampled the distal esophagus. So if we exclude those cases, then our sensitivity for BEST2 was 94%. Therefore, for future studies and clinical use, we recommend that if the capsule has not sampled the gastric mucosa, which we can tell from the sample because we use the gastric cells as quality control, then we would recommend that you repeat the cytosponge to ensure that you've got a high, what we call a high confidence result. So on that background, we designed BEST3 as a pragmatic multi-site randomized controlled trial in primary care. And the primary endpoint of this study was to ask the question, if you offer cytosponge TFF3 for patients on medication for reflux symptoms in the primary care setting, would that diagnose more cases of Barrett's esophagus than what the GP would ordinarily do? So what I mean by the usual arm, usual care arm, is the GP would give medication for reflux as usual, lifestyle advice if appropriate, and still refer for endoscopy as and when the GP felt necessary. Whereas in the intervention arm, every patient is offered a cytosponge TFF3 test. Now, of course, if they're offered it, they don't have to take up that offer. So we then analyze the data in an intention to treat manner so that we include all of those patients in the intervention arm as having had an offer of cytosponge. We evaluate their results whether or not they actually took up that offer. Who gets an endoscopy in the intervention arm? Well, it's just those patients who test positive on the TFF3 test. Secondary endpoints are the stage of cancer detection. So we're interested to know, can we detect cancer at an earlier stage through cytosponge? Is it safe? Is it acceptable? And what are the health economics of this approach? The study design was randomized. We used 2 different forms of randomization, cluster and patient level. Cluster randomized means that a whole GP practice was randomized into either usual care or offer of cytosponge. Whereas in the patient level randomization, within a given practice, patients are randomized to usual care or cytosponge. I don't want to dwell too much on the details of the data collection, but just briefly to say that we wanted to ensure equity across the study arms. So you might say, well, in the offer of cytosponge, there you're really looking hard for Barrett's esophagus, so you're going to find it more often. So we relied in the data collection on a coded diagnosis of Barrett's esophagus. In other words, it had to have been coded in the medical record as a diagnosis of Barrett's in either the usual care or the intervention arm for us to count it. Any cases that were not coded were not included. So this was a study across England. mainly sites on the eastern side of the country. There was no particular reason for that, it's just the way it worked out, but quite a nice spread of location, and there was a spread in the demographic groups of the practices included. The recruitment flow diagram looks something like this. I'm not going to go through it in huge detail, but 13,657 were identified as participants. They were identified using the GP prescribing record. So these were all patients on acid suppressants for reflux. If they're on acid suppressants as a cover for aspirin or NSAID, then that was excluded. And then they were randomly assigned, as I explained, into either offer of cytosponge or usual care. Now, the proportion who expressed interest at the bottom of this graph here in the offer of cytosponge group was 39% of patients. So this is a letter out of the blue that's come from their GP surgery saying, would you like to take part in this study? The actual number who took part in the end was 24%. So it dropped from 39 to 24% because of scheduling difficulties, or they were ineligible because of being on anticoagulants, for example, or they changed their mind, and so on. And then just another thing to point out from this complicated consort diagram is that 95% successfully swallowed the cytosponge and produced a sample. And all the details are in the Lancet paper if you'd like to read it in more detail. Here's an overview of the demographics. So because the usual care data was anonymized and aggregated, we can't give you the breakdown of every single row of information compared to the intervention arm, where each patient provided individual informed consent. But you can see that there's an age distribution. There's a range in the size of the practices. Medication, most patients were on PPIs as expected. And there was also a range of the socioeconomic groups that the practices involved in the trial. So a good spread and matched across usual care and intervention. First of all, on the safety and adverse events. So the overall adverse event rate was 9%. And it was a range of minor symptoms, the most common being a sore throat. And we recorded that as an adverse event if it required medication or interfered with eating, which occurred in 3.7% of patients. There was one detachment and 2 serious adverse events not thought to be related to the cytosponge, a coincidental myocardial infarction, hernia repair. What about the acceptability data? We asked patients to rate it between 0, meaning completely unacceptable, and 10, completely acceptable. This data was really extraordinary, that the median was 9 with an interquartile range of 8 to 10. And if you look down on the color code to 6 and above, which I would say, is more than neutral, then you can see that 90% of patients found it acceptable. There are a small number of patients who find it really quite unpleasant, but these are truly in the minority. Here we come to the crunch point of the whole trial, the main primary endpoint. So we were interested to know, did we diagnose more cases of Barrett's esophagus if offered the cytosponge compared to usual care? And we found 140 cases of Barrett's in the intervention arm compared to 13 in usual care, which gives a rate ratio of 10.6 when you account for clustering in the randomization, highly statistically significant. Someone asked me what I expected. I was obviously blind to the results, which were processed by the clinical trials unit at King's. I said that I expected we might find 3 times as many in the intervention arm compared to usual care. So I was really quite stunned by this difference. So what did that translate to? So out of 1,654 patients that actually swallowed the cytosponge, 221 or 13% required a confirmatory endoscopy. When we did a confirmatory endoscopy, how often did we find something? So 59% had a positive finding, 127 with Barrett's, 4 with dysplasia, 4 with cancer. So I know there are many endoscopists attending this meeting, and we will know that for many endoscopies that we do, we don't find anything specific. So yes, there are false positives, but I think that this is a really very helpful triage with a very useful positive predictive value of 59%. Where we find a false positive, it's usually because there's intestinal metaplasia at the junction or the cardia, because that's what TFF3 will ascertain. The specificity of cytosponge TFF3 was 93.2% in BEST3. This just shows you the breakdown of the cancer diagnoses. So now I've broken down the offer of cytosponge into two groups, those that actually had it and those that were offered it but declined, and usual care. So you can see the Barrett's, there's no dysplasia on the top, but what I want to draw your attention to is the dysplastic Barrett's, low grade, high grade, stage 1, where we see 8 of those in the cytosponge arm that actually swallowed it, 1 in a patient who was offered cytosponge, but then went off and had an endoscopy before they actually were able to take up the appointment because they were concerned. And in the usual care arm, the cancers that were diagnosed were more advanced, and unfortunately 1 passed away even during the duration of the trial. Although the numbers start to get small here for these important cancer and dysplasia diagnoses, there is a shift towards earlier stage at diagnosis, which I think is very encouraging and obviously what this technology is all about. So from this trial, I think we can say that cytosponge TFF3 is safe and acceptable. It does improve the detection of Barrett's compared with usual management. It can also detect dysplasia and early cancer. I want to spend just a few minutes before take questions, just saying where we are now. So this is an FDA approved and CE marked test. Innovate UK have funded Project Delta, which some of you may have heard about and be taking part in, which is an implementation research project. So this is moving away from just gathering more evidence, but actually how do we fit it into the clinical pathway? How do we make this work in practice? Can this be done? And obviously we still have to publish on the full economics analysis. Briefly about Project Delta, there are 3 main work packages. How do we identify patients at risk in primary care? Should it just be based on their PPI prescription or other risk factors which would help us enrich the population? How do we implement the sponge practically into our practice? And can we use AI to triage the pathology results to make that much more time efficient for the pathologist? The idea is then to develop enhanced NHS clinical pathways that use cytosponge. I've talked about primary care, which was the focus of BEST3, but I think important to mention secondary care, particularly in light of COVID and what's being planned by NHS Innovation. So in secondary care, we foresee that we could use this technology for patients referred from the GP with heartburn predominant symptoms without alarm symptoms to have cytosponge to help triage those that need endoscopy most. And that would be aligned with commissioning priorities for rapid and early cancer diagnosis and reduced waiting times. And of course, this becomes particularly important because of what we've seen in COVID with real restrictions and bottlenecks in endoscopy. The Scottish Government have rolled out cytosponge to help deal with their COVID backlog. They're using it for 2 areas, symptomatic heartburn referrals. Oh, I've lost my slides. I think Oliver's slides have come up suddenly.
I apologize, Rebecca. Could we trouble you to share your screen again, please?
Have you got my screen or not?
Not yet, I'm afraid. Could you share your screen again, please?
So just briefly to finish, the Scottish Government have rolled this out for symptomatic referrals and Barrett's surveillance to meet their COVID backlog. And that is now also being very actively discussed by NHS Innovation. And many of you may have seen a query that's come out to the Cancer Alliances to ask whether your hospital is interested in using cytosponge during the current time for symptomatic cases with heartburn symptoms. The Delta project is also ongoing, and the Delta project also includes using cytosponge for Barrett's surveillance. I haven't talked about that in detail today, but we add additional biomarkers to help us understand the patients with Barrett's at particularly high risk. So this is a very exciting time for cytosponge, a real opportunity, and I'd really be interested to hear what you think and whether you're interested to take part. And if you would like to take part in Project Delta or the NHS Innovation to test this technology for, further, sorry, lost my voice, please let us know. I should, of course, thank a fantastic team without whom this would not have been possible. Many of them listed here, too many to list in by name. An advisory team with PPI involvement, Liz and Charles, many of our trial sites, and thank you if you're one of them, and fantastic funding with support as well. Thank you very much. I'll be very happy to take questions.
Thank you, Rebecca. I hope you have a glass of water nearby. Obviously, I've heard this talk so many times, but each time I find it more and more fascinating and truly impressive work, and the findings even more. So I guess you've touched on the use of cytosponge for surveillance of Barrett's. Michael has asked a little bit more insight into where we are in terms of detection, because there, of course, the issue is detection of dysplasia, not just the Barrett. So how do you envisage this coming along in the next future?
Yeah, I think this is a really key area. And what I think we all want to do in endoscopy is to focus on the patients that need therapy and not the low-risk short segment Barrett's esophagus. And I see the cytosponge as a technology that should be able to help with that. So as well as using TFF3 to check that there are goblet cells, that we have ascertained the Barrett's correctly, we also stain for P53, which is the most prevalent cancer gene-specific mutation. We also asked the pathologist to assess atypia, which is the cytological equivalent of dysplasia. And we use that information together to give a guide for the dysplasia status. We did publish on this a few years ago in Lancet Gastrohepatology. We had some other biomarkers there as part of a risk score, but they are not very clinically practical. But at the moment, for our risk stratification, we're using P53 and atypia, and we're able to give a readout on that, and we're using that as part of Project Delta. We're just in the middle of analysing a much larger patient cohort, which we hope we'll be able to report on soon, which will give you an idea of how accurate that combination is. And we're very hard at work building copy number biomarkers into this offering as well, so that we can give even more accurate risk stratification. So it's a work in progress, but I think we've already made quite good progress.
So there is another question from the floor, which I think is very relevant. What we'll be doing once we get all the new Barrett's diagnosed, and how do we cope them in terms of financial consequences on the NHS?
Yeah, so, I mean, obviously, if you're using it in secondary care, then potentially we should be saving some endoscopy because we're triaging the people that need it more when we have those with heartburn. In primary care, if we do case finding, then yes, we could generate a lot more endoscopy. That's why what we've just discussed with the risk stratification is so crucial. What I would really envisage is that we don't just put everybody with Barrett's into endoscopic surveillance, but we do this additional triage on the cytosponge, and we distinguish between high risk and low risk. And those who are at low risk can hopefully just go into a cytosponge follow-up in, say, 3 or 5 years' time. One of the things we're busy collecting is what do the results over time show with cytosponge? So we haven't really published anything on that yet from our longitudinal samples, but we have quite a few of those now.
So obviously, I mean, one of the things that we have learned from BEST3 is that it's not just about the new patients which are referred to the clinic, but there's a whole bunch of people that are out there having happy treatment with PPI and being at risk. Do you want to comment on this?
Yeah, I mean, that probably is where, if we really want to have an impact on patient survival from esophageal cancer, it's that group we need to find. Because most of our patients, they just never see the light of day. They never get referred. They never have the benefit of a test. And probably, you know, in a way we could, this is going to be very controversial, but put it like this, we could potentially scrap all surveillance, do a one-off proper baseline test, pick up all the people properly with some dysplasia and treat those. If we did that kind of strategy, I'm not suggesting that's what we should do, but we probably would have more of a population impact. So I think, you know, we really need to think hard about that, because at the moment our rate of early diagnosis is low, and most of our patients are advanced and their prognosis is poor.
Yeah, And there is one question about dislodgement or detachment. I think you mentioned it, but you just give us again the rate of detachment of the cytosponge. Just for
so
those.
less than one in 1,000. That's a conservative estimate. Probably no less than 1 in 2,000. It will happen occasionally. I think, you know, with this kind of device, if you do enough of them, it will happen. You could argue that many of these patients should be having endoscopy anyway. The patient will not be distressed by it. They'll be surprised, but they should be mentioned when they're consented. And, you know, you have quite a few hours before they need an endoscopy, because I don't think that sponge is going to go anywhere. And you just remove it very straightforwardly at endoscopy. So it's an inconvenience, obviously. With the manufacturing, we're working with Medtronic, and it's one of their main concerns to keep that rate as low as possible. But I don't think it's a big issue.
Well, Rebecca, thank you very much for joining us for this exciting lecture. I hope you can stay connected and take part to the discussions for the next talk. So it's now time to welcome back Oliver Peck from Regensburg. So he's going to tell us how to optimize the detection of dysplasia and make that surveillance endoscopy more effective and hopefully less of a burden for the patients if we think about thinking of improving our dysplasia detection and be confident about the diagnosis, and then maybe scheduling follow-up endoscopy at later stages. Thank you, Oliver, for being back, and the floor over to you.
Thanks, Masi, and great talk, Rebecca. Is really really amazing results. Yeah, I just want to give a brief overview how I think you should do your Barrett's surveillance. I think this is very important that you do it properly. We all know that there's a high mortality of Barrett's adenocarcinoma. This is old data, but it has not changed a lot in recent years. And there are some data that surveillance really helps to reduce mortality and diagnose those cancers at an earlier stage, because we have this window of opportunity in Barrett's, because it all starts with development of a Barrett's, non-dysplastic Barrett's, and then goes over several steps from low-grade, high-grade, early Barrett's cancer, and then to an advanced Barrett's cancer. And we can treat low-grade with, for example, radiofrequency ablation, and we can treat high-grade dysplasia and early Barrett's cancer with endoscopic resection, EMR or ESD. And we can really help the patients and treat them in that window of opportunity. But we have to diagnose this dysplastic lesions early enough. And that's the reason why we should do surveillance. It is also recommended in all guidelines, also the BSG guidelines, that despite the fact that they are lacking randomized controlled trials, it is recommended in all guidelines to perform surveillance in patients with Barrett's. There is also a systematic review and meta-analysis was published 2 years ago in Gastro, and it has been shown that patients who have surveillance have lower mortality rate, and when there is a patient who had surveillance, and when there's a previous diagnosis of Barrett's esophagus, and also the diagnosis is usually made at an earlier stage of the cancer than those who had no surveillance. So it is there's at least some data showing that this also helps to reduce mortality and diagnose it at the cancer or the lesions at an earlier stage. And also the ESG guidelines, which is the merged guidelines of all European guidelines, recommend surveillance and how should it be performed. It's important to mention that tongue or columnar aligned tongue of in the distal esophagus of less than 1 centimeter is not defined as a Barrett's. So when you have a tongue of so-called Barrett's less than 1 centimeter, should not be called Barrett's, and it could be called an intestinal metaplasia in the distal esophagus, but then you should only have a close look at it, and when there is some irregularity, you can biopsy it, but you don't have to survey those patients, because we know from several studies that the risk of this formerly called ultra short segment Barrett's esophagus is so low, so that those patients don't need surveillance. Surveillance should be performed in patients with a longer extent of Barrett's, longer than 1 centimeter in length. So in this short Barrett's esophagus, from 1 to 3 centimeters every 5 years, and from 3 to 10 centimeters every 3 years. And patients with a longest segment, longer than 10 centimeters of Barrett's, should be referred to an expert center. And it's also important that older patients, older than 75 years, should not have regular surveillance endoscopy when there's a diagnosed Barrett's without any dysplasia. So it's very difficult to find those early lesions, because early neoplastic lesions in Barrett's esophagus are very subtle and really hard to detect sometimes. And in daily practice, most endoscopies hardly see patients with early Barrett's neoplasia. They really rarely see those lesions, and therefore it's quite difficult for them to recognize. So what are the basic principles to detect early Barrett's lesions? First of all, you should take your time to inspect the Barrett's esophagus. You should clean the esophagus before you inspect it. You should take the best endoscope you have. The most modern endoscope you have, with at least high definition optics. Inspect them carefully with white light. Look for subtle abnormalities. You should also switch on your virtual chromoendoscopy, like is it NBI, iScan, or BLI. And you should also biopsy subtle abnormalities, and also you should not forget to retroflex in the stomach to have a close look at the cardia. So this is a short video how you should perform an inspection. So a transparent cap at the distal, at the tip of the endoscope, is very helpful to stabilize your view on the Barrett's mucosa, and you can also flatten out the folds. Here we switch then on, in this case, the BLI mode, and you can see nicely how you really can inspect the mucosa with this cap, stabilize your view, and really have a very close look. We also have, with this endoscope, we can zoom in with optical zoom, and you really nicely can see the Barrett's mucosa and even find small irregularities. You can see here some in the center of this video, this image here, this irregularity. You have more vessels, and the superficial architecture of the mucosa is gone. This is after spraying some acetic acid, and again you can inspect it. So this is the usual Barrett's mucosa when you sprayed some acetic acid over the Barrett's. And then again, do your inspection, close inspection of the, you see I take many pictures to document everything. And again, with the cap, you were able to stabilize your view. And now we come back to this area we just saw with the BLI and magnification, where we saw that there is loss of the superficial pattern. And also there's another the vascular structure is different, and we see here this lesion. This is a very small lesion, and this was a high-grade dysplasia in this patient with long segment Barrett's esophagus. So I think you saw that you really should take your time to really properly inspect the Barrett's, and there's also some evidence for that. This is an old study from Pratik Sharma's group. He showed that when you take more than 1 minute per centimeter of Barrett's esophagus, you significantly find more high-grade dysplasia and early adenocarcinoma than when you spend less than 1 minute per Barrett's, and this was really a large difference in this series. And this also this study shows that also when you take your time and put those patients for surveillance on a dedicated list with a 30 minutes time slot, and that is done by a specialist endoscopist, you find significantly more dysplasia than when you do it in your routine program. Also, it is in the ESGE guidelines that you should use a 1 minute inspection time per centimeter circumferential Barrett's esophagus. This guideline was published 4 years ago. So where to look in Barrett's is also important to know your hotspots, where are most of the dysplasias. And this is a quite old study we published from Wiesbaden 13 years ago now. And we were able to show that most of the dysplastic lesions in Barrett's are between 12 and 3 o'clock. So almost 60% are in this quadrant, and most of them are at 12 o'clock. So when you really have to pay attention at that position. You should look for mucosal and vascular abnormalities. I showed you that in the video, and also I think this is quite easy to diagnose this nodule here, but this is much more difficult. This high-grade dysplasia is perhaps 2 millimeters in diameter, and you can only recognize it because there's an absent mucosal pattern here, destroyed pattern, and you can nicely see it here. And also this small early Barrett's cancer here, it's very difficult to find. Acetic acid staining really helps in this case. So when you have a patient with a Barrett's esophagus like this, it's quite easy to find this lesion here. I think you don't need any advanced imaging, but when you switch on, you can, here in this case, the LCI, you can see this, and after acetic acid staining, it becomes very clear that there is another type 2C cancer on the opposite side of this cancer you just saw easily during white light endoscopy. So this meta-analysis with almost 1,700 patients shows that acetic acid staining is very effective, has a high sensitivity and specificity to diagnose high-grade dysplasia in intramucosal cancer. And I really encourage you to use it every time when you scope a patient with Barrett's esophagus. So it's also easy to learn, which has been shown in this publication, the PREDICT classification from Pradeep Bandari's group. I also was part of this. And so the only thing where you have what you have to look for is the loss of focal acetowhitening. So you spray some acetic acid, then the Barrett's turns whitish, and then you wait for half a minute, and then you see those areas that become reddish are those suspicious areas. And then you have to inspect those areas and look whether you have a mucosal abnormality, and then you nicely can diagnose and identify those dysplastic lesions like you can see here, for example. And in this study, it was nicely shown that it's quite easy to learn. It's a quite complex slide, but it only should show that this was sensitivity and specificity before the PREDICT classification was trained. And then after training, endoscopists and even nurses were able to improve their detection or the sensitivity and specificity to diagnose early Barrett's lesions was significantly improved afterwards. Should you still perform 4-quadrant biopsies according to the Seattle protocol? Yes, I'm afraid you have to do that at the end. So you should take biopsies in the esophagus at several levels, 4 quadrants, like you can see here, and put it in separate containers for every level. And this is the old study where the Seattle protocol comes from. It has shown that when you use the Seattle protocol, then compared to just random biopsies, not according to the protocol, you find more dysplasia and more early cancer. And even today, it is necessary because you can see that even with modern endoscopes, there's still you find not significantly more with modern technology than in previous years. So it's still not time to get rid of the Seattle protocol. How can we improve our detection of Barrett's neoplasia? I think training is everything. I said in the beginning of my talk that the problem is that most endoscopists don't see so many lesions, and so it's quite difficult for them to recognize them. And it has nicely been shown in this gastro paper from last year that it is a training. It's quite easy to train that with a web-based module, the Born module. So you can run videos, and then the system asks you where is you can stop the video in and then show where the lesion is, and then you have to demarcate the lesion and mark where you would biopsy, and then your results are compared with the expert delineation. And this was a study we performed. It was a multi-step validation of this Born Born module, and we had more than 200 endoscopists in 5 countries. There were 25 videos in 4 batches, and after every batch there was a mandatory feedback whether the biopsy was correct, or how much of the lesion did the endoscopist delineate, and how close were you being an expert. And having a look here at this those numbers, you can see that there was an improvement of the endoscopist regarding the detection score, the delineation score, and the expert agreement score with every batch. So you easily, when you use this Born module, which is available online without any charge, then you really can improve your detection and delineation skills. You can find it on different websites, on the UEG website or the Best Academia website. So it's easy to find, and then you can train yourself online. So I want to conclude. How should I do my Barrett's surveillance? The steps I would recommend are: first, clean the esophagus, then careful white light inspection. It's very easy to, very helpful to use a transparent cap, as I showed you. Switch on your virtual chrome endoscopy and inspect the whole Barrett surface again after you had a proper inspection with white light. Then what I usually do is spray some acetic acid and look for the reddish areas and take targeted biopsies of those suspicious lesions. And at the end, you still have to take your 4-quadrant biopsies. I'm afraid you can't get rid of this at that time. So what will be the future perspectives? There are some future perspectives, but they are not available for prime time, which is artificial intelligence. There are some working modules that might be available in the next years. And also there is this the brush cytology, the WATS, wide sample, wide area brush, sampling brush, which you can use to brush the whole Barrett's, that improves diagnosis, but still this is not available everywhere in Europe, and we still have to wait for that. So I would like to thank you.
Thank you, Oliver. As always, very clear presentation, and with a clear eye on the teaching and the education. Thank you so much. So I have a couple of questions, and I'm also going to pick some questions from the floor. So first of all, you mentioned that the ESG guidelines suggest that we should not survey patients with Barrett's over the age of 75. With the increasing life expectancy and many patients living, and being fit at the age of 80 or even more, do you think this is an absolute recommendation, or we should rather take a more tailored approach based on patient fitness?
Absolutely. So when you have a patient with 75 which is still running a marathon, you of course then should have more surveillance endoscopies. But we all know 60-year-old patients who come in with a wheelchair, then we can stop earlier. So I think it's always, like always in medicine, it's just a recommendation, and I think it is, of course, it has to be tailored to the patient who sits in front of you.
Yeah, the PSG guidelines actually don't have an age cutoff, and I would encourage really to have a patient-tailored approach here.
Yeah.
Then the other question, you're doing a diagnostic endoscopy for investigation of dyspepsia or reflux, and you bump into a 12 centimeter Barrett's with a patient that seems to tolerate not greatly the endoscopy. What would you do?
When
you've
you
got 15 minutes to do this endoscopy, then you have patient.
Then you should stop and reschedule the patient to come back on a specialist and ask the patient to take PPI prior the endoscopy because you don't want to have inflammatory changes, and then you should use at least you should use 30 minutes for that time slot to really inspect those 12 centimeters of Barrett's, because according to the guidelines you should inspect at least 12 minutes or even longer. And when you, at the end, when you have to take quadrant biopsies, this also will take quite a while, and then you will use those 30 minutes. Yeah.
And I think this is a really good point, which I would want to leave with the audience. There's no point in taking 2 biopsies, because then somebody else might review this endoscopy and say, oh, there's no dysplasia, so we can schedule the endoscopy in 3 years. But basically, that 2 biopsies mean nothing. They are completely under diagnosing a potential dysplastic Barrett's. So do you think that we should routinely use acetic acid or rather MBI or BLI? So in a routine approach for all patients with Barrett's esophagus?
That's what I usually do, and I would encourage, because it's quite easy to use. It's cheap and it's quick and it's quite easy to learn. I think it's for those who don't use it very often, advanced imaging techniques like NBI and BLI are more difficult to interpret than acetic acid. That's why I really recommend to use it and get some training, because it's quite easy to get trained. Just watch a few videos on YouTube or wherever, or go to a center where they do it quite often. Then you really know how to use it.
And what about low-grade dysplasia? Can image enhanced techniques reliably identify low-grade dysplasia?
No. Usually when you, low-grade dysplasia is very difficult, and it's usually picked up during quadrant biopsies. What my experience is, when you see a lesion and it's on biopsy, it's low-grade, and then when you resect it, it's usually high-grade or cancer. When you have a lesion that is clearly visible and you have only low-grade on biopsy, then you still should resect it and should not go for RFA.
And how do you clean your esophagus? This was a question from the floor. Any particular solution or just water?
Usually just water is enough. When you have a lot of mucus on it, you can use some acetylcysteine, but usually water is enough.
So that patient with 12 centimeter Barrett's then goes on to having the Seattle protocol biopsies. It's non-dysplastic. When do you get him back?
Yeah, there are different guidelines. So in Germany, we have the guidelines that the patient should come back 1 year later, and then we go to the recommended ESG intervals. Because usually when you diagnose a dysplasia, it's usually during it's usually there, and when you miss it during the ERS, your first endoscopy, you might pick it up 1 year later. As I said at the beginning, it's quite difficult to identify those lesions. That's why we in Germany have this guideline to the patient should come back 1 year later and then have 3 or 5 years intervals. According to the ESG guidelines, the patient should come back 2 or 3 years later.
Okay, I am sure that our audience is now much more comfortable in managing endoscopically the diagnosis and surveillance of patients with Barrett's esophagus. Thank you so much, Oliver, for your very clear presentation and for answering the questions very clearly. So we've now got this patient with early neoplasia, and we have to sort out the treatment. So Michael is back here with us and is going to tell us about the endoscopic management of early esophageal neoplasia, when and how to resect. Thank you, Michael, for coming back, and stay with us.
Hi, hello. Can you hear me well?
Yes, very well.
Okay, I'll try to share my screen. Can you see my presentation right now?
All good.
All good? Okay, then it's perfect. So thank you very much for setting the landscape for me, because once you detect the lesion, you have to figure out what to do with the lesion that you detected. And obviously, as Rebecca mentioned beforehand, you want to make it less burdensome for our patients. So you would like to resect it endoscopically instead of doing surgery. So my task is to talk you when and how to resect. And when I thought about it, I divided into by thinking about when. I want to talk to you about lesion characterization and delineation, and also oncological safety after endoscopic removal. And when I refer to how, I will discuss with you endoscopic treatment techniques, and also complications and long-term results of endoscopic and surgical treatment. This is not so commonly done. Usually we are seeing only data from endoscopy, but I think that we should compare the endoscopic resection data with surgical data, because this is what we are competing with. So to start with when, obviously we can treat endoscopically precancerous lesions, but also cancers which are limited to mucosa or superficially invading submucosa, but those with minimal risk of lymph node metastasis. And in order to make it, we have to have a really careful assessment before endoscopic treatment. And honestly speaking, this careful assessment is based mostly on endoscopy. Therefore, we have to delineate the lesion. We have to assess morphology using Paris classification. This is not so common, and we are not generally so good in assessing Paris classification. Then we have to go a little bit deeper and try to use our advanced imaging skills to assess surface and vascular pattern, and then consider some additional imaging, especially when considering that the lesion may be invasive in terms of deeper submucosal invasion. And obviously what we should bear in mind when we embark on endoscopy action is that after treatment, we really have to have the highest quality of histopathology possible. So first thing about Paris classification and assessing the lesion morphology. And when we think about esophageal lesions, we should bear in mind that when we see a sessile lesion or excavated lesion, these kind of lesions will have increased risk of deep submucosal invasions. And these lesions are usually not suitable for endoscopic resection. So we are aiming at this flat, superficially elevated or superficially depressed lesions. This is what we are looking for and what we can consider for endoscopic resection. So once we assess the lesion, then we have to use the advanced imaging before resection, and I will talk both on the squamous cell cancer and Barrett's adenocarcinoma. So for squamous cell cancer, it is useful to use Japanese Esophageal Society classification and assess the vascular pattern of the lesion with so-called intrapapillary capillary loops, so IPCLs. So these IPCLs are small vessels which are visible on the surface of esophagus even without magnification. You can assess it simply with by zooming slightly or by using dual focus, and you can somehow predict invasion depth. So what you are looking at is when you see these thickened vessels, which are either loop-like or without loop-like formation, this is something which is suitable for endoscopic resection. But when you see these highly dilated vessels, this will, and you can see it on this corresponding view, with this caliber, you would predict that this lesion will be deeply submucosal or even deeper cancer. So this is not suitable for endoscopic resection, because obviously the final result of the depth of invasion will come from histopathologists, but you have to somehow guess what you are dealing with, and this is really useful to make not a blind guess, but a guess based on some evidence. And then I would like to show you some example for squamous cell esophageal cancer. So it is a 2B lesion, slightly reddish. We'll encounter it in a moment. It will be clearly demarcated on NBI. You can probably already see it. It is a completely flat lesion in here, not so small. Indeed, this patient has several lesions, but I would like to, let's make it a little bit quicker. Now we switch to narrowband imaging, and here you can see the lesion. There is a brownish discoloration of the background mucosa. You can clearly delineate this lesion. There is another one over there. And what you can see even without dual focus, that there's near focus, there starts to be seen these IPCLs. And when you come closer, you really easily spot this enlarged intrapapillary capillary loops, which are thickened, but they correspond to the B1 in Japanese Esophageal Society classification. So with regard to Barrett's cancer, it is a little bit more difficult, because when you want to characterize the thing that you are looking at, it's probably, you can use like a Bing classification or the PREDICT classification that was mentioned before. And the Bing classification looks mostly on irregular mucosal or vascular pattern on the surface of Barrett. It is not so useful for prediction of invasion depth. You can more easily delineate the lesion, but it's very difficult with Barrett's to really, based on advanced imaging techniques, to predict the invasion depth. So we base it more on gross morphology than advanced imaging, actually. And here there comes an example of high-grade dysplastic lesion in short Barrett's. Now, after the biopsy, it may be even almost called like irregular Z-line, but it was a short Barrett.
Unfortunately, I think the connection dropped.
Michael, okay, so is it his connection?
Yes, I think he. Oh, okay, there you go.
Michael, welcome back. We can't hear you yet.
Okay.
Okay, we can hear you now.
You can hear me, okay.
Yes.
So I will try to speed it up and right now and show you what we are looking at, and with this lesion. So here you have this lesion, which is like a small depressed Barrett's cancer with irregular mucosal and vascular pattern in here. So this is the lesion that you should look at. So when we come back to the European guidelines on the assessment before endoscopic treatment, and when we think about squamous cell cancer or Barrett's cancer, in fact, the bottom line is endoscopic characterization using Paris, using advanced imaging, and this will mostly guide the decision whether to resect endoscopically or not. And then once you resect it, the thing to consider is also oncological safety, and this will be mostly based on histopathological criteria. Because what you would like to achieve is R0 resection. So you would like to have clear margins, especially horizontal margin, but also lateral margins. Then you should have no well or moderately differentiated cancer without lymphovascular invasion and with a pre-specified cutoff for depth of invasion, because it will relate to the risk of lymph node metastasis. And when you think about squamous cell cancer, Barrett's cancer, or gastroesophageal junction cancer, in fact, when you consider mucosal M1 and M2 squamous cell cancer, or M1, M2, M3 Barrett's cancer, then the risk of lymph node metastasis is pretty low if you take into account, in addition, all the other factors that I mentioned before. But when you think about deeper invasion, it might also be suitable for endoscopic resection for Barrett's and gastroesophageal junction lesion, which are really superficially invading submucosa. Then the risk of lymph node metastasis may be small, providing that all the other parameters are fulfilled. It is not so good, or the risk is not so small for cancers invading muscularis mucosa, so M3, or cancers invading superficially submucosa, because the risk of lymph node metastasis rises to 4–8%, providing that all the other criteria are fulfilled. Therefore, you should do something else to the patient if these criteria are, if the depth of invasion is deeper than M2 for squamous cell cancer. And you can expand this criteria, or consider expanding this criteria for squamous cell cancer, and add on chemoradiotherapy. And this is an emerging thing. So after endoscopic resection, if you have a M3 cancer or SM1 cancer, you should either consider referring the patient for surgery or adding chemoradiotherapy. And this is really an emerging thing. So then when you've already know when to do, then you should consider how to do. And this brings us to indications for endoscopic treatment. So for squamous cell esophageal cancer, the ESD is a first option, first tier option, whereas for Barrett's esophagus, endoscopic mucosal resection is a first option. For gastroesophageal junction lesions, it is not so well specified, but I will try to guide you through all this data. So with regard to the question how on endoscopic submucosal dissection for esophageal squamous cell cancer, I have prepared a video for you. So this is an extensive squamous cell cancer, but a superficial cancer of full circumference and standing over 11 centimeters. You can, without magnification, clearly see these B1 vessels, so loop formation, thick vessels. And what you do, you actually mark the lesion. With this kind of lesion, it's difficult to resect it otherwise than by using tunneling technique.
Oh, I'm sorry. I think there was a connection issue again. I do apologize. Hopefully it'll pop back soon in just a few moments, like it did before.
Fingers crossed.
Yes, yeah. Oh, it's okay. Hopefully that's a good sign.
So hopefully Michael will be back soon. It seems like he's having a little bit of an issue with the connection. He managed to come back pretty swiftly before, so hopefully will be the case. Hold on with us. He was showing us an interesting case of squamous dysplasia early cancer being treated with an endoscopic submucosal dissection. And he was showing us how to lift.
He's back in. Yeah.
The mucosa. Okay, great.
Sorry, Massi.
Oh, that's okay.
Okay.
Things, virtual meetings are all full of unpredictable events.
Yeah, I'm trying. Yeah, I'm sorry. I'm not sure when I got lost.
Yeah, so we were to the stage of the lifting of the mucosa prior to the.
Okay. Can you allow me? I need to share my screen. Okay, now I'm allowed. Okay. So I will try to move.
Oh. Oh, unfortunately, it happened again. I do apologize.
Do you think, could it be the video, Calvin?
Oh, okay. Yes, I think it's, yeah.
Bear with us. You will all be familiar with this kind of situations during virtual meetings. So
it does happen.
Yeah. A short wait. It was part of my comments for the conclusive remarks that everything went well technically, and I was pretty happy with everything, but obviously I cannot make this comment anymore. But I think so far everything went well, and I'm sure that Michael will be back soon and finish his talk.
I'm in here. Sorry.
Hi, Michael. So maybe we can go straight after the video. I'm not sure whether the video is making this issue.
Yeah, maybe. So can you see my screen right now?
Not yet.
Okay. So nevertheless, I will skip it and I will try to move forward. Sorry for that. I mean, there is something happening with Wi-Fi. So the bottom line with this kind of resection, so endoscopic submucosal dissection, is to. Am I online?
Yes, we are hearing you and seeing you, but we don't see your screen yet.
Okay. Sure. Okay. Is
There
it
you
okay?
are. Beautiful specimen.
Okay. Is it okay right now?
Yes.
That looks good.
Okay. So let's hope for the best. I will try also to share maybe Wi-Fi from my mobile, because just to have a backup. Okay. Nevertheless, so this is the specimen, and the bottom line with endoscopic submucosal dissection is to resect the entire lesion en bloc in order to provide really good specimen for histopathological evaluation. So what is the rationale for ESD for esophageal squamous cell cancer? And this meta-analysis published 6 years ago provides some evidence why ESD should be the first line option. So as you can see by this simple comparison of ESD and EMR, en bloc resection is achieved much more frequently with ESD, 97% as compared to 50%, and also curative resection is achieved much more frequently with ESD as compared with EMR. And this results also in significantly lower recurrence rates following ESD as compared to EMR. Therefore, there is no doubt that for
I'm so sorry. I think we just hit another snag.
Michael is having a hard time. I can
Yeah,
imagine it's not easy for him.
it does happen.
We are all very understanding, and I think he's the one that is suffering the most, I suppose, right now.
Uh,
I think it's not easy. So hopefully his 4G or maybe 5G will back him up.
yeah. I think he is logging back in, so he's logged up.
Yeah. So we'll give him some few extra minutes to complete his talk. Hopefully, we won't be too long until he's back and complete his talk. So hopefully he's soon back. So for squamous cell carcinoma, the bottom line is that ESD is the preferred technique because it ensures more radical resection, higher rate of curative resection, and lower rate of recurrence. So while Michael is back, I can just quickly say that CPD points will be available. We've got 6 points for attendance to this event. Because some of you might not be interested in the CPD points, instead of us delivering 200 plus certificates, if you can email then Joanna to request the CPD certificates, then we can email it to you back. The event has already been approved by the Royal College of Physicians, so we'll be in the position to give you the CPD certificate straight away. Just a reminder to everyone to use the pigeonhole .at for the questions. You can potentially also use the Zoom chat, but we would prefer to have the questions, if any, at the end of the talks on the pigeonhole. So far, it's been pretty good. We had quite good discussions after meetings in previous sessions. This time, Michael is obviously having some harder time to connect. So I suppose we'll give him another 30 seconds, but in case he doesn't manage to get back, I'm afraid we'll need to move to the next talk. So hopefully he can be back soon.
Nasi, maybe we could go to the next talk and Michael could come back again.
Yeah.
Later.
Yeah. Okay, so in the interest of time, I can see Lizzie. Welcome.
Hello.
Lizzie. Great to have you here. So Lizzie is consultant oncologist at Cambridge University Hospital. She's trained between New York and the Royal Marsden here in the country. So completed her training in some of the most prestigious oncological institutions worldwide, and we are extremely lucky and honored to have now her in Cambridge, where she's already been doing fantastic work, particularly in the research field, to help our patients with esophageal cancer. Lizzie, it's such a pleasure to have you here today. We're all looking forward to your talk on the innovations for oncological treatment of esophageal cancer. Thank you very much, Lizzie.
Thanks, Masi, for the very generous introduction. It's lovely to be with you here today, and thanks for inviting me to this meeting. I'm going, as you said, I am a medical oncologist, and I specialize in GI and colorectal cancer, actually. So, but this is all about esophageal cancer today. And if I can just get my presentation to load up. Can you see my screen?
Yes, looks good.
Okay, perfect. Thank you. Okay, so I'm glad that I was asked to give this talk now rather than earlier in the year, because we've just had a really tremendous ESMO meeting, which is the European Society of Medical Oncology, at which there have been some really important advances in the treatment of esophageal and gastric cancer, which have been will be practice changing for patients with advanced disease and in the adjuvant setting. So I'm going to discuss some of those today, and then also some work around novel targets and biomarkers. So these are my disclosures. And as I said, this is the agenda for today. So immunotherapy first, targeted therapy second, and then a little bit on biomarker development, including some work that's been done in the lab in Cambridge. So I think that most of the people at this meeting are not oncologists. So this is where we have been in terms of the treatment of esophageal cancer and gastric cancer, maybe prior to a year and a half ago. So for locally advanced cancers, our treatment for squamous would be chemoradiotherapy followed by surgery or not. For adenocarcinoma, either perioperative chemotherapy or trimodality therapy and surgery. First-line chemotherapy in the advanced setting, and that is most patients, because most patients present with advanced disease, was platinum and fluoropyrimidine, with trastuzumab for 20% of adenocarcinoma who were HER2 positive. And in the second-line setting, we had taxanes and irinotecan, which are, minimally effective, and then the addition of ramucirumab for patients in the second-line setting of adenocarcinoma. Unfortunately, that is not NHS funded, but it is available in other jurisdictions. So then before the ESMO meeting, which was in mid-September, we had some important developments over the past few years in immunotherapy. And so first of all, in squamous cancer, we have nivolumab, which is an anti-PD-1 inhibitor, was shown to be better than chemotherapy in the second-line setting. We had nivolumab again shown to be better than no treatment in the third-line setting for adenocarcinoma. And in the United States, but not in Europe, they have licensed in a tumor agnostic way, so across any tumor type, pembrolizumab, which is another PD-1 inhibitor in MSI high cancers or microsatellite unstable cancers. And I'll talk a little bit more about those MSI cancers towards the end of the presentation. So in terms of the benefits, what we've done in terms of squamous cancer to change the treatment landscape, there's a number of important trials. And so those were Keynote 181, Attraction 3 in the chemorefractory patients. In the first line setting, Keynote 590, and adjuvant post-trimodality is Checkmate 577. I'm going to touch on each of those in turn, very briefly, given the time constraints. So in the second line setting, in the Keynote 181 trial, patients were randomized to either chemotherapy or pembrolizumab, an anti-PD-1 antibody. The trial had three co-primary endpoints. In the first co-primary endpoint, which was in all patients, it was negative. Interestingly, because of a split alpha, it was also negative, although this looks positive, doesn't it, for patients with esophageal squamous cancer. And it was literally just because the alpha was very stringent because of co-primary endpoints, but it was widely positive for patients with high CPS scores. So we look at PD-L1, which is a biomarker associated with immune response and exhausted T cells. And if they have high levels of PD-L1, which is a CPS score of 10 or greater, then those patients were sensitive to pembrolizumab. And this was caused pembrolizumab to be licensed in the United States for patients with a CPS score of 10 who were squamous cancers. But this is why not adenocarcinoma. So the trial contained adenocarcinoma and squamous, but PD-L1 expression means something different in adenocarcinoma and squamous cancer. And you can see here that, although the response rate was equivalent in adenos and squamous who had high levels of PD-L1 score, the sustained benefit was only seen in squamous cancer. So it's important to interpret the PD-L1 score in the context of histology. A trial which was conducted purely in squamous cell cancer in the chemorefractory setting was Attraction 3, and this used nivolumab and compared it to chemotherapy. Now, this trial was conducted only in Asia, and as you can see, and this led to some certain challenges around the registration. In the earlier trials, you can see that the response rate to nivolumab in squamous patients is not bad. It's about 17%, which is what we'd expect from chemotherapy, optimistically in that setting. And what you see in the Attraction 3 trial, and this was not a biomarker selected population, which is interesting, was that there was about a 2.5 month benefit for patients treated with nivolumab. And so, but importantly, if you look at the table on the right there, you can see that patients treated with nivolumab have many fewer side effects than patients treated with chemotherapy. And so this is one of the real benefits of immune checkpoint blockade treatment, especially with anti-PD-1 monotherapy, which is very well tolerated. Now, I was at EMA last month arguing that these data should be interpreted as positive for European patients as well. And fantastic news, nivolumab was just licensed after that meeting for European patients with squamous cell cancer. So I hope that, the next step is a nice approval. So watch this space, although we are treating patients with this on an expanded access at the moment. This was the big news. So moving this into the first line setting, this was Keynote 590. So I think that it's established already that squamous cancers are slightly more immunogenic than esophageal cancers, and they tend to have a greater benefit from monotherapy. So can we move this into the first line setting, which will benefit more patients, because only 30–40% of patients get to second line therapy, unfortunately. So Keynote 590 was a global study. Now, this study enrolled, again, adenocarcinoma in squamous patients, which to medical oncologists, and I guess to people at this meeting, probably doesn't make sense because we realize that they're biologically different. And patients were randomized, treatment-naive, advanced cancer to either chemotherapy, cisplatin and 5FU, or the same plus pembrolizumab. Primary endpoint was overall survival and progression-free survival in various cohorts. Now, in this study, 3/4 of the patients were squamous cancer. Most of the results are in squamous cancer populations, but you see that it was very successful. So when we add the chemotherapy, the thing with immune checkpoint blockade is that responses tend to be slow to monotherapy. And we know that in these rapidly progressing cancers, what we really need is a little bit of a kickstart from cytotoxic chemotherapy to reduce the tumor burden and allow the immune checkpoint blockade time to work. And so the first group, and the most successful, was in patients with squamous cancer with high PD-L1 expression, so immunogenic tumors. And you can see that there was almost a doubling of overall survival, so from 8 months to almost 14 months. So this is a highly sensitive population. If you look at the squamous cancers with all comers, so regardless of PD-L1 status, you can see that there's a modest benefit. It's coming up to 3 months. The question for me with this is, because we know that there's a good proportion of patients in here, at least 50% who are high PD-L1 expressors, is that benefit only for them? And these are preliminary data. So I think that will, whether this is approved for an all-comers population or just the CPS high subgroup, remains to be seen. They also looked at adenocarcinoma and squamous cancer with high PD-L1 status, and that was a positive result for overall survival as well, a 4-month benefit. Again, they haven't given us the breakdown for squamous cancer and adenocarcinoma, and that's important based on what we saw from the monotherapy activity, where PD-L1 means something different in adenocarcinoma and squam. Then when we get to the all patient group, we can see that there is also a benefit, but it is much less. It is less than 3 months, and we generally want to see 3 months to improve, to change practice. And this is probably driven by the inclusion of the less sensitive adenocarcinoma group. So this is a practice-changing trial for squamous cancers, at least those with a high CPS score, and I expect to see regulatory approval for this. This is not powered for adenocarcinoma patients. There's only 200 adenocarcinoma patients in the trial, so we don't think it will change practice for them. I'll move on now to adenocarcinoma. And so just to say that over the past 3 years, we've had a lot of successes and failures. We had a positive chemorefractory study, Attraction 2, that showed that nivolumab was better than placebo in chemorefractory patients. But after that, we had lots and lots of negative trials. So we had negative second-line trials, and negative first-line trials, and negative maintenance trials. And what we learned is that when you don't compare immunotherapy to just placebo, that there's a real modest benefit for adenocarcinoma patients. The expression of PD-L1 is a moderate sensitizer. It will slightly improve response rates if it's present, but the higher the level, the better the response. And we know that MSI patients on high TMB or tumor mutation burden have good outcomes. And so into this, where we only had approval in the third line setting, we've got two really important trials. Skip that one. So this was Checkmate 649, which was just presented at ESMO. So this is the largest trial which has ever been conducted in gastric cancer. There were 2,000 patients enrolled on this study. And what was reported was the two arms, which were standard of care chemotherapy first line versus standard of care chemotherapy plus nivolumab. There was an arm with no chemotherapy and dual immunotherapy, and that has not yet been reported. That arm was closed early for toxicity, but it's possible there was still a benefit, so we'll wait to see what that shows. It was a global study, and it's worth noting that the chemotherapy was oxaliplatin-based rather than cisplatin-based, because we've had negative cisplatin studies before. This is the primary readout of the study. So the primary endpoints were overall survival in patients who express PD-L1 with a score of 5 or greater. So that's about 30 to 40% of the population, but it depends on the assay. And there's a lot of work, standardization work going on around these assays now. And what you can see here is that for patients who express PD-L1 with a CPS score of 5 or greater, who received nivolumab in the first line setting, there was a more than 3 month survival benefit. Survival was about 14 months, which is really good. I know it probably doesn't seem a lot to patients, to those who aren't oncologists, but actually breaking through the 1 year barrier for this patient group is really important. And as you can see, there's a tail on the curve. So there are long-term survivors. This is what we expect to see with immunotherapy. It also improved response rates from 45% to 60%. So you could expect a symptomatic improvement for those patients. So this is very likely to be licensed as a new standard of care, at least for this patient group. So PD-L1 CPS score 5 or greater. Other secondary endpoints of the study were to look at the same combination in those who were lower PD-L1 expressors and who didn't express PD-L1, all patients included. And it did show benefits in these groups, although they were incrementally less than in the immunogenic population, as you can see here. The question here is, again, as I brought up in the squamous study, is the benefit in these groups really driven by inclusion of sensitive tumors? So what we need to see is the outcome in patients who in those groups alone, and I'm sure that will come forward in the future. One of the last studies that was shown in the immunotherapy session at ESMO was Attraction 4. So this was almost the same study as Checkmate 649, except only done in Asia. And we're used to having Asian patients do better on chemotherapy than Western patients with gastric cancer. Again, treatment naive first-line patients were randomized to chemo plus or minus nivolumab. And what was shown in this study was that the patients had a really important improvement in progression-free survival, which was the same as Checkmate 649, but no benefit in terms of overall survival. And so the reason for this is because patients, two reasons. First of all, patients in Asia tend to get more second-line treatments, which will eat into the benefit from first-line treatment. So for example, most patients in Japan will get second, third, and even fourth-line treatment. And also, this is not a biomarker selected study. So whereas Checkmate 649 primary endpoint was in PD-L1 expressors, this was in an all-comer population. So this study won't be used to license nivolumab in Japan, but Checkmate 649 will, because it was a global study. So those are the practice-changing trials that have come through in the past 6 weeks for esophageal and gastric cancer. So we're going to see a lot of changes now. That was in the advanced disease setting. So this is where we were. Standard chemotherapy, first line, second line, nivolumab in the third line. This is where we are now with chemotherapy and pembrolizumab for esophageal cancer, chemotherapy and nivolumab for adenocarcinoma. And this is where we could be in the next couple of years, because what we're working on, and including studies that we've got open at Addenbrooke's and across the UK, our studies with in the perioperative setting. And as you can imagine, when we see these deepening of responses in the sensitive patient groups, we might expect to see more or zero resections and cures, in fact, hopefully, with this treatment. So in future, what we hope to see, I mean, I think we've had now the low-hanging fruit in terms of immune checkpoint blockade in identifying the immunogenic, the sensitive populations. We really need to focus on the immunologically cold tumors. We'll have dual checkpoint blockade, so the new antibodies coming through, bispecifics, LAG3. Also combining immune checkpoint blockade with other antibodies like trastuzumab. That looks very promising, and also combining it with small molecules. So those have very encouraging results, especially in early studies. So I think one study that probably the people in this meeting will be quite interested in is the adjuvant study. So we use chemoradiotherapy followed by surgery as one standard treatment for esophageal cancer, both adenos and squamous. And this was a global trial which looked at patients who both squamous and adenos, checkmate 577, and who had surgery and had residual disease in the resection specimen. So they were a poor prognosis group. And it randomized those patients to adjuvant nivolumab or placebo for a year. And so it was another practice-changing trial. The primary endpoint was disease-free survival or recurrence. And the recurrence rate in patients who didn't have treatment was very poor. So the median time to recurrence was 11 months. But giving nivolumab as an adjuvant therapy doubled that. So it improved from 11 to 22 months. So this is very likely to become a new standard in patients who've had chemoradiotherapy followed by surgery with residual disease in the resection specimen. There's some debate around whether squam versus adeno are more sensitive, and as you can see, in terms of the histology, there was a significantly bigger benefit in terms of the squamous cancers, but there's still a benefit for the adenocarcinoma patients. So the hazard ratio is bigger for squam, but it's still there for adenocarcinoma. This is not going to change our perioperative paradigm. I mean, I think if a patient was going to have perioperative chemo, that's still the right choice. But for patients who've had chemoradiotherapy, this is very likely to be an option in future, especially if they fall into that poor prognosis group. So a couple of minutes on new targets, moving on from immunotherapy, although the whole world seems to be immunotherapy at the moment. It's been 10 years since trastuzumab was licensed in HER2-positive cancers. And we've had a number of negative trials, and that's really because of the heterogeneity of biomarker expression in gastric cancer. But now we have a really promising new drug called trastuzumab deruxtecan. This is an ADC, which means it's an antibody drug conjugate. The antibody takes the drug to the cell, links to the outside, and then there's a chemotherapy payload that goes into the cell and kills it, essentially. And so this is a really potent ADC. And in an early trial in Japan, so they've taken HER2-positive gastric cancer, second-line setting, and randomized them to either chemo or TDXT. And the response rates were 50%, which is incredible. We expect response rates around 15% in second-line treatment. And survival was improved by about 4 months, and survival was actually almost a year in the second line setting, where we would expect 6 months. So this is a drug which we are using at Addenbrooke's in a clinical trial. We're one of the only sites in the UK, and I can say from personal experience that it is effective. So this is a Japanese study, and we will need to see the data from the other studies. But certainly, this will very likely become a new standard in future. One or two words on MSI. So we are now checking for MSI in all cancers, gastric cancers and esophageal cancer, adenocarcinoma. And there's two reasons for that. We know that in resectable gastric cancer, it's a mismatch repair is present in about 10% of tumors. And this gives the tumors a hypermutated phenotype, an active immune infiltrate, and an excellent prognosis. But it also has a role in prediction. And just to say, this is the reason why we are checking in resectable gastric cancers. Doesn't tend to be so much in esophageal cancers. We know
based on the MAGIC trial and the classic trial, and now meta-analysis, the patients with MSI gastric cancer who have surgery alone have an excellent prognosis. If these patients are treated with chemotherapy, it's at best has a null effect and is possibly detrimental. So for these patients who tend to be older patients, also with antral cancers, it's reasonable to discuss omitting perioperative chemotherapy. And that's a big debate in the oncology world at the moment, but certainly something that we have done for several patients this year. MSI is also predictive. So it predicts these tumors, which have high mutation burden, are extremely sensitive to immunotherapy. They can expect response rates of 50 to 60%. So we now have access to immune checkpoint blockade on the NHS first line because of COVID. And so this is one reason to check all your metastatic tumors for mismatch repair deficiency, because these patients can have a potentially life-saving treatment if they have access to immune checkpoint blockade. And last slide, this is also, I think, where we will go in terms of biomarkers in the next few years. This is work by Emma Ocox, who is one of the PhD students in Rebecca's lab in Cambridge, looking for ctDNA in patients post-resection is now a standard in the United States and some other countries for patients with colon cancer. And that's because we know that patients who are ctDNA positive after resection, who have minimal residual disease, are extremely likely to recur. And so stratified adjuvant treatment is one possibility for these for these patients. This hasn't been shown before in gastroesophageal cancer. And what Emma has done is analyze the Occam's data set using a commercially available ctDNA assay. And what she has shown is that patients who are ctDNA positive are about 5 times more likely to recur. Now, because this is a ctDNA assay that's commercially available, it wouldn't have picked up all the mutations that are present in esophageal cancer. So what the lab are doing at the moment is working with Natera on a personalized assay, which is 100% specific and sensitive in work we've done so far. So what we would like to do in the future is set up an adjuvant trial and treat patients with high-risk disease, perhaps with more targeted therapies or more intense treatment to reduce the risk of recurrence. So that's kind of more of the future. So that's the conclusions for innovations in oncological treatment. We're going to see massive changes in immunotherapy in the first-line setting for squamous cancers and adeno in the adjuvant setting, post-trimodality therapy. We're going to see new changes, new drugs in HER2-positive space, and we'll be using MSI and ctDNA as predictive and prognostic biomarkers. Thank you very much.
Thank you, Lizzie, so much. Tom Crosby and Rebecca Fitzgerald send you the compliments, and I can only do the same. So excellent talk. We did have some questions. So given the importance of the MSI in the management of particular gastric cancer, potentially also a subgroup of esophageal adenocarcinoma, how do you see this going implemented into clinical practice in order to inform treatment?
I think this is a really critical question, and it's something that we've been speaking about. I've been speaking about with oncologists because I know that the uptake of mismatch repair testing is different in different areas of the country. So I would advocate that it could be included in NICE guidelines. So in colorectal cancer, mismatch repair testing is recommended in NICE guidelines. And so it's done routinely in most hospitals and funded. So getting the funding from commissioners is critical in some trusts. So I would advocate that it's included in guidelines in order that there is not really a postcode lottery in the uptake of these really important treatments.
I'm sure you're doing your work on that. There was a question about other checkpoints like CTLA-4 or LAG-3. Is there anything coming on the horizon?
That's a really good question. So we know that when we use PD-1 and CTLA-4 together, that they do improve the response rate. They double the response rate. In the trial that with the design in Checkmate 649, it was Nivo and high dose IPI, and we know now that that is effective but toxic. However, in colon cancer, we have switched to Nivo and low dose IPI. It's much better tolerated, so trials in future might be able to use that. There is some evidence that LAG-3 also adds benefit, but it's early days for those trials. So yes, So yes, but those will come in future.
Just a curiosity, you mentioned that the CPS sometimes 5 was used as a cutoff and some other times 10. What is the reason for that? And how easy is to perform this test?
So this is a really critical question moving forward. One of the issues that I didn't bring up was that both different assays and different platforms have been used, and there is variability in the proportion of patients who have different CPS scores depending on the platform, and so there needs to be some work so that we're actually doing precision medicine in terms of these antibodies and selecting the right patients. In terms of CPS 5 versus 10, those companies were different companies and they used it based on previous trials that they had done.
Excellent. I think we'll, in the interest of time, we'll stop here. Thank you so much, Lizzie, for, again, a great presentation. And I think I can see the horizon much brighter. We'll try to go back to Michael and see whether he can complete his talk. I heard that you, Michael, went on speaking, and I'm so sorry. I know it's such a pain for a speaker to have this problem. So, so we were at the stage, yes, of the comparison between ESD and EMR. So please carry on with your talk, and fingers crossed everything will be okay.
So sorry for that. Another reason for preferring an on-site meetings as compared to virtual meetings. I'm sorry to you, Massi, and sorry to all the participants for that. Okay, I'll try to be as brief as possible to conclude this talk, but also to make my teaching points. So to explain why the rationale why ESD is a first-tier option for esophageal squamous cell cancer is being shown by this meta-analysis, which shows that both en bloc resection rates and curative resection rates are much higher with ESD as compared to EMR for squamous cell esophageal cancer. And what is to be expected that also the recurrence rates following that are much higher with EMR as compared to ESD, and all what this meta-analysis shows is that it favors ESD for esophageal squamous cell carcinoma. So how about Barrett's esophagus and high-grade dysplasia and early adenocarcinoma? Here, the endoscopic mucosal resection is a standard of treatment. You obviously mark the lesion, then you use, I will move it forward, then you use the ligation device to create pseudo polyps, and then here we have the pseudo polyp that was created. Then we use the snare and we place it underneath the rubber band in order to cut off the specimen. And the bottom line is that we don't want to have bridges, and we really, at the very end of the resection, we want to have this resection bed clear and without any bridges in between. But what it results in is that it results in several pieces after the resection, and it's much more difficult for histopathologists to assess the quality of resection and completeness of resection. But despite that, there is really good evidence that ligation is
Oh, I'm so sorry, Messi. I think we might have lost connection again.
Yeah.
Oh, okay.
Michael is back.
Gosh, it's terrible. Can you see my slides?
We can see you. We can't see the slides yet, but hopefully.
Okay. Okay, then I will share my slides again. I don't know why it is happening. I even tried to share my Wi-Fi from my mobile phone. Okay, is it good?
Yes.
Is it okay? Then it's fine. So the evidence is based mostly on this. On several studies but these are probably the most important ones. The one from Oliver Pech that I referred to beforehand, and this one with 1,000 patients with mucosal adenocarcinoma, shows at almost 5 years of follow-up complete remission in 94% of patients. And the other study, which is a very important one, though a very small one, is a randomized trial from the Horst Neuhaus group, 20 patients in the ESD group, 20 patients in the EMR group. It is certainly not adequate sample size, but what it shows is that there is no reason, there is no difference between incomplete remission of neoplasia in both arms. And in order to make a really change with ESD, we would need much larger sample size, and the difference in favor of ESD would be probably very, very small. But it requires much longer time, therefore, for ESD to complete instead of EMR. Therefore, really, ligation EMR for Barrett's adenocarcinoma is the first-line treatment. So how about gastroesophageal junction cancer? There is much less evidence for that. We are talking about gastroesophageal junction cancer without Barrett's esophagus. And we think that for this kind of lesion, endoscopic submucosal dissection should be the standard of care. And this is based on some preliminary data. This is the specimen from the endoscopic submucosal dissection. This is based on preliminary data from the two centers from Cambridge University and National Institute of Oncology, 40 patients with gastroesophageal junction neoplasia. In this small cohort, 1/3 was upgraded, had upgraded histopathology post-resection, almost 1/4 had undermining squamous epithelium. But the most important results are that despite the fact that the mean lesion size with the ESD group was significantly larger, en bloc resection and complete resection rate were significantly better with ESD as compared to EMR. For curative resection, there was no significant difference, but the sample size was really small. So we are going to proceed with this study and try to confirm these preliminary results. So two last things that I would like to touch on is complications after ESD and EMR, especially as compared to surgical treatment. So the first line shows us the comparison for complications with ESD as compared to esophagectomy. This is a retrospective study, but it clearly shows that periprocedural mortality is significantly lower with endoscopic resection as compared to esophagectomy. Even though the mortality rate is pretty low in this cohort, and also severe complications are much less frequent with ESD as compared to esophagectomy, and most of them were treated endoscopically because most of them were stenotic strictures dilated with endoscopy. And the complications are even less frequent with ligation EMR, and this also comes from a study from Oliver Peck with 1,000 patients. Major complications, only 1.5%, and some minor complications also accounting for around 1.5%. Therefore, we can do less harm to the patient with endoscopic treatment as compared to esophagectomy. And how about the long-term results, which are of interest for both us and our patients? So long-term results after ESD as compared to esophagectomy for squamous cell esophageal cancer, PT1A cancer, are pretty much similar. Have a look, overall 5-year survival are comparable between ESD group and esophagectomy group for squamous cell esophageal cancer, which should be a convincing result. And another study, which is also not a randomized trial, but with random matching between EMR and surgery and a median follow-up of more or less 4 years, shows that both overall survival and 5-year disease-free survival are comparable between EMR and surgery group for PT1A early esophageal Barrett's carcinoma. So it brings us to the summary that in order to resect, when to resect lesions in the esophagus, we need to have careful endoscopic assessment using Paris classification and also some advanced imaging technologies. Then the indications which are absolute for squamous cell cancer are M1, M2 cancers, and obviously precancerous lesions. Extended indications are M3 cancers and SM1 cancers, providing that all other risk factors are negative. And in this situation, because of increased risk of lymph node metastasis, we should consider adding chemoradiotherapy, which is becoming like a standard of treatment, as I mentioned. And for Barrett's adenocarcinoma and gastroesophageal junction adenocarcinoma, mucosal cancers for sure, and superficially invading cancers with all other negative factors could be considered also indications for endoscopic treatment, because it results in oncological safety and risk of lymph node metastasis of 0 to 2%. With regard to how to perform endoscopic resection, ESD for sure is a first-line treatment for squamous cell cancer and should probably be considered for gastroesophageal junction cancer, whereas for Barrett's adenocarcinoma, ligation MR is enough. What we know is that complications are significantly less frequent with ESD or EMR, so endoscopic resection techniques as compared to surgery, but long-term results of ESD and EMR are comparable with surgery. Thank you so much.
Thank you, Michael. I'm really glad that you managed to complete your talk. I felt really sorry for you, but excellent talk despite the technical challenges. One question which I wanted to ask you is the selection for patients for endoscopic treatment, in particular, the need of radiological staging. So if we have an early Barrett's associated neoplasia, like a nodule, Paris 2A or 2B, do we need to perform additional staging, EUS and CT scan?
So this is a very controversial and good question. So honestly speaking, in many centers, EUS is being done for this kind of lesions, but there is emerging evidence that EUS quite often overstages Barrett's cancer. So the lesions where actually T1 cancers are staged as T2 cancers. And this was shown in a couple of studies, and some of the studies from the Netherlands over the last 2 or 3 years. Therefore, I think that it's controversial according to the local expertise of the center to perform EUS or not. We are usually not doing EUS before these resections unless we suspect submucosal invasion. So when we see a bigger nodule or the lesion look a little bit nasty to us, then we think that performing EUS should be an option. And also with regard to the CT scan or PET-CT, we do PET-CT or CT scan only in case of before resection, only in case of confirmed cancer and suspicion of submucosally invasive cancer. If we think that we are dealing with an intramucosal cancer or precancerous lesion, then we do not perform CT scan or PET-CT beforehand.
So bottom line, expert endoscopic assessment and endoscopic resection are the best staging modalities because there is a risk of overcalling with the EUS. And what do you think is the reason for GOJ cancer being treated better with ESD compared to EMR, since it is the same type of disease? Somebody might argue than the Barrett's adenocarcinoma.
I think that there is several reasons. One is that I've shown it, and there is this subsquamous epithelium extension quite often in this gastroesophageal junction lesions. We've seen it in 1/4 of gastroesophageal junction lesions. And it's difficult to quantify this extension. Therefore, a much wider extension, I think, is better. And also assessment of this part of esophagus or the junction is even more challenging than assessment of regular barometer or esophagus. So I think that it makes it more difficult to just to simply assess the extent of the lesion.
Very good. I think in the interest of time, I would like to close your talk here, but thank you so much for being with us for a long day, Michael. We really and truly appreciate it. I'm sorry that there was some technical difficulties, but I really would like to thank Hartley for your presence at this meeting.
Thank you so much.
So it is time for the last talk. It is often a difficult field because obviously many patients with esophageal cancer present with dysphagia, difficult nutrition, and the nutritional aspect goes very much along with the oncological treatment. So I'm really glad to have Sam Grimes together with us. She's a senior dietitian, cancer-specific dietitian in our group, MDT group in Cambridge. And I really look forward to your presentation, Sam, on the nutrition of the nutritional aspects of these patients during the oncological treatment of esophageal cancer. Thank you very much, Sam, for being with us.
Thanks very much, Massey. I'll just share my screen now. Don't appear to be able to share my slides. Ongoing theme of problems here. Can you help, Calvin?
Sure. Is there an error message when you try to share the screen?
No, I'm pressing the share screen and it's nothing is happening.
Nothing is happening. Oh dear. Okay. Oh, let's see what we can do. Let's see.
See if your slides were emailed to Calvin.
Okay.
Yeah. What's possibly happening is that the share screen pop-up is appearing behind a window of some sort. It's being hidden somewhere. So yeah, so you might have something open that's covering it. Failing which, yes.
Try to minimize your window, Sam.
Yeah.
And meanwhile, if you could try to email perhaps your slides to Calvin.
Sure. Yeah.
That's a good yes, thank you, Professor Kaminsky. Let's change this. Yes, I've changed that such that multiple people can share. Oh, I do apologize. These things do happen. They do. Yeah. Yeah.
Don't worry.
I really cannot make the comment about everything running smoothly anymore, I'm afraid.
Yeah, I heard that earlier, Massey.
I was really looking forward to it, but I think it's you know, even in larger conferences, these things do happen, and I'm afraid it's
they really
one thing we have to cope with with the new reality.
Okay, I have just emailed it.
Brilliant. Okay.
Okay.
So
Sam, you will need to give us a prompt when you want to change.
Okay, sure.
All right. And
Have you got it?
yes, I do. And let me take care of that right now. And brilliant.
Okay. We're ready. Okay, so next slide. I haven't got any disclosures. And you can go to the following one. So you can hear me okay?
Yes.
Okay, great. So where do we start? So we're going to talk about the nutrition across the pathway for esophageal cancer patients. So firstly, we know that malnutrition and cachexia are associated with poor prognosis. Cachexia is multifactorial and difficult to reverse, particularly when there are metabolic derangements. And malnutrition also has really quite a negative effect on the patient's experience. It impairs their quality of life, decreases physical, emotional, and social well-being, and it also does increase their use of healthcare resources. The inactivity then they experience further contributes to their muscle wasting and further catabolism. And in particular, sarcopenia is associated with reduced function, impaired quality of life, and post-op complications, as well as toxicity to therapies. And sarcopenia is receiving more attention actually in sort of nutritional world over recent years with its regard to impact on outcomes. And this is more and more important as the average BMI of the adult population now is increasing. And obesity quite often can mask poor nutrition and poor lean tissue mass. Next slide, please. So we know esophageal cancers, gastric cancers are aggressive and have often poor outcomes. We know that about only 25% start on a curative pathway, and even of those, 60% often end up with metastatic disease. And we've heard also from Lizzie the focus on developing new therapies and better choices for treatments to improve survival. But preserving quality of life is also really important. So nutrition is an important factor in this regard. Often screening and assessment is overlooked, and in a lot of areas there is actually a lack of specialist advice, and there's also even now a lack of specialist dietetics working in some of these big centres. So nutrition therapy should be preferably offered to patients before they are severely malnourished. So we need to be treating people sooner when the goals of actually include maintaining or improving their nutritional state. Should be offered to patients who we know are likely to develop anorexia or GI side effects to treatments, and definitely in severely malnourished patients. Offering them or treating them with a more radical approach, particularly if they're on curative therapies, is very timely. So really the interventions need to be as timely as possible to have the greatest benefit. Next slide, please, Calvin. So where are the nutrition recommendations? So we can see that ESPEN have provided some guidance, and with regard to the efficacy of nutritional intervention, they recommend nutritional intervention to increase oral intake in cancer patients who are able to eat but are malnourished or at risk of malnutrition. So this would include looking at treating symptoms such as dysphagia or side effects to treatments if they've started, and offering oral nutritional supplements. But you'll see here the evidence is only moderate, and there's quite significant questions for research regarding the clinical outcome of dietary advice and oral nutritional support. Next slide, Calvin. So with relation to the modes of nutritional treatment and when to escalate, if the decision has been made to artificially feed patients, enteral nutrition is the mainstay and should be used in the first instance if there is access to the gut and the gut is working, and parenteral nutrition if that's not sufficient or feasible. And again, you'll see the evidence is moderate, and the research questions are really linked to the clinical outcomes with regards to enteral and parenteral nutrition or combinations of. Next slide, thanks, Calvin. So we look at other guidance. So this is more specific to esophagogastric cancers. And again, the suggestions are offering nutritional assessment, tailoring specialist dietetic support with people with OG cancers, offering interventions such as enteral or parenteral nutrition, particularly those going ahead for surgery, and in palliative settings, considering support from specialist cancer dietitians. So, you know, these have been created from lots of papers, but you'll see because the guidelines are not very convincing or prescriptive, there are sort of the recommendations and the questions for research really do highlight the lack of evidence. But we know that there is a huge role to play. Next slide, thanks. So what do we do as dietitians? Along the patient pathway, a lot of our first mainstay is about nutrition support. Most of our interventions will take the form of diet first, or oral nutritional, parenteral nutrition, and intensive nutritional care, particularly for those along treatment pathways that are radical in their approach. And we know that if patients are malnourished before surgery, any surgery, that will affect their outcomes. But the mainstay of our dietetic treatment, particularly in the early stages of the pathway, are about dysphagia management. And as Massi said at the beginning, a lot of patients present with dysphagia at varying different degrees. And it's important as a dietitian for us to really understand the limit of this dysphagia, because it impacts greatly on our dietetic intervention, but also the timing of our approaches. Patients may come with just one or two food items that they can't manage, but there will always be patients that describe an inability to swallow anything other than fluids. So as part of our assessment, not only are we trying to ascertain the level of dysphagia, but also the rate at which it is changing. Because we see patients, at Cambridge, we see patients right from the very beginning of their pathway. And quite often there are a number of further staging investigations that have to take place before treatment even starts. And that can be a good couple of weeks. And if somebody's dysphagia is changing very rapidly, you might need to change your approach and be a little bit more aggressive with relation to your advice and your intervention. So it's important to take all of those things into consideration. The other big part of our work, and this is more really associated perhaps down the route of treatment, is actually managing specific symptoms. This can be obviously of the tumour, but also side effects of the treatment. On chemotherapy and radiotherapy, things like mucositis, nausea, esophagitis, appetite loss, taste changes are all things that will impact on people's ability and desire to eat. Then there are a lot of dietary myths and that patients seem to follow in their effort to try and do something themselves for managing their cancer. A lot of these can sometimes increase further their risk of malnutrition. Many of them will avoid large food groups, for example, or be extremely restrictive, and can impact on them reaching their nutritional goals. The other part of our work is more associated with some of the medications, the supportive medications that patients are prescribed during their treatments, such as antiemetics, antidiarrheals, laxatives, and analgesics. And while we don't prescribe these and we don't modify the doses at all, but we talk to patients about if they're taking them and when they're taking them, because quite often the timing of these medications does significantly impact on their oral intake, particularly. And you'll be surprised at the number of patients that are prescribed lots of these medications and just try and manage without them. They just don't feel the need to take the anti-sickness because they're not being sick, but they're just constantly nauseous. And there are stories like that a lot of the time when we're reviewing our patients, and also the stigma attached to quite hefty painkillers and the thought that they're going to get addicted to them or have other side effects from them, but not taking these supportive medications quite often impacts greatly on their ability to take on nutrition. So the other part of our discussions in some patients are around enteral tube feeding. So there are lots of different feeding tubes that we can use, and we give it very careful consideration depending on the treatment that the patient is undergoing and if they're having surgery or even what surgery. So for example, with patients who are undergoing chemoradiation, we know that that's associated with increased toxicity. And it's really, really important that we carefully select these patients and undertake some advanced nutrition planning to make sure that they are able to complete their treatment without any of the unplanned admissions for failure to thrive. There are some instances where, for example, we might place NJ tubes at the beginning of the treatment, particularly if patients are of low BMI or struggling quite significantly before they embark on the treatment. Sometimes we might go along a route of a more longer term feeding tube, like a jejunostomy or a gastrostomy, if we know that patients are struggling from the outset. Although it must be noted that we wouldn't ordinarily suggest a gastrostomy tube for anybody having an esophagectomy, just because of the impact that has on the surgery and the mobilization of the stomach. Next slide, please. So in terms of our focusing a little bit more on our preoperative nutritional pathway, so at Cambridge, we're very fortunate in our dietetic, with our dietetic service, to be able to actually attend all of the consultant-led clinics. And this really does have a huge benefit because we're able to review these patients with the rest of the MDT, so with the consultants, with the specialist nurses, at the times that patients are coming in already for their treatment and reviews. So this helps particularly with our MDT working, joining up any issues. Quite often we find that patients may give us some information that perhaps they haven't shared with their consultant that might be quite important. So it's a really good opportunity for us to have a really effective consultation all round with patients when they attend at each cycle. And because of the because we're quite rural here and patients travel for quite a long distance, it really does help then with relation to avoiding multiple appointments when they have to travel a long way. So we're able to review patients at each chemotherapy cycle, and if patients are having radiotherapy combined with their chemotherapy, then we'll also see them weekly, certainly from week 3 onwards, when their side effects are more likely to be causing any nutritional problems. And we also have the opportunity to telephone patients in between those times as well. So then the next stage of support will happen at the prehabilitation clinic, which is relatively new in the last year or two. And this has been part of our enhanced recovery for patients undergoing esophagectomy. So this is a clinic run by the dietitian and a specialist nurse and a physiotherapy. And we usually run it about 4 weeks before patients come for their surgery. And it gives us an opportunity to do another assessment of their current intake. And this is important, particularly if people have had treatment in their local hospitals and not here. It also gives us an opportunity then to discuss the provision of nutrition in hospital, how their oral intake will progress after their surgery, and also the jejunostomy feeding that we operate for our esophagectomy patients. We'll talk about texture modification of their diet, because we limit them to a very soft or puree diet for a couple of weeks, and also we send patients home with overnight jejunostomy feeding. And it also gives us an opportunity to just start instilling some more longer term dietary changes that they'll need to follow after surgery. And as many of you will probably already know, lifestyle changes are always really difficult, but if we can start early and get patients to understand the dietary changes sooner than when they're well, before their operation, then they're more likely to be able to adapt and make plans to make those changes later on. We also need to talk to them about some of the difficulties associated with surgery, some of the eating problems that patients experience, which I'll go into a little bit later. And because we feed all of our patients with a jejunostomy and we send them home with jejunal feeding, we take this opportunity to arrange and sort out all of their pump training and all of their deliveries, which will just help for a speedier discharge and also contributes to our reducing our length of stay following the surgery. Next slide, please. So following esophagectomies, intensive nutrition support is really, really essential. This is when they are more likely to suffer eating problems and have a terrific weight loss if they're not supported from a nutritional point of view. Many patients experience some all of these, but a majority will experience at least a few of these problems, including appetite loss, satiety, taste changes, swallowing or food sensation of food sticking, conduit dysfunction, dumping, bowel habit changes, reflux, and more longer term with vitamin and mineral deficiencies. And that's why we've felt that it's been really quite essential to place feeding tubes at surgery, and also to send patients home with them whilst they are beginning to build up their oral intake after their operation. Next slide. So in Cambridge, our nutrition protocol follows this pathway, and this is part of our enhanced recovery pathway. So there is routine placement of feeding jejunostomies at theatre, and we start feeding the day after surgery. Generally speaking, oral intake commences at day 5 with fluids and progresses until about day 7 or 8, where they start puree or semi-solid foods. If bowels haven't opened by day 6, then we routinely commence laxatives, and around about day 7 or 8, we start planning their discharge home, aiming for home around about day 9 or 10, with a switch to an overnight feed rather than a 24-hour feed, so that we're supporting their movement and ADLs in preparation for going home and continuing to improve their oral intake. So at home, they then continue with puree or soft diet for 5 to 6 small meals a day, and progress to their soft diet after about 2 to 3 months. We continue their overnight feeding regimen from anything between 1 to 3 months, and that really does depend on what's happening in terms of treatment post-surgery. So some patients will go on to have adjuvant chemotherapy. And in that group of patients, quite often we may continue their feeds for a little bit longer until at least cycle 1 of that adjuvant chemotherapy, just to make sure that they are managing to eat and drink okay and not suffering too badly with side effects of their treatment. Next slide, please. So after we implemented our enhanced recovery protocol and routinely sending patients home with jejunostomy feeding, we did notice an improvement in that patients didn't lose quite so much weight at 3 months post-operatively. And you can see here that our median weight loss was about 7 kilograms, reduced nearly to half at 3 months with more supported nutritional intake. But what was quite important for us to understand, or for us to see, was the clinical significant weight loss. So that those patients with a weight loss of more than 10% reduced from 44% to 15%, which was really really useful to see. And actually, anecdotally, what we've found is that people have returned to their ADLs more quickly. They're approaching adjuvant chemotherapy in better shape as well. Next slide. So after surgery, we mentioned earlier about some of the common problems with the nutritional intake. And then later on, the nutritional problems or other problems associated with their surgery do continue, but they are slightly different. And these are some of the common GI late effects that we have been noticing in our upper GI surgical cohort. The most common problem tends to be bacterial overgrowth, but also pancreatic enzyme insufficiency, and to a lesser degree bile acid salt malabsorption, and dumping still is an issue, and in some patients lactose intolerance. We have picked up a few other problems such as celiac disease and inflammatory bowel disease. Some of the thought process behind this, in terms of the etiology, appears to be altered transit, blind bowel loop, or for Roux-en-Y for gastrectomies, enzyme asynchrony, as well as decreased stimulation of the pancreas, and also sometimes the chemotherapy and radiotherapy effects. Next slide, please. So currently we manage these late effects in our specialist nurse and dietetic clinic. And we use an algorithm that we have created with our gastroenterology and nursing colleagues. So we do take a very detailed diet and symptom history, and we use our algorithm. And so when we have identified pancreatic enzyme insufficiency, we would also make sure that we do a fecal elastase, and we might prescribe or ask the nurses to prescribe some pancreatic enzyme replacement therapy. Sorry, I'm in a With regards to bacterial overgrowth, we would send patients for a breath test and prescribe their antibiotics, and CCAT scans and bile acid sequestrants plus or minus a low-fat diet. Other tests that we would do, because sometimes these affect absorption, would be a micronutrient screen as well, and hematinics, and also celiac serology, thyroid, and fecal calprotectin. However, we are actually in the process of creating more robust MDT guidelines for managing some of these late effects, following the research that one of our surgical fellows undertook. So hopefully in the near future, we'll have even more robust guidance to help some of these patients. Next slide, please. So just to couple more slides. So this is more about our non-surgical patients. And we don't seem to provide the same amount of attention sometimes to some of these patients, particularly with nutrition. And we don't know really if survival outcomes are affected by nutrition. They might be. And are we a little bit more accepting of weight loss in the palliative care setting, even though we're treating our patients with all the different lines of therapies that are now being introduced? And next slide, Calvin, please. And this this panel is from a paper by Martin and demonstrates the impact of weight loss and survival. And you can, so this was studying a range of cancer sites and cancer stages, performance status, and each one of these were independent predictors of survival. But you can see here, the greater the weight loss and the lower the BMI, the scores change. And a score of 4 demonstrated a 4.3 month survival median. And for those that had grade 0, they had a 20.9 month survival median. So you can see here that the weight loss grades were independently predictive of survival in patients both of good and poor performance scores, and controlled for age, sex, and cancer diagnosis, and also their stage. So it is really important to consider, as there are more and more developments in treatment lines for patients now, and we need to make sure that we are addressing their nutrition throughout all of these potential therapies that might be open to them. So to summarize, last slide, please. We know that poor nutrition status has an impact on outcomes, quality of life, and treatment tolerance, but there isn't a huge amount of evidence. Malnutrition may develop at any time and usually is progressive if unchecked. There really does need to be more good quality research. And throughout the disease trajectory, screening for and the assessment of malnutrition is really highly recommended in cancer patients, and appropriate nutrition intervention. And maybe we just need to look a little bit more closely at the nutritional management and earlier intervention of nutrition for our non-curative patients, combining this obviously actually with physical therapy as well. So that concludes my presentation. Thank you very much for your attention.
Thank you so much, Sam, for such a comprehensive overview of the nutritional aspects in the esophageal cancer journey. There were quite a few comments on the importance of the nutrition and the synergy that needs to be established between dietitians and physicians treating cancer. So, for example, Tom Crosby just commented how easy it is to ensure that patients have access to nutritional aspects during their journey. What are the suggestions that you would recommend to make sure that this happens in clinical practice?
So I think nutrition screening is definitely one thing that you can implement without the, so if you don't have a dietitian in your clinics, definitely implementing some form of nutritional screening will help identify those at risk. And then you will be able to, on the basis of that, refer to the dietetics departments within your hospitals or regions. That would be the first port of call I would suggest.
Do you have any rule of thumb for patients presenting with de novo cancer about how actually to select patients, for example, for a nasogastric or nasojejunal feeding? What are the sort of elements that should guide us to understand sort of those that are going to benefit the most?
It's quite difficult to sort of just limit that to one or two different things as to whether you would plan a feeding tube for a patient on the first presentation. I think the things that you would definitely need to look at would be the weight loss and the percentage weight loss over what period of time. So 5 to 10% weight loss in 3 months would be pretty significant. And also at presentation, understanding their dysphagia, the level of dysphagia, and how quickly it's changing. Because I think those are the two main things that certainly are things that we would pick up and try and hone in on more, particularly at the beginning of a pathway when we know that we've got a few weeks before treatment starts. So if someone's presenting with quite severe dysphagia, or even dysphagia where they're managing soft foods but it's getting more difficult and it's changing very quickly, those are the patients I would be highlighting quite urgently as potentially needing some more intervention. If you're able to do that and you have a bit more time on your side, if patients do need a feeding tube, you've then got your staging investigations to actually place a feeding tube. So, for example, we see patients in the surgical clinic right at the very beginning of their pathway when they are being assessed by the surgeons as to whether they might be a potential surgical candidate, but they need to have a staging lap, for example. We're present in that clinic and able to assess patients, and if we feel that actually we're approaching the requirement of a feeding tube, then the surgeons have an option then to place the feeding tube at staging laparoscopy, which we've done several times here, which has been quite useful.
And finally, there was a comment from Akat about the feeding jejunostomy. So just to clarify, we place feeding jejunostomy on all patients undergoing an oesophageectomy. Is it correct?
Yes, all esophagectomies.
And we keep it for 1 to 3 months. Has there been any occurrence of patients actually needing the feeding jejunostomy for a longer period? And how long can we keep it safely?
So, yeah, occasionally some patients require them for a bit longer. So you remember I said those that are undergoing adjuvant chemotherapy, sometimes we generally would advise patients, even if they are weaning down their feeds almost at the point of not requiring it anymore, we would always suggest that they keep them in for at least cycle 1 of adjuvant chemotherapy, just to make sure that they don't have a really rough time with their chemo. There are some patients that then do go on to have a really difficult time and rely quite heavily on their feeding jejunostomy for the duration of that time. So that would elongate their feeding time for maybe nearly up to 3 or 4 months.
Excellent. I don't think there are other questions. So thank you so much, Sam, for your talk. We've reached the end of our symposium. I think it's been overall an excellent day. I learned a lot, and I hope all the attendees on the line have learned as much as I did. We did have some technical issues, but I think we can cope with them, and we are happy that everything and all the messages and all the talks were delivered in good time. It is 4:10, so I don't want to keep people for too long, but I just want to thank once again Calvin for its technical support, Joanna for organizing such a wonderful day, Nastasia for the support during the practical development of this and for the scientific content. And obviously I want to thank all the speakers for their time. Some of them have given more than one talk and stayed with us for so long, participating to the discussions with the questions. And obviously I want to thank all of you for attending and for making this day a successful day. We are planning to do the 10th edition of the Upper GI Cambridge Symposium. We don't have a date yet, but all of you will be informed about the date and the draft program. It is going to likely happen in springtime and most likely to have some live endoscopy events. So I'm really looking forward to the next Upper GI Symposium. So all of you have a great weekend, stay safe, and I hope to see you, many of you, at soon meetings or virtual events. Thank you so much, and I look forward to the next occasion to share with you scientific and educational content. Goodbye, everyone.
Goodbye.
Bye.
So we also had animals attending the meetings. I know we had people from different continents. I didn't think that animals could have been interested, but you know.